Mic test. Good morning, everyone. We'll start in about 5 minutes. Thank you. Good morning, everyone. So let's all settle down. We will about to begin. I am Dr. Paul Martin M. Garcia, today your host for our conference today. Good morning, ladies and gentlemen, colleagues and friends. In celebration of the Philippine Heart Center's 50th anniversary, the Department of Surgery and Anesthesia presents the ASEAN Coronary Surgery Masterclass. To start our day, may we call on Dr. Maria Chaser Centina Golong for a short prayer for our start.
Good morning. Let us all stand up and let us put ourselves in the presence of the Lord. In the name of the Father, of the Son, of the Holy Spirit. Amen. Dear God, we ask for your guidance as we are gathered here today for this esteemed ASEAN Coronary Surgery Masterclass. Let us take a moment to pause and reflect on the profound journey that brings us together. We acknowledge the dedication and hard work that each of us has invested in our pursuit of excellence in the field of cardiovascular surgery. We ask for guidance and wisdom as we share our knowledge, experiences, and insights. May our discussions be filled with collaboration and respect, fostering an environment where learning flourishes. Let us remain open-minded, embracing innovative ideas and diverse perspectives that enhance our practice and ultimately benefit our patients. We also honor the patients who place their trust in us. May we be reminded of our responsibility to provide compassionate care and to strive for the highest standards in our profession. May our hands be steady, our minds be sharp, and our hearts be filled with empathy. May this masterclass strengthen our bonds as colleagues and friends, guiding us toward a future where we can make a meaningful impact in the lives of those who we serve. With gratitude and purpose, we begin this masterclass ready to learn, share, and grow together. This we ask through your Son, Jesus Christ. Amen. In the name of the Father, of the Son, and the Holy Spirit.
Okay, let us remain standing for the national anthem of the Philippines. Mga kababayan sa ng Pilipinas. Thank you. We may all take a seat. So to formally begin our day, to formally welcome us all, may we call on Dr. Christopher C. Cheng, our department manager of the Department of Surgery and Anesthesia. Let us give him a warm round of applause.
Thank you, Dr. Garcia. Good morning, everyone here. It's my great pleasure to welcome you all here to the ASEAN Coronary Surgery Masterclass. We're here to bring together leading minds in coronary surgery. So whether you are here to share your experience or to engage in stimulating discussions or learn from each other from collective expertise in the room, we are very, very thrilled to have you here. The event provides a unique opportunity to bridge ideas, foster collaboration, and push the boundaries of our collective understanding about coronary surgery. Today, we are very, very fortunate to have esteemed speakers and participants from around the world, and I'm confident the discussions, the presentations, and networking that we'll be creating here will be both intellectually enriching and inspiring. Also, I'd like to extend my gratitude to all the organizers, the sponsors, and volunteers who made this event possible. Without their hard work and dedication, would not have been here today. And we are looking forward to a productive, very productive, insightful, and enjoyable meeting. And I encourage you all to take full advantage of the opportunity to connect with the fellow attendees here, share your perspectives, and engage in the dynamic conversations. Once again, welcome, and let's make this masterclass a memorable and impactful experience for us all. Thank you very much.
Okay, so the next part of our program will be the introduction to the first Avenilo P. Aventura Honorary Lecture. So to tell us all about who Dr. Avenilo P. Aventura is, let us all welcome Dr. Dennis De Asis.
Good morning, everyone. So, who is Dr. Avenilo P. Aventura Sr.? His accomplishments and contribution to cardiac surgery in the Philippines is so immeasurable that trying to say it in a few words or in a very short time is probably futile as seen in this 14-page resume. Dr. Avenilo P. Aventura originally came from the province of Pasig, Iloilo City, after which he moved to Manila to complete his medical education at the University of Santo Tomas. He left the country for further training and had his general residency training at Elmsware, New York, and had his fellowship under the tutelage of Dr. Charles Bailey at St. Michael's Hospital in New Jersey, at St. Barnabas and St. Anthony Hospital in New York. After which he moved to Walter Reed Army Medical Center in Washington, D.C. for further training. His quest for continuing education and improvement and his thirst for knowledge is reflected on the numerous research papers he has authored and co-authored, over 100 in this resume, and some book chapters in cardiac surgery that he has contributed. After completing his training in the United States, he went back to the Philippines, and the then President Ferdinand Marcos and the First Lady saw his potential and identified him to spearhead the establishment of this institution, making him the very first medical executive director of Philippine Heart Center. Dr. Aventura Sr. also performed many pioneering operations in the Philippines, including the first successful renal transplantation in 1970, the first televised open heart surgery at the V. Luna Hospital on February 14, 1972, even before the inception of Philippine Heart Center, the first coronary artery bypass graft surgery on April 14, 1975, developed and implanted the first ASEAN bioprosthetic, the Philippine Heart Center porcine heart valve. And because of all his contributions, he was given several awards. Worth mentioning are the Plaque of Recognition for Selfless and Dedicated Services to the Armed Forces of the Philippines and the Presidential Award from UST Medical Alumni for International Recognition. It is then befitting that with all the contributions he has given to our institution, to cardiac surgery in the country, that we name this honorary lecture after him. And who else is best to deliver this honorary lecture other than the person who bears his name, the heir to the throne, Dr. Avenilo P. Aventura Jr., who will be formally introduced by our department chair, Dr. Christopher Chen.
Again, good morning. Now I got this privilege to introduce the first Dr. P. Aventura, Senior, honorary speaker, who happens to carry the same name with a junior tagging behind the name. So I shared the same medical school with Dr. Aventura Jr. or June as how his contemporaries addresses him. I was a senior for a few years in this University of Santo Tomas. After his medical school, he went further to finish his general surgery residency and fellowship in general surgery residency at UST Hospital and the fellowship in thoracic and cardiovascular surgery here at the Philippine Heart Center. He finished it in 2002. And after that, he proceeded with his further cardiothoracic surgery training in the University of California in San Diego in the Rady Children's Hospital from 2006 to 2008. And then he came back to the Philippines. And then when he came back, he started creating waves. He performed several first in the country procedures. Some of these examples are just like the first successful ECMO survival, first hybrid coronary revascularization, first double parts sandwich technique for a post MI VSR, and many, many more. He's currently the executive director of the Philippine Heart Center, and prior to that, he was the chief of ischemic or coronary surgery in the department. So he is also the chairman of the Cardiovascular Council of the Philippine Heart Association. Dr. Jun Aventura is a member of many reputable international medical societies such as the American College of Surgeons, International Society of Minimally Invasive Cardiac Surgery, International Coronary Congress, International Society for Heart and Lung Transplantation, and many more. His expertise and passions, aside from his usual cardiac surgery, are the following: off-pump coronary bypass surgery, minimally invasive cardiac surgery, ECMO, and heart failure, heart transplant surgery. He has been a regular speaker in many local and as well as international fora and has generated numerous scientific studies which were presented locally and internationally and published in journals. Ladies and gentlemen, let me have this pleasure to present to you the first Dr. Avenilo P. Aventura, honorary speaker. He is our executive director. He's an excellent cardiovascular surgeon, a conscientious clinician, a reliable colleague, and a friend. Dr. Avenilo Aventura Jr., or we call him fondly call him as June. June Aventura.
Thank you very much, Chris, for that very very nice introduction. And thank you to our colleagues for gracing this occasion. Yeah, you've seen some snippets of the history of cardiac surgery and coronary surgery in the Philippine Heart Center. So basically, I'm here to add a little more, maybe, of because I had first-hand experience from being the son. So I was born 19. Forget that. No, but 1975, when the Philippine Heart Center started, I was a little kid running around the place, just going around. We were doing, we were playing violin. All my siblings and me, my sisters, we were playing for the doctors as entertainment. Can't see it. So that was what we were doing before, because that's the way my mom wanted us to do stuff, just for entertainment. And lo and behold,
I kind of wanted to be like my father, and then went into med school, and then tried to sort of like be like him. Wait. No, for that. Okay. So I'm here to talk about coronary surgery in the Philippines, beginnings of the heart surgery. Looking back at the history of aortic coronary bypass and how it paved the way towards cardiac health in the Philippines. So an introduction, 1975, the Heart Center started, and it was a pioneering for Filipino surgeons and cardiologists to establish a specialized heart center, training local doctors and advances procedures like CABG. So over time, it actually major hospitals across the country became equipped for life-saving heart surgeries. No, this is a picture of the inauguration of the heart center. Here's on the left side, Dr. Ventura, President Marcos, sadly in the middle, in front, and his wife Imelda. Beside him is Dr. Charles Bailey, and after that is Dr. Denton Cooley and his wife. So these were good times, and we started the heart center. So how did what's the road to the first aortic coronary bypass surgery? So actually, this started back in a military hospital just a stone's throw away from here, maybe a couple of streets down. It's a military hospital called V. Luna Hospital. He had other surgeons like Teodoro Dino, Fronte Tomacruz, Eduardo de Guzman, and Captain Arnold Guspa to help him. He started performing successful closed heart surgeries at the V. Luna and complex heart and lung surgeries at the UST Hospital. The UST Hospital is the oldest university in Asia. That's where we and Dr. Cheng graduated from. Since the Spanish came, they've been here and have been here ever since. So this is where it started. After USD, he went to Danbury Hospital in Connecticut, and then to New York for training. He said he wanted to be an OB surgeon, but actually because he saw OBs were like had these fancy cars and all of that, and then somebody came over, which was Dr. Charles Bailey, and said, "Why don't you go into cardiac surgery? This is something new." And it was he was there 1959, 1960 or something like that. And then it was like an eye opener. Yeah, why don't I just go there? And so he trained under him in St. Barnabas and New Jersey and in New York. But he actually went to Elmhurst Elmhurst Hospital in New York first, which now I think is part of New York University. And this is his car. He said he had several Filipino friends there, and he had a car, but this car just went forward. If you had to go back, they had to push it. So that's him thinking about or looking at his car. So this is Dr. Charles Bailey. Dr. Charles Bailey is a time, he was in a cover of Time magazine before. He did the first mitral commissurotomy and so many other pioneering surgeries. And one of which is revascularization of the posterior diaphragmatic portion of the heart. He did it, I think that was off pump. But here you can see that Dr. Ventura, during that time, he was part of this paper. They were actually the ones who did the surgery. And it was pretty good because of the fact that they did it during the time of, I think it was 1966 or 1965 or something like that. And this is the first one to do posterior myocardial revascularization. This is Dr. Charles Bailey with the family, all my sisters and me on the right. So 1972, it was not 1975, it was 1972 that the first bypass surgery was done in the Philippines at V. Luna Hospital. on Captain Manuel Tabas of Morong, Nueva Vizcaya. And aortocoronary bypass, saphenous vein to the LAD was done. And after 3 days, Captain Tabas could walk around. And then somehow the first couple got wind of what he was doing and all of this stuff. Dr. De Asis was talking about the first renal transplant and all of that. Actually, the first renal transplant was it's this actually if you think about it, it's called maybe the second, but actually it's the first successful one. It's from a live donor. So when he did it, he was doing it in dogs. And Dr. Domingo Antonio was the chief of cardiac surgery surgery in the USD hospital. Found out about it, and then he said because Dr. Antonio is a urologist, so he did he saw what he was doing, and he said, "Why don't we do it in human and we could do it already." So they did it, and these are stuff that he was telling me. I did everything, and he just anastomosed the ureter. So, but that time, it was the team from the UST hospital. Now, the first couple actually wanted to start a program or a foundation to help full cardiac patients. They were trying to look at who were actually able to do because this was like groundbreaking during that time because nobody or it was quite new during that time, and he came in at the right time, and they established the Heart Foundation of the Philippines. The Heart Foundation actually was the one who actually gave funding for all of these patients. So they asked him to do the first televised open heart surgery in 1972. I think they did the open mitral commissurotomy. And the day after surgery, this is what he was telling me also, that the day after he wanted to have this patient walk. So he did. And then the first couple heard about it. And then President Marcos said to Imelda, he said, they're having the patient walk around. Could you go to Viluna and see what's happening, if it's true or not? And she did. And then she found out that the patient was walking, and she said, Dr. Aventura, you're going to get your heart center. So, groundbreaking. Many cardiologists and Dr. Aventura went to the US and Europe and took a look at all these hospitals during that time. And that's why if you take a look at our ICU, there's it's like a petal, and inside, and you can see the nursing station or the station is in the middle, and all the rest are around, so that it's easy to take a look at. So that's what they found out in different hospitals in the US and Europe then. So Philippine Heart Center was inaugurated in 1975, February 14, the Day of Hearts. And Dr. Aventura Sr. was named the Philippine Heart Center Executive Director. They did the first patient, PDA ligation. And then coronaries, we had so many international guests and alike. Like my boss in the US, Dr. Stuart Jameson. I don't know if you know Dr. Jameson. He was saying, because he was introducing me as stuff, where you come from? Oh, I'm from the Philippines. Then, where's that? And he said, if you haven't been invited to the Philippines, you haven't been anywhere at all. So he had so many friends, especially people from Cleveland Clinic. Dr. Floyd Luke was at the house during when I was quite small. You see me on the middle with in my dad's lap. They gave a plaque, which is inside our our hospital, near the pulmonary area, near the elevators. And Dr. Hostra Peterson, you know him from Cleveland Clinic. He came over and he was surprised that there's a plaque given to the Filipinos for the Heart Center. It says, in recognition of the efforts of Imelda Romualdez Marcos, First Lady of the Philippines, and the staff of the Philippine Heart Center to enhance the health of the peoples of Asia. So he was quite surprised and brought it the picture and had the picture taken there. This was a couple of years ago. So first coronary bypass Philippine Heart Center was done in 1972. In 1975, because this is the first one done at the Philippine Heart Center. So Shoemaker in Cubao, and took 7 hours. But I think some of the most were a little longer. Maybe I think what I hear is 13 hours for a bypass surgery during that time, because it was quite difficult during that time. So first years of the Heart Center, we were doing a lot of coronary surgeries, and it started out with 4 operating rooms. I think you've seen the operating rooms before. Started with 4, and then now it's actually 10 operating rooms. We started with the IMA grafting in the 1980s with the retrograde cardioplegia administration, then OPCAB in the 90s. And then we had a hybrid in 2013. Then we had the Z-benefit package in 2013, and hybrid cabbage 2016, and coronary flow meter in 2017. So from 150 beds initially, now it's 570 beds. This is more purely cardiac institution. Our mandate says we should be able to do cardiovascular to help in the cardiovascular disease of Filipino patients. So we had the SPD, or special packages, in 1992. And in 2000s, we started doing our multi-arterial graftings, and Z-benefit 2013. Okay. PCI, how are we doing with the PCI? Initially, we started with 1 cath lab, and then 3, 4. Now we have 6 cath labs in the Heart Center. Dr. Manuel Chuachaco is our previous director back in 2010 to 2016, and he spearheaded the hybrid procedure and the Z-benefit package, because the Z-benefit package actually improved the numbers that we were doing. We were on a plateau, but when we had the Z-benefit package, where in the government actually pays for these cabbages that we can do, that is standard risk, it went up again. So this is our Z-benefit package, which is still we still use presently. And then Dr. Romel Carino, he was chief of surgery during 2018 to 2020, but he succumbed already back in 2021, right? 2021. He is an instrumental figure as well, because he was instrumental in training our fellows and the rest of the staff for cardiac surgery, especially coronary surgery. These are one of the, both him and Dr. Chuachaco are one of the surgeons who are very high volume as well. So the PhD training program, which started back in 1975, has all encompasses adult cardiology, pediatric cardiology, cardiovascular surgery, anesthesiology, cardiovascular radiology, cardiovascular pathology, cardiovascular nuclear medicine, pulmonary physiology, therapy, and nephrology. So all of these are, we have training in the Heart Center. And now for cardiac surgery, one of our doctors who came, who actually was one of the first 4 cardiac surgeons, fellows here, whose son is also a cardiac surgeon, Dr. Garcia here. So his father was or Florimon Garcia was one of the four pioneering cardiac surgeons before. He was talking about how Dr. Aventura went to Baguio, one of the cities in the north, and saying, if you wanna be a heart surgeon, oh, you better apply to Dr. Aventura in the Heart Center because we're starting a new heart center in the Philippines. I said, who is Dr. Aventura? Oh, that's me. He said. So these four cardiac surgeons were all named Florimon, Florante, Florencio, and Florante again. Yeah, four. I mean, it must be something that to think about why Dr. Aventura Sr. would recruit four floors. So maybe it's because of the flowers of the heart, our logo for heart. So I don't know. Yeah, so this is our cabbage outputs from 1975 to I think it's close to 1,200. And then PCIs here, our cabbage ratio. And now we started off from just Manila. Now we have 18 regions in the Philippines. We have a center for almost 15 out of the 18 regions, some of which are here, like CDO. We have SPMC in Davao. We have Cebu. We have Marawi. We have Zamboanga. Lasifara, no? Cotabato. Oh, Bicol. A lot are actually here. And these are the ones that we have trained. And these are the ones who actually we want to have the Filipinos have access to the cardiovascular work that we do. So these graduates have produced hundreds of cardiovascular personnel and allied medical specialists and are now spread all over the country. The goal is to reduce the gap between urban and remote hospitals. So, is the future bright? Well, we're trying. As I became executive director June of last year, I'm trying to build what we can to make Heart Center relevant again, because this was not Philippine Heart Center before. It was called Philippine Heart Center for Asia. And for a reason, maybe it's because they wanted not only for the Philippines, but for everyone in Asia during that time. But of course, we plateau and we get set in our ways. So basically, we have to really innovate and try to be as what we can be. All right. So we plan to more or less go into more minimally invasive approaches. We plan to acquire a robotic system, do more coronaries that are more innovative, and increase the number of increase our structural capability. Our former First Lady, Imelda Romualdez Marcos, this is a plaque in front of the Heart Center. When you come in, I don't know if you noticed that in the this morning, but it says, be there, but one Filipino sick and uncared for, our mission is not done. 50 years after. This is our logo for the 50th year. And we've had a lot of, we did a lot of, new happy things and all our celebrations. And you are actually part of that. Part of the, one of our, sort of like a legacy lecture, legacy symposium. This was our anniversary gala last few weeks ago, graced by the former First Lady, with my father on the right side, and my family, and some of our staff here. So thank you very much. And Philippine Heart Center plans to expand its capacity and initiate is establish a center as a leading cardiovascular institution in the region. Thank you very much.
Thank you, Dr. Aventura. May we ask Dr. Aventura to stay on stage? And also, I am inviting Dr. Cheng, Dr. De Asis, and Dr. Yam to present the certificate of recognition. Dito. Dito, sir. Yes, sir. Yes, sir. So the certificate of recognition um, is awarded to Dr. Avenilo L. Aventura Jr. in recognition of his invaluable contribution as speaker and resource person during the ASEAN Coronary Surgery Masterclass of the Department of Surgery and Anesthesia of the Philippine Heart Center, given this 8th day of March 2025 at the amphitheater of the Philippine Heart Center. Thank you, Dr. Aventura. Also, we will be giving a sash and medal to Dr. Aventura. And also presenting a mini sculpture of the puso, which means heart. This is a miniature version of the sculpture that we saw earlier this morning in front of the Medical Arts Building. So again, a warm round of applause for Dr. Aventura. Okay, so on with our short history on how the Heart Center began. So today, let's start with the innovation. So to give a little course overview of what we will be talking about today, let us all welcome Dr. John Andrew M. Yam.
Hi, good morning, everyone. Thank you for joining us today. So 50 years ago, the world came to celebrate the opening of the Philippine Heart Center for Asia. Today, we want to bring the Heart Center to the world as we are streaming live on YouTube. To celebrate with us, we have world-renowned experts, rock stars in the field of coronary surgery to discuss the finer points of cardiac surgery. We will be touching on off-pump bypass, minimally invasive robotic cabbage, conduit selection, pre-op optimization, and surgical training. Tomorrow, we will be discussing clinical scenarios that are often tricky to manage. I hope that after this meeting, everyone will go home as a better cardiac surgeon. Thank you to everyone who made this possible. Our foreign guests, Dr. Aventura, Dr. Cheng, Dr. De Asis, our industry partners, and our untiring admin staff, Lods and Ses. Good morning to everyone.
Thank you, Dr. Yam. So our first session for today will be all about hybrid coronary revascularization, indications and outcomes, OPCAB current trends and practice, and stentectomy by Dr. John D. Puskas. Unfortunately, Dr. Puskas would be able to be with us today due to a previous engagement. So a little background on Dr. John D. Puskas. Actually, his CV is 80 pages long. But this is a little overview. So he graduated summa cum laude in biology in Princeton University, MD at Harvard Medical School in 1986, Master of Science in Surgical Science in University of Toronto in 1991, General Surgery Internship and Residency in Mass Gen Hospital, Harvard Medical School, Cardiothoracic Surgery Residency and Fellowship, Emory University in 1996. Currently, he's the Chief of Cardiothoracic Surgery in Emory University Hospital, Midtown, Director of the Carlisle Fraser Heart Center, Emory University, Director, Coronary Vascularization Reference Center and Cardiovascular Clinical Research Unit, Mount Sinai Health System, founder and co-director of the International Coronary Congress, which we are fond of attending, and also the founder of the International Society of Coronary Artery Surgery. So we will hear Dr. Puskas through our recorded lecture today.
My name is Dr. John Puskas. I'm professor of cardiothoracic surgery at Emory University in Atlanta, and I'm delighted to participate, even if only remotely, in this celebration of the Philippine Heart Center. This lecture is entitled The Rationale for Hybrid Coronary Revascularization. These are my disclosures. Specifically, I've been national PI of multiple NIH-funded trials related to hybrid coronary revascularization, and I consult with and receive royalties from various companies involved in coronary surgery. Now, hybrid coronary revascularization is the planned combination of surgical and percutaneous techniques in two different coronary territories, both scheduled and performed within a predefined time period in a single patient with multi-vessel coronary artery disease. I'm going to show you two case presentations. The first is this patient with two-vessel coronary artery disease, including the proximal LAD, who is a Jehovah's Witness, which means he refuses any blood transfusion and has multiple other comorbidities along with his unstable angina. This is the preoperative coronary angiogram documenting ostial LAD stenosis. You can see it here in this coronal view, and a type A lesions in the mid-right coronary artery. The operating room setup is standardized. The robot is brought up to the table where the patient is anesthetized, and the console is somewhat removed geographically from the table in the corner of the room. We dock the robot after inserting trocars in the second, fourth, and sixth intercostal spaces, and then sit at the console, manipulating the robotic limbs remotely, of course. The robot provides high-definition visualization, motion scaling, and zoom features, which are quite advantageous. We harvest the pedicled IMA exactly as we would do through an open procedure. Once the memory is harvested, we give heparin and clip it distally and then divide it, leaving it tethered to a pericardiotomy on the anterior pericardium, through which we will later approach the LAD. Skeletonized IMA harvest is accomplished similarly, but in a skeletonized fashion that utilizes sharp and blunt dissection, as well as monopolar and bipolar cautery and multiple small clips to achieve an atraumatic harvest of a skeletonized vessel. Either works very well. Once the mammary artery is harvested, we undock the robot and then use the camera to identify the optimal site for about a 4-centimeter skin incision, typically medial to the left nipple in a male. And through this little incision, we retrieve the internal mammary artery, treat it with papaverine, and then anastomose it to the LAD, which is stabilized with the Medtronic Nuvo device. The anastomosis is constructed under direct vision with a well-visualized, well-stabilized target, attempting and expecting to achieve the same precision of anastomosis that we would achieve in an off-pump bypass. Here you can see a nice cobra head anastomosis of the lead to the LAD, and here you see a very small skin incision. We usually, almost always, measure the flow in the left internal mammary artery graft using a transit time device from Medistim to document the flow and the pulsatility index and the diastolic fraction. And then typically on postoperative day number 1, the patient goes to the cath lab, has angiography documenting patency of the internal mammary artery, and then in this case, a stent to the right coronary artery. This is case number 2 now. And this patient has left main bifurcation and proximal LAD stenosis, as well as multiple other comorbidities, and refusing to have sternotomy. Here you see the distal left main stenosis, as well as the proximal LAD stenosis and ostial circumflex stenosis. The lateral view demonstrates that distal left main stenosis rather clearly. We did a robotic-assisted alignment of the LAD, and then on day 1, our cardiology colleagues stented the left main into the circumflex, jailing the LAD after documenting patency of the internal mammary graft. So here you see the mammary graft being shot. That's widely patent. And then we stented the left main into the circumflex with a drug-eluting stent. And the completion angiogram demonstrates a beautiful, widely open left main into the circumflex with a jailed LAD. This patient was discharged home on postoperative day 3 and was back at work as a laborer in 2 weeks. We actually published back in 2011, more than a dozen years ago, this technique of hybrid robotic grafting of the LAD and subsequent stenting of the left main into the circumflex for left main bifurcation stenosis. Now, there have been several systematic reviews and meta-analyses comparing hybrid revascularization against coronary bypass surgery by conventional techniques. Most have demonstrated that hybrid revascularization is no worse, and some have demonstrated perhaps that hybrid has some advantages in terms of lesser morbidity or even mortality compared to conventional bypass. In this trial, a prospective approach was taken, and 200 patients were randomized to have either hybrid revascularization or conventional coronary bypass surgery. At 12 months follow-up, there was no difference in freedom from MACE. At 5 years follow-up, there was no difference in freedom from MACE between conventional bypass and hybrid coronary revascularization. Here you see at 5 years the mortality curves. Now, we are funded through the National Institutes of Health a hybrid coronary revascularization observational trial some years ago. The goal of this was to study the behavior of sites in the United States of America in treating patients who had coronary anatomy amenable to hybrid revascularization. Did those patients receive hybrid revascularization, or did they receive multivessel stenting? We hope to learn enough about these centers and the behavior and practice regarding patients with hybrid eligible coronary anatomy to inform a prospective randomized trial of our own. So here you can see that in this hybrid revascularization observational study, these different centers had dramatically different approaches to patients with similar coronary anatomy. At Emory, most of those patients received hybrid revascularization and only a few received PCI. Similarly at Yankeneau. At Montefiore, they were much more balanced and even, while at Columbia, most of those patients received PCI and not hybrid revascularization. Nonetheless, when we followed these patients through 12 months, there was no difference in mortality, MACE-free survival. But at 18 to 24 months, there seemed to be a signal towards a better MACE-free survival for patients who received hybrid revascularization compared to multivessel stenting. This meta-analysis examined hybrid revascularization against coronary bypass much more recently in 2022, concluded that hybrid revascularization was safe and effective, and it reduced short-term complications. Now, I'm going to skip over those slides to this one, which is a 10-year follow-up of propensity-matched groups in China who, with similar coronary anatomy, underwent either hybrid revascularization, conventional bypass, or multivessel stenting. And what they found that was compared with conventional strategies of multivessel stenting or coronary bypass, hybrid revascularization offered satisfactory long-term outcomes in terms of MACE and functional status. And this was an encouraging 10-year finding. We were able to write a grant that was funded through NIH to accomplish a prospective randomized trial for hybrid coronary revascularization. This rather ambitious trial intended to enroll 2,300 patients at 70 sites with multivessel disease involving the LAD, eligible for hybrid revascularization or PCI. The primary endpoint was 5-year MACE, and this was a superiority trial organized by myself and Greg Stone, myself, a surgeon, and Greg Stone, a cardiologist. So this was truly a multidisciplinary effort. As mentioned, the primary endpoint was all-cause mortality, MI, stroke, and repeat revascularization over 5 years. Secondary endpoints included each of the components of that composite primary endpoint, as well as health status and cost effectiveness. However, enrollment was relatively slow to ramp up. In the first 1 year, we enrolled 200 patients of our planned 2,300 patients. Unfortunately, the trial was ultimately halted, and this was due to a variety of technical challenges that impacted our enrollment. The trial was funded in 2016, but the investigational device exemption consumed most of 2013 due to numerous bureaucratic hurdles at NIH and FDA, and enrollment didn't begin until 2017. When we onboarded North American sites, only a total of 37, NHLBI would not allow us to enroll the 40 European sites that wanted to begin enrolling patients in the trial and were ready to launch, and Asian sites were also not permitted. So ultimately, the NIH enforced its 7-year rule, which was a new rule at that time, demanding that R01 clinical grants would have to complete their follow-up within 7 years of the award date. But our endpoint was a 5-year follow-up, and the IDE had consumed an entire year after the award. So this rendered it essentially impossible to complete enrollment for our trial. And although we did enroll 200 patients and followed them for 2 years, this did not add a lot of new information to the literature. Clearly, those 200 patients did fine, but no strong conclusions could be made. Dr. Moreno and I wrote this JACC Review Topic of the Week in 2020, concluding that hybrid revascularization had important benefits and advantages for carefully selected patients and deserved more attention and more study, because we could optimize individualized outcomes for revascularization patients if we appropriately allocated them to either CABG, multivessel PCI, or hybrid revascularization. And that requires a careful understanding of what hybrid revascularization is. It is intended to provide a limit to the LAD graft to patients who presently receive only multivessel stenting or LAD plus other non-LAD stenoses. It's intended to move patients out of the cath lab and into the operating room for minimally invasive bypass for at least part of their therapy. And it's intended to replace a stent in the LAD with a lead to the LAD, prolonging life. It is not intended to provide stents to patients who would otherwise receive multivessel all-arterial bypass. It is not intended to move patients out of the operating room and into the cath lab. It is not intended to promote incomplete revascularization or replace multiple arterial grafts with multiple stents. Well, we need to be realistic about this and try to move towards a really compelling and attractive operation, which in my mind would be bilateral ITA grafting in a closed chest anaortic off-pump approach. What will it take to make that sort of thing routine? Well, we'll need to have clear evidence that hybrid revascularization beats multivessel stenting, which is what is provided to most patients suitable for hybrid revascularization. And I think that's doable because I don't think it will be difficult to convince cardiologists that a LITA to the LAD beats a stent in the LAD, if we can do that LITA with near 100% patency and near zero mortality. That said, we need industry to help us make hybrid revascularization, especially bilateral ITA hybrid revascularization, more reproducible, more easily performed, and more easily taught. And this will require better instruments to facilitate bilateral ITA harvesting without sternotomy. We need to have the coronary stabilizing devices reintroduced, and the facilitated anastomotic devices need to be miniaturized and integrated onto robotic arms in order to allow TCAB, totally endoscopic coronary artery bypass grafting, to become more commonplace with bilateral ITA grafts and no sternotomy and no aortic manipulation. So this pragmatic approach realizes or acknowledges that the real world reality is that most patients with two-vessel disease involving the LAD receive multivessel stenting without even a discussion with a surgeon. Most cardiologists believe that a drug-eluting stent in a non-LED lesion is about as good as a vein graft. But hybrid revascularization offers a pragmatic approach by engaging the cardiologist to perform a diagnostic cath, a second diagnostic cath to document patency of the IMA, and then an intervention, stenting the non-LED lesions. It's very difficult to have cardiologists give up patients that they can and do stent, but they all do understand the benefit of an ITA to the LED. And hybrid revascularization fundamentally is about giving more patients a LITA to the LED. Once again, the International Society was founded to advance the state-of-the-art in surgical coronary revascularization and to improve the care of patients with coronary artery disease worldwide. We've had 10 annual meetings, most recently in London, and we look forward to our 11th annual meeting, 2.5 days to discuss advanced techniques in coronary surgery in New York City, December 4 to 7 this year. We would be delighted to welcome many of you there. Thank you again for the privilege of participating, even if just remotely, in this celebration of the Philippine Heart Centers. Thank you so much.
We'll have 2 more lectures of Dr. Pascas.
Hello, my name is Dr. John Puskas. I'm professor of cardiothoracic surgery at Emory University here in Atlanta, and it is my privilege to participate in this 50th anniversary celebration of the Philippine Heart Center. This lecture is entitled The Rationale for All Arterial, No Aortic Touch Off-Pump Bypass and How I Do It. These are my disclosures. The rationale for all arterial, no aortic touch off-pump bypass is relatively simple. Arterial bypass grafts offer better long-term patency than veins. We also know that avoiding aortic manipulation greatly reduces the risk of perioperative stroke and therefore death. Thus, it's logical to consider all arterial, no aortic touch as the best long-term revascularization strategy as well as the least perioperative morbidity, and therefore constituting state-of-the-art coronary bypass. Let's look at some of those assumptions. We know from this rather famous paper that 2 arterial grafts are better than 1, in this case 2 double mammary grafts. You can see for survival and for intervention-free survival, beta beats CETA in this long-term Cleveland Clinic follow-up paper by Bruce Lytle. And here's the 20-year follow-up with that same 10-year paper demonstrating that those survival curves for double mammary grafting continue to diverge through 20 years of follow-up in favor of bilateral ITA grafting. At Emory, we explored the question of whether bilateral ITA grafting would result in longer-term survival in diabetic patients, knowing that our patients presently are much more likely to be diabetic than they were in the days when those early studies at the Cleveland Clinic were done. And yes, indeed, for diabetic patients, bilateral ITA grafting has a dramatic benefit. In fact, here are 4 groups of patients, a total of about 40,000 patients at the Emory University database, where beta in non-diabetic patients had the best long-term survival, but the second best survived patients were those with diabetes who received bilateral ITA grafting. And those patients with diabetes receiving bilateral ITA grafting actually survived longer than patients without diabetes who were only given a single arterial graft at the time of their operation. David Taggart and his colleagues published this paper in the New England Journal looking at the 10-year survival for a randomized trial called the ART trial. I had the privilege of participating in this publication, and this is the largest RCTA of beta versus CETA with the longest follow-up. We looked at intention to treat and also as treated analysis of these patients through 10 years of follow-up. And that's very important because about 20% of all patients received a different treatment strategy than intended in this trial. 14% of patients in the bilateral ITA group actually received a single ITA. 4% of patients assigned to single ITA actually received bilateral ITA. And 22% of patients in the single ITA group received a second arterial graft in the form of a radial artery. and this muddied the waters and confounded the analysis. The intention to treat analysis, simply by virtue of the assignment of the patient to a single or double ITA strategy, revealed no difference in mortality at 10 years. But if you looked at patients rather by how they were treated, rather than how they were assigned in the randomized trial, those patients who received multiple arteriographs actually had a lower mortality by almost 20% over 10 years than patients who received a single arterial graft. So in the as-treated analysis, beta beat CETA. And by intention to treat, the multiple composite endpoint of death, stroke, and MI was not different. But when we looked in the as-treated analysis, patients who received multiple arteriografts were less likely to have death, stroke, or MI at 10 years, gained by about 20%. So why don't patients receive bilateral ITAs more commonly? Why do we surgeons perform that operation infrequently around the world? I think fear of deep sternal wound infection, especially in diabetic patients, is a primary reason. And in fact, it is true that bilateral ITA patients in most studies demonstrate a greater risk of deep sternal wound infection than single ITA patients. However, if we look at skeletonized bilateral ITA harvest in this right-hand column, you can see the skeletonized ITA harvest does not confer an increased risk of deep sternal wound infection when both mammary arteries are harvested. Here in the ART trial specifically, skeletonized bilateral intrathoracic artery patients had an identical risk of deep sternal wound infection as pedicled single mammary patients. So skeletonizing the mammary artery during harvest mitigates against the risk of deep sternal wound infection, probably because it preserves retrosternal microperfusion, as demonstrated in this study, where tissue oxygenation in the retrosternal tissues and blood flow were documented to be superior if the arteries were harvested in a skeletonized fashion. Moreover, we know that there are other ways to mitigate against deep sternal wound infection. Vancomycin paste pushed into the bone marrow of the sternum at the beginning of the case and then again at the end of the case greatly reduces the risk of deep sternal wound infection. In fact, it is recommended in this expert consensus review from the AATS. We particularly use it religiously. A single gram of vancomycin with 3 or 4 drops of plasmolyte produces a little ball of paste that can be pushed into the bone marrow. We may use 3 or even 6 of these at a time in order to push into the bone marrow, reduce bleeding during the case, and mitigate against the risk of deep sternal wound infection after the case. Is it worth it? Do patients who receive multi-arteriografts actually live longer than patients who receive single arteriografts? Well, the answer is clearly yes. This is a study of over 1 million patients from the STS database presented last year at STS, in which multi-arteriograph patients, of which there were 100,000, outlived single arteriograph patients, of which there were over 900,000, over the course of 10 years follow-up, with a highly significant p-value. In fact, when we look at each of the subgroups of patients in this study, all groups benefited from multi-arterial grafting. Left main, 2-vessel, 3-vessel, low ejection fraction, normal ejection fraction, urgent, elective, off-pump, and on-pump patients all did better with multiple arteriografts compared to single arteriografts. That was especially demonstrable for young patients. The younger the patient, the longer they have to live, and therefore the greater the benefit of arterial grafting. Here you see the trends over time in the STS database. From year 2010 through 2020, our rate of using 2 or more arterial grafts improved slightly, especially only at the end of this analysis. We're still at about 14%. Note that about half of those patients who received 2 grafts received betas, and about half received a radial artery graft. Speaking of radial arteries, I had the privilege of participating in this analysis with Mario Gaudino of 6 previously performed prospective randomized trials comparing Alita plus a radial plus veins versus a lita plus veins? That is to say, does adding a radial artery as a second arterial graft impact survival? And the short answer is yes, it does. Graft occlusion is less common, so that death, MI, and revascularization for patients who received a radial artery is less common. Angiographic graft failure is less common. And repeat revascularization is less often necessary in patients who receive more than one arterial graft when that second arterial graft is a radial artery. Indeed, this interesting study with angiographic follow-up from Australia demonstrates that radial arteries and internal mammary arteries both are better than saphenous vein graft patency, and they're approximately equal to each other. This reminds me of a quote from Dr. Carpentier from 1973, in which he argues that the discussion should not be on the difference between the radial artery and the mammary artery. It should be between venous tissue and arterial tissue. Because we know and have known since 1970 that neointimal hyperplasia plagues vein grafts when they're connected to the aorta and used for outflow to the heart. Neointimal hyperplasia is the Achilles heel of vein grafting. So that here you see in this JACC Review of the Week paper from 2022, that patients who receive total arterial vascularization outlive those who receive multi-arterial but not total arterial. In other words, avoiding saphenous vein grafting altogether reduces the risk of mortality over long-term follow-up. Now, switching gears for a moment, what is the biggest and most feared perioperative morbidity? I would argue it's stroke. And here's the one-year results from the Syntax trial, demonstrating very clearly that CABG has a higher perioperative stroke risk than PCI. And that was the case in the Freedom trial as well, roughly twofold higher risk of stroke for CABG versus PCI. But we have ways of reducing that risk. We can avoid CPB entirely, or when we use it, we can do epi-aortic scanning and individualize the location of cannulas and clamps, or we can minimize the use of those clamps altogether. And we demonstrated from Emory in 2015 that a no-touch technique had the best observed to expected ratio for stroke, minimizing the risk of stroke even in patients with higher preoperative risk. This is a meta-analysis from Edelman and others from Europe, studying anaortic off-pump bypass versus side-clamped off-pump bypass, and anaortic off-pump bypass versus conventional bypass. And in both comparisons, in these meta-analysis, anaortic OpCab had the lowest risk of death compared to either side-clamped OpCab or conventional bypass. And this brings me to this important paper. It's also from JACC in 2017. 13 studies were used in this meta-analysis in a network fashion, about 40,000 patients. We compared outcomes with 4 different techniques: traditional on-pump CABG, off-pump bypass with a partial clamp, off-pump bypass using the heartstring facilitated anastomotic device, which minimizes aortic manipulation, and then entirely no-touch aortic technique, or anaortic OpCab. In this meta-analysis comparison, we look at each endpoint, here stroke, there mortality, here myocardial infarction, and we compare the alternative techniques. So for anaortic OpCab compared to conventional coronary bypass, we see that the odds ratio for stroke is 0.22, meaning that there's a 78% reduction in stroke for anaortic OpCab compared to conventional bypass. And anaortic OpCab sits at the top of the pyramid, the most preferred technique for stroke, death, near the top for myocardial infarction, at the top for renal failure, for bleeding, and for atrial fibrillation. It beats conventional or partial clamped OpCab essentially every time. So can no aortic touch and aortic off-pump bypass be generalized? Well, Alexander Albert has led his department in Germany to adopt a uniform anaortic OpCab approach for all their coronary patients, irrespective of which surgeon is doing the case. This took some effort, I am sure, to convert from a historic on-pump practice to a new no aortic touch, all arterial off pump practice. But the result was that early stroke was reduced by almost 90%. And here you can see over time, as the rate of anaortic OPCAV increased, the risk of all stroke, or especially early stroke, plummeted. And thus, avoiding aortic manipulation is recommended in the European guidelines for revascularization. And preferably no touch technique when off pump is used. So in summary, surgical coronary revascularization must deliver the best possible long-term outcomes with the least perioperative morbidity. All arterial grafting prolongs life because beta and radial arteries are generally better than vein grafts for long-term patency. No aortic touch off pump, by avoiding manipulation of the ascending aorta, is associated with lower risk of stroke and death, and especially benefits high-risk patients. Therefore, I consider it state-of-the-art CABG. Now, how do we do it? Well, first we must harvest the internal mammary arteries in a skeletonized fashion. And I have thought about coronary bypass surgery as a two-step operation. Sometimes it's a three-step operation. The three steps are harvest the arteries. Second step is construct the composite conduits. And the third step is deploy those conduits on the heart. So the first step is to harvest the two internal mammary arteries by skeletonized fashion with uplifting retractors, and there are a variety of them. This is the one we use most commonly, the Coutil retractor, and it gives a nice view of the inside of the sternum. And you can see we take down the fat and pleura to denude the chest wall and allow us to approach the mammary artery with the harmonic scalpel. We use this hook blade on the harmonic scalpel to cauterize the side branches of the mammary artery with minimum trauma to the artery itself. The scalpel will literally liquefy fat from around the artery. It can be allowed to touch the artery very briefly without damage to the artery and without inducing spasm. And this allows us to very carefully see the branches with this flutter technique. And then we use the forward edge to cauterize or coagulate the branches before we divide them with the hook portion, as you see about to happen here now on this side branch. Here's the hook, and we've divided that side branch. Now then we build the composite conduits. I'm going to show you here several different ways of building composite conduits. In this particular one, we're going to take the right mammary off the chest wall and suture it to the side of the left mammary artery to build a composite conduit of bilateral ITAs. We've identified the optimal site for this anastomosis based on the geometry of the heart and our intended targets. And then we bring the lita up onto the drapes. We occlude it with an atraumatic bulldog proximally, and we construct this anastomosis in a very, very controlled fashion, totally immobilized, well illuminated, perfectly visualized. And each suture of this anastomosis passes in exactly the same way for each of these constructions. We build this T-graft the same way every single time so that the surgeon and assistant know exactly what's going to happen next. Once the artery is complete, we document good flow in both limbs of the composite conduit before we proceed with the bypass grafting. Now we can build the lita composite also using radial artery in the same fashion as a T off the side of the left internal mammary artery. I'm going to show you this in a different case. Here's the lita. We're identifying the optimal site on the LAD that we're going to cut off the very end of the lita. Here's our target on an intramyocardial ramus intermedius. We're going to identify the optimal site for the proximal inflow with a radial artery graft just inside the edge of the pericardium. And then we're going to build that anastomosis exactly as we did for the right mammary off the left mammary. Again, immobilized, stabilized, and well visualized so that we can construct that anastomosis in a very, very precise and reproducible fashion. And then once again, we check to be sure the graft is patent and hemostatic and that flow in both limbs of the composite conduit is excellent before we proceed with the distal bypass grafting. Now, on the right-hand side, we usually elongate the skeletized reta. The reta is used in situ in most of my cases, but I think it's very important to avoid tension on the reta. My personal belief is that the reports that have shown reta patency to be inferior are caused by technical problems with the deployment of the reta, especially if it's used in a tight configuration in situ, or when it's sewn as a free graft to a thick-walled aorta. And that mismatch is just too great to overcome and achieve perfect patency. So for us, you'll see us trying to get to this PDA here. But the reta, well, it seems like it might reach there, but that's too tight. There's not enough laxity there. So we're going to use an elongation of that reta to reach without difficulty to that PDA. And we do that building an I composite conduit and then demonstrating flow before attaching it distally to the PDA. This is my personal favorite operation. The right mammary elongated with a piece of radial to reach without tension whatsoever to the distal right circulation, the left mammary in situ to the LAD, and the remainder of that left radial from the side of the left mammary to the rest of the lateral wall, 1 or 2 obtuse marginal vessels. There are many different ways to do this, and it can be achieved in multiple different configurations. I like to think very carefully and individualize the approach to each patient, taking into account the relative tightness of each of the native coronary stenoses, the quality of each of the various conduits available, the geometry of the heart, and the distances we need to cover to avoid tension and to avoid asymmetric competitive flow within composite arterial conduits. Here's another possible configuration, a so-called K graft. It looks a bit like a K, and Junjiro Kobayashi taught me this graft, and so I call it a K graft. Here's an intraoperative video demonstrating the reta elongated with a piece of radial artery brought through the transverse sinus to approach the obtuse marginal. A T graft of radial off the side of the leta for a diagonal and the leta to the LAD. Here we're going to pass that radial artery, which has inflow from the right internal mammary artery through the transverse sinus to easily reach with no tension at all to the lateral wall of the heart. We happen to be clipping the appendage in this particular case. And here you see the reta I graft, which has been passed through the transverse sinus, being used to bypass a posterolateral marginal on the lateral wall of the heart in an off-pump configuration. A video tutorial of our technique is available here. There are many different images here, and we hope that that may be also helpful. Again, my personal favorite operation, the one we perform most commonly, is this one. Bilateral ITA with the radial artery outflows from the ITA to all territories of the heart. It's especially helpful in a patient with a porcelain ascending aorta, as shown here in the picture. We liked it so much that David Taggart and I put it on the front of this book, which we published a couple of years ago at Oxford University, State-of-the-Art Surgical Coronary Vascularization. Now, the syntax, freedom, and fame long-term results demonstrate that CABG is superior to PCI for most patients, especially diabetic patients with complex coronary artery disease. But stroke remains the Achilles heel of the heart, the Achilles heel of coronary bypass for the heart. In my mind, off-pump bypass has now entered into a new phase. Rather than simply replacing on-pump bypass, it provides an opportunity to recreate bypass surgery as a whole by achieving a no aortic touch all arterial configuration. This will reduce the risk of perioperative morbidity by avoiding aortic manipulation and maximize the longer-term benefit of the procedure. So to me, the real goal should be a zero mortality in elective coronary bypass and a near zero repeat revascularization rate. These are only possible with a no aortic touch, all arterial approach. Once again, the International Society for Coronary Artery Surgery was founded to advance the state of the art in surgical coronary revascularization. We've had 10 annual meetings, and we look forward to our 11th in New York City in December. We would be delighted to welcome many of you there. Thank you again for your attention and for the privilege of participating in the 50th anniversary of the Philippine Heart Center. Hello, my name is John Puskas. I'm professor of cardiothoracic surgery at Emory University in Atlanta, and it is my privilege to participate in this exciting conference honoring the 50th anniversary of the Philippine Heart Center. Thank you for the honor of joining you remotely. This lecture is entitled Coronary Stentectomy for Management of LAD Chronic Total Occlusion, Full Metal Jacket. These are my disclosures. Coronary stentectomy is a surgical treatment of severe in-stent restenosis, typically after multiple PCI procedures, especially in the LAD, usually involving extensive endarterectomy and removal of multiple stents, in other words, a full metal jacket, followed by very long onlay patch grafting, preferably done with an internal mammary artery graft. This is a video case report of one such procedure in a 64-year-old gentleman with the typical comorbidities and debilitating chest pain with minimal exertion. This now forcibly retired businessman was literally unable to get from the bedroom to the bathroom without angina. His coronary angiogram will be shown and documents this very, very severe, multiply stenosed full metal jacket of the LAD after numerous interventions. We opened his chest and harvested the left internal mammary as a skeletonized graft. And here you can see an image of the full metal jacket in the LAD and the skeletonized ITA adjacent to it. In this image, the feet are towards the right-hand side and the head towards the left. After establishing cardiopulmonary bypass and cardioplegic arrest of the heart, we opened the distal LAD just beyond the end of the stents. And this is critically important in order to establish the correct planes for the endarterectomy. We want to be absolutely certain where is the intima, where is the adventitia, and where is the media intima core, which will include the stents, to be removed by formal endarterectomy. We then use a 15 scalpel blade, typically requiring multiple blades, to cut down directly in the midline, the 12 o'clock position on the anterior aspect of the LAD over its entire length, cutting down directly onto the typically multiple layers of stents in the LAD. The cobalt chromium from which the stents are manufactured blunts the stainless steel scalpel blade, and we typically have to replace the scalpel blade numerous times during this procedure. The key then is to establish the correct plane for the dissection. Here you can see we've identified the core, we've identified the normal adventitia plane distal to the stents, and we're now beginning the endarterectomy, trying to get a circumferential dissection while preserving the adventitia entirely intact and avoiding any tear or rent in the adventitia. You see, we just harvested a core of media and intima from a diagonal branch. And this illustrates a key part of this procedure, namely that we want to preserve the outflow from the LAD by doing limited endarterectomy of diagonals and septal perforators, and then reperfusing those vessels because they represent the outflow for our neo-LAD, which we will recreate using the left internal mammary. More distally, and right around the apex of the heart, we perform a traction endarterectomy, completing the distal endarterectomy of literally the entire LAD. We continue the dissection proximally until we reach a point where the LAD begins to dive deep into the base of the heart and it becomes more inaccessible. We transect the layers of stents at this region, typically adjacent to the first diagonal and certainly distal to the first septal perforator. These are an instrument that is normally used to cut sternal wires. The multiple layers of cobalt chromium sometimes require a rather vigorous instrument to transect. And here you can see now the adventitia of the endarterectomized LAD, the core specimen of stents, intima, and media, which is over 10 centimeters long, and the skeletonized left ITA, which will be used to reconstruct the LAD, creating a neo-LAD. My grandfather taught me to measure twice and cut once. So we measure very carefully the length needed in the skeletonized left internal mammary artery before we incise it over that entire length to begin our anastomosis, which will reconstruct a neo-LAD composed of left internal mammary artery tissue and residual left anterior descending adventitia, with the outflow to the diagonals and septal perforators. The anastomosis is a long and relatively tedious anastomosis. It must be done very carefully. Each bite in the skeletonized mammary is at a normal depth, while the bites in the adventitia of the LAD are deeper than one would normally do. We want to achieve hemostasis there, and we also want to exclude as much of the LAD adventitia as we can while still preserving outflow to the diagonals and septal perforators. This is why I refer to the procedure as a neo-LAD. Once the procedure is completed, only the posterior aspect of the LAD adventitia, which feeds the septal perforators, and the lateral aspect, which feeds the diagonal ostia, is left intact. The remainder has been excluded by these sutures and rebuilt with healthy left ITA endothelium. Anastomosis is completed all the way around, typically requiring at least 2 8-0 proline sutures due to its length. Then we restore flow and wean from bypass. This is a typical flow, excellent flow in the transit time flow meter with a low pulsatility index and a high diastolic fraction. Postoperatively, we're obviously concerned about the risk of thrombosis of the graft and acute closure of the LAD, resulting in a large anterior myocardial infarction. So as soon as the patient arrives in the intensive care unit and is clearly not bleeding in a surgical way, we give a half load of aspirin, which is 2 baby aspirins, 162 milligrams total, and 2 Plavix tablets, 150 milligrams, as well as subcutaneous heparin. On postoperative day 1, we add to this apixaban, either 2.5 milligrams twice a day for small patients or 5 milligrams twice a day for larger patients. We repeat a coronary angiogram 6 months later, and if that documents wide patency of the graft, then we will stop the apixaban and continue the dual antiplatelet therapy. A second repeat study at 1 year, if it shows a wide patency of the graft, will allow us to discontinue dual antiplatelet therapy and proceed with lifelong monotherapy. This is that same patient, 6-month angiogram. You can see the LAD is reconstructed with outflow to diagonals and septal perforators, but it's somewhat irregular and relatively small. At 12 months, it's a little more regular and somewhat larger, with better outflow to septals and diagonals. There seems to be some remodeling of this neo-LAD. So in summary, stentectomy for full metal jacket, CTO of the LAD, is done for patients with chronic total occlusion or subtotal occlusion of full metal jackets in the LAD. When percutaneous approaches have been exhausted and are no longer beneficial, and when there is significant viable myocardium in the anterior wall and septum, causing relentless or debilitating angina. The goal of this procedure is the same as any coronary surgery: to improve quality of life by removing angina and to extend length of life by preventing myocardial infarction. This is, in fact, a niche procedure, and we are happy to receive patients in transfer or surgical referral for this special procedure. Frankly, I've done now 14 of these procedures only, and I don't know of anyone other than Shinichiro Takanashi in Tokyo who is doing this procedure. So we consider it truly innovative, and I can tell you that it is exceedingly demanding from a technical point of view. The International Society for Coronary Artery Surgery was founded to advance the state of the art in surgical coronary revascularization and to improve the care of patients with coronary artery disease worldwide. We've held 10 annual meetings, the most recent one in December in London, and we look forward to our 11th in New York City in December of 2025. We would love to see many of you there. Thank you so much for your attention, and congratulations to the Philippine Heart Center on 50 years of excellence.
Thank you, Dr. Puskas. Unfortunately, he isn't here with us today. So, with our esteemed guests, would you like to have any comments or any suggestions? I know some of you do OPCAB surgeries. Do you have any experience with the stentectomies or anything you would like to say?
Yes, I have.
Yes, Dr. Keita.
The stentectomy and the atherectomy. Yeah, in Japan, we have a lot of the very aggressive cardiologists
Yes.
want to do PCI for RID. But after removing the endoatherectomy, after doing endoatherectomy and stentectomy, it has a much high risk of post-operative thrombosis on the RID.
Yes.
So we need to give heparin immediately after
Okay.
surgery, but we need to confirm the bleeding is not much.
Okay, yeah.
And we also need to give the patient a much antiplatelet therapy using aspirin and clopidogrel and some other kind of warfarin and DOAC as well.
Mm.
So it's really important to open the bypass
Yes,
after surgery. It's a
immediately.
very important tips.
Okay. Thank you, Dr. Keita. Any others? Yes, Dr. Chang.
Hello, good morning, everybody. So, Guo here from Singapore. I think as we are facing younger populations who go to cardiologists, I think we'll face this problem getting commoner in the near future.
Yeah, exactly.
In my practice, when I do coronary atherectomy, not stentectomy, I put them on warfarin for 6 months. So I was just wondering for Dr. Kikuchi, in your center where you see stentectomies, how long do you keep them on warfarin for?
Usually 6 to 12 months.
Okay, so it's aspirin and warfarin.
Yeah. Before then, we also give double antiplatelet therapy until 6 months.
As you saw, Dr. Puskas's kind of post-operative, he gives full antiplatelet therapy plus apixaban. Apixaban is
DOAC.
DOAC, exactly, which is not the direct one, which is Coumadin. So I think they do the same thing as you do. But I think that the number one issue, even before stentectomies existed, with endarterectomies was post-operative patency.
Yes.
And the first 24, 48 hours is very critical, as Dr. Kikuchi has posted. And I think that you have to weigh the bleeding versus the antiplatelet and anticoagulation, because at the end of the day, some of these patients bleed and you have to be very careful. So that's why I think it's very patient selective.
Okay.
And I think you have to be very careful with it.
We can't do this
For
kind
everyone.
of surgery for the elderly patient
Yes.
because of the bleeding.
Okay.
And the feeling of removing all endothelium or stent and replace coronary artery to we using mammary artery.
Okay. Anyone from local from the Philippines, if you have any questions or comments? If none, I would like to remind everyone that we are live on YouTube and also thanking our industry partners. Okay, so we can move on to our next session. So our second session, we will talk about inflow options for mixed cabbage and insight to right gastroepiploic artery for severe RCA lesions by Dr. Natapon Arayawud Hikul. So a little background on Dr. Natapon. Dr. Natapon graduated from Chiang Mai University, proficiency in general surgery, also from Chiang Mai University, and thoracic surgery. His cardiothoracic surgery is from Maharat Nakhon Ratchasima Hospital in Thailand, 2009. Currently, he's the chief of cardiothoracic surgery in Lampang Hospital in Lampang, Thailand, and fields of interest in OPCAB, arterial conduit revascularization, and minimally invasive cardiac surgery. I was fortunate enough to be able to visit him in Lampang last July for a month of observership in his OPCAB and minimally invasive surgeries. And I am proud to call him my mentor and also my friend. So without further ado, let me welcome Dr. Natapon Arayawud Hikul. Let us give him a warm round of applause. Thank you, Dr. Martin Kase, for the kind introductions for me. It's a privilege for me to come here in this mega city of the coronary surgeries in Southeast Asian country. Thank you, Dr. Junior Ventura, Dr. Yam, and all the crews, my teachers all around here, and my friends back there. I would like just to, actually, all the core things was also mentioned by Professor Pascas already. And my duty is just to extrapolate all this knowledge to my practice in my local hospital in the northern part of Thailand. I didn't work in the university hospital. I work in a government-based hospital. However, in my hospital, the burden of cardiovascular surgery is high, especially in the coronary artery surgeries. So we try to do our best to improve the quality of life of my patients. And I know even we are a small hospital, minimally invasive surgeries is, may also lift up the quality of life of my patients in the community. My talk is about the inflow options for mixed cabbage. So I'll do my best. This is our active surgeons in my center. We are 4 surgeons, and I'm the senior guys out there. And I worked there for 15 years to establish the new center in the northern part of Thailand. As you know, the main objective for the mixed cabbage is that, that means we do a lot of millions and anatomy outcome beforehand. And then we go on to get out of the box to avoid the complication related stenotomy that we all know it's out there if you do more and more out of the bilateral ITA harvesting. And also, if we do that, we have to realize that we don't have to do the non-inferiority result compared with stenotomy. And if you do that better, you extrapolate again to complete revascularization and do more multi-arterial revascularization or even total arterial revascularizations. What options do we have if we do mixed cabbage? Many ways. I think there's many more than this slide, but what we do in my hospital is ascending aortic clamping, IT, Y graft, or even inside grafting. And the other ways around it we use now in some particular case, we use a left subclavian artery as an inflow. I will start with some video to everyone to see how we really do it. Ascending aorta is what we get used to in cabbage, right? So actually it's not quite easy, I think, for mixed cabbage because the access is small and sometimes it's far away from you. So if you really want to do that, what would you do? This is a 68 years old Thai patient with recent anterior was non-STEMI.
diabetes, hypertension, like we all have, hypokinesis or anterior wall of the heart. So we have a 31% of ejection fractions. Right chori is the diffuse disease on the proximal to mid part, but the target to the PD or PL is good. So I plan to do bilateral paracervical vein graft. This is after I harvest bilateral ITA completely, and then I move on to explore the ascending aorta. Well, most important is you have to remove all the thymus gland. Everything, like Professor Kikuchi will tell you later on, to access to the ascending aorta as much as you can. I didn't learn it by myself. I was learned from many other experts how to expose this. This technique I got from the Professor Nambala from the Indian. You can see that the right shoulder of the aorta, you see that the pericardial stitch coming up into the second intercostal space coming up. So put it higher. So maybe it can help to push your aorta close to you. And very important, like Professor Kikuchi might say, that the important thing is not how you make a suture, it's about how to control with the anesthesiologist. Because you have to maintain the aorta to be soft, like a 7 to 80 millimeters mercury pressure. And not just that, you have to make them stay with you and maintain that pressure for 15 or 20 minutes before you do the operation of the anastomosis. So if you can do that, everything is just a regular operations. And the other thing that is you have to practice is use a not pusher, because it is not safe and appropriate to use your hand tied down. It's a bit far. You're almost there, but usually uncomfortable to tie down with your hands. It's a bit in off-palm way, and you have to be, cautious. And if something wrong happens, like adding a suture, you have to do it gentle and calm. It can be done. And in this case, you can see that I also have to use the octopus stabilizer to press the PA down a bit, but in some particular case, not every cases. So yeah, like we said, this is small incision. You have to measure the graft flows in every time. It's very important, the quality control for the mix-up cap. So this is the practice that we do regularly in my center. Thank you, Jules, also here to stress or concentrate on the flow measurement of validity of the graft, especially in small incision and off-palm surgery. And we regularly perform CT scan before the patient discharge every case to make sure that we don't do the infidelity output for our patients. Another case, this is a 9 years old, the same, but EF is better. This is a CTO LAD, and also some disease on the OM or circumflex system. This is another way around to approach to the ascending aorta. This case, I don't use the pericardial stitch up like the previous case. I just pull it up into the skin of the patients. And as you know that we are developing country, even we use this soft tissue retractor, we have to reuse it. So I don't want to make a stitch on this. And it can be done also the same. Let's see. If you have to remove these pictures, and you can see that ascending aorta is a bit beyond you. And after I do this manipulation, aorta will become close to you. Maybe 1 centimeter is enough coming to you. So I have to make a stitch of pericardium to the skin of the patients to save this soft tissue retractor to use it later on. You do as much as you can to feel that you make a wall on the right side of the heart to push the aorta to you. At this time, you have to talk and communicate with the anesthesiologist all the time that where are you doing? What are you doing right now? What is the pressures, blood pressures? That's most important. If you do something wrong, your partial clamp, you slip off, dissection can happen, and many other serious complications might come after that. The more you do the stitch, the closer the aorta will come to you. Oh, sorry. After that, when I feel that the aorta gets soft, I use one or two pieces of the moisted 4x4 gauze on the right shoulder of the aorta. And then you see that aorta was right in front of your face. And then you do the partial clamp over that. When the situation like that is, I think each and every one you can do. Most of the instrument that we use is a regular instrument that you have in your OT. I think the only thing is not pusher is something that you have to feel comfortable and maneuver it well when you tie down them. This case is also interesting. After I finished these operations, when I measure the flow, the ITA flow is quite susceptible. I'm not so happy with the flow, and I see that my lita TRD is quite stretched. So when I lift the heart up like this, the flow is coming back to be a good flow. That means my ITA TRD is a bit short. So you have to make a revision. Extend the graft as eye configurations to the LAD as an inflow to your distal LAD. So all of these procedures you have to make familiarity with. So in this community, like we come today as an Asian community for coronary artery surgeries, I think just lita to LAD and vein graft is not enough. You want to make a better quality of life of the patients. So you can do this before the discharge. At least the graft is patent. For when you come to more complexity, like you want to do more arterial graft and aortic non-touch, you have to think about our composite, I, T, or Y. In this case, I use the free writer graft off from the lita. So in this kind of procedures, like Professor Pascas mentioned, in median stenotomy case, we can extrapolate this technique into our practice in left thoracotomy as well. I always say that if mediocre surgeons like me can do, I think everyone can do. Just have a belief. I think that the evidence that we know about all these grafts, no need to mention again. We just ignore them. I think just do it. And after this, you can think about any other things about Y graft with the vein graft. And we can know that now vein graft, you can make it more superiority with the evidence from the European countries' guidelines. We respect more about vein graft harvest, less touch, non-pressurized. You can do it with the patients as well. In this graph, we extend the right ITA with the right vein graft. So you can do the 4 or 5 bypass graft with the minimal invasive cardiac surgery. Yes, you can see that the configuration of the graft might not a bit funny, but it's a learning curve. I think it's a bit too long. I learned it from the CT scan, so in the future, I will do it better for the patients. And this is also, we do more and more bilateral ITA harvesting. You can do many kind of configurations. So I think like not just TTFM, but validity with the CT scan or angiogram is worthwhile for us to step forward to make sure that we don't do a bad thing for the patients. And all this showing up that the left thoracotomy CABG can be done. And this is all performed in the off-pump way. Actually, I love to do in situ grafting myself, like we do median stenotomy, like a bilateral ITA and GA grafting. So when I feel more comfortable, this is the case I performed last month. This is a young guy, Thai male patient, recent STEMI with comorbidity a lot, ejection fraction 28. LVDD is approach 6 centimeter, which is over the guidelines or recommendation to do the mix, but this case I will try. You can see that the ejection fraction is not good, but LV wall thickness is still preserved. CT scan, the target was, really bad for his age, 51 years old. So I try to do triple bypass with different in situ. Start with the GA harvesting. As many one might skeptical with the size and the quality of the GA in the Southeast Asian population. From my experience, I think the size is quite fashionable and not so small, as long as you use harmonic scalpel, which is very important. Not to just do clip and cut or tie down. It's very difficult to handle. And thoracotomy for this case, I will do generous, maybe 10 centimeters because the heart is big. So all of these things. This is the right ITA harvesting. You cannot do in every cases, but you have to see the patient's anatomy, the chest side, mediastinal side, with direct vision, like Professor Kikuchi mentions all the way about this. So I'm the left-hand surgeon, so it's quite a bit difficult for me to harvest, but I try my best to do both sides of the ITA harvesting, clip and cut, low diathermy power. You can do the skeletonized as we do in median stenotomy. So what I want to say is that if you do this, try to do this regularly every week. I think everyone can do it. This is a 10 centimeter. So this is bilateral ITA harvesting and GA harvesting completely. And then you can see that right ITA can reach LAD if you do a full length, if you can. This is a liter to LAD. And then we move on to liter to the OM, to the base part of the OM. You can see that actually the size of the ITA, even in Southeast Asian country, if we treat them well, it's big enough. It's not as big as Professor Pascal showed us in the video, but we can. Trust me, you can. There are many ways to get exposed to the lateral wall and inferior wall of the heart and end up with the GA to the PDA through the hole just above the left liver, the same as we do in median stenotomy. And end up with the transit time for measurement before the patients get out of the room to make sure that you do a good job for your patients. This is a post-op CTs before the patient's discharge. This one is quite challenging case because the heart is big. And patient is doing well right now, coming for the follow-up already. So there's many other cases we do like this. With the result is quite acceptable with bilateral ITA and GEA, and even some radial artery to as a Y graft to complete vascularizations. And on the right side is the case I performed 2 weeks ago. I want to show you that in mix, you can even do the bypass of the GA to the distal RCA also. Because this case, funny thing is that when you go up into the aorta, the PDAP is much smaller than I think. I cannot, even the angiogram is good. So I have to dig up into the distal RCA in mixed is also possible. And this is another interesting case. It may be the first case that I do GA to the PDA in mix, but the conduit seems to be a little bit short. So I have to do the extension with the non-touch vein graft. Before the discharge on the left-hand side, you can see the graft is okay. But we're still skeptical that how long it's gonna last. This is a difficult case, so I asked them to do the CT scan 4 years later because the clinical is good, but you can see that luckily it's still the same. This is another complex RCA case with the only bypass from the GA to the PDA. We all can perform in mixed fashion as well. This is the other one that I want to show you around for someone who feel reluctant to approach the ascending aorta in mix is the inflow from the left subclavian arteries. This is a 75 years old Thai female. Ejection fraction is 45. And I would say that if I decided to use left subclavian artery as an inflow, I recommend to do the finding and encircle the left subclavian first before you open the right thoracotomy, left thoracotomy, because if you do that, the anatomy might change, the intercostal surface change also. Just find and encircle them first, and then you harvest the left ITA. This case I plan to do double bypass, lead to LAD and non-touch vein graft from subclavian arteries. Yeah, after that, I make a hole in the second intercostal space and drop it down and do the anastomosis to the left subclavian arteries. This operation performed by anyone. This is my colleagues perform this. I help him. So that's why everyone can do that. If you don't want to touch the ascending aorta and patient is elderly, I think it's a good option to avoid aortic manipulation. Anastomosis is straightforward. And when you finish that, you declamp, and then you have to check bleeding from the side branch because of the non-touch vein. Some hidden bleeding side branch is really dangerous. So just make sure that there's no bleeding. And then you drop it down to the second intercostal space. Yes, like this. And then you do the anastomosis as you usually do. This is I finished the operations. Okay, this is a CT scan before the patient discharge. Usually I would recommend to leave the length of the SVT maybe around 5 centimeters longer than usual, because you have to prepare for when the lungs coming up later is what we were not kinking. Actually, 2 years ago, my colleagues studied this approach to compare between the Y graft with the vein graft, Y from the ITA and subclavian arteries, and also from the inflow from the ascending aorta. It found out that the result is not so bad, at least in the left subclavian group. 21 cases, early CT scan is 100% patent. This is another slide. I want to show you that this case I do the subclavian artery bypass, and before this chart, intraoperatively the flow is a little bit skeptical to lead to LAD. So I found out there's some spasm from the operations, and also a year later I want to see what my saphenous vein graft look like in 1 year. So I can see both things is that my ITA is still the same, and also the literature already is getting bigger after spastic gone away. So to summarize my talk, I think that there's a various way to achieve the optimal inflow for the mixed op cap. I think the tailoring which is the best is actually non-settle. I think multi-arterial graft or even total artery vascularization is also a viable options, even in mix, and is challenging. Ascending aortic inflow in mix is possible, but also technically demanding. That is why I think CT scan, epitic scan before surgery is mandatory. I think the most important is the quality of the graft patency is the key factor to improve the quality of life. TTFM and CT scan is your friend as your teachers also. Thank you very much.
Thank you, Dr. Natapon. So at this point, we'll have a question and answer for Dr. Natapon. Do we have any questions from the body? Also from our esteemed guests?
That was a spectacular talk. It was extremely educational. The question I had for your gastroepiploic, what is your post-operative anti-spasm combination do you use? Because gastroepiploic it's a relatively well-known in terms of its spasm after surgery. So what have you been successful with?
For the gastroenteric artery, I don't have any special recommendation. I keep you all independent. That's usual. No.
But no potential no calcium channel inhibitors, nothing like that.
No, sir. For radial artery, I use for at least 1 year or the rest of the life. But the GA, I think it's okay because for my belief is that the muscular layer is not that as much as in the radial arteries. So usually it's okay. Yes.
Interesting.
Yes,
Thank
sir.
you.
But this is only my experience. Sir. But you have to ask maybe Professor Kikuchi and Professor Royce.
Yeah, I sometimes use calcium channel blocker for patient because during the harvesting GA, sometimes patient GA got a spasm. Then I decide to give some calcium channel blocker for the patient after after surgery. Yeah, that's all. Yeah.
Okay, any more questions? Yeah, Dr. Royce.
Hi, I don't have any experience of the gastroepiploic, unfortunately. But as far as the radial artery is concerned, I really don't use the calcium channel antagonists at all. In fact, I give them vasoconstrictors. I'll talk about it in my talk later.
Okay. So if there are any none, we make Dr. Yam.
Wonderful technique, Doctor. But I just wanted to ask something. Aren't you afraid that the intercostal muscles will crush your vein graft? If you go through the second intercostal space, when the intercostal muscles contract or heal, won't it crush your vein graft?
For lepsoplavin approach, right? I make a hole that my finger, my index finger can pass through easily to make sure that my graft was not constricted. To make maybe sometimes you have to cut the muscle around the intercostal space, a piece of them, and you pass the needle and you make sure that it's not strangulated. Yes, sir.
Thank you, Dr. Natapon. So we can move on to your second lecture. Okay.
Thank you very much. Sorry to interrupted your time. This is actually the study that we performed in my center last year. Because in our center we use a lot of arterial graft and also gastroepiploic arteries. This is the study made from our Japanese fellow in my center. It's about in situ right GA, maybe a more appropriate graft compared to the eye composite graft of the right ITA extended radial arteries for severe right coronary artery stenosis. It's also performed by Dr. Hideki Isa. This is as the business like, and we all know from the early morning lectures that total artery revascularization is the best for the patients. But no, it's not fully recommended in any guidelines. And yet, many renowned surgeons in the world have a lot of papers to confirm its superiority. There's many ways to do total artery revascularizations, but in my center, there's two interesting configurations that we do. So we want to compare between the in situ GA graft to the RCA system, or right ITA plus radio as an eye composite to the PDA system. So this study compare right eye radio eye composite with the in situ GA graft for severe RCA stenosis. For the patients and method, since 2011 to last year, 2024, in our center, we perform off-arm surgery about 2,500 cases. So we have GA group 141 case, right eye plus radio in 71 case. And we do the propensity score matching. So we have 65 on both arms. The preoperative characteristic is pretty the same after we match them. Comorbidity is the same. Everything is the same. So when you see the operating data, even operating time, median number of grafts, conversion is 0. For the last 5 years, the conversion of pump is less than 1% in Lampang Hospital. We use a variety of graft, RITA, LITA, radio, GEA, as you know. The drain outcome is, drain content is the same. Transfusion is less. Early extubation in 1 day is more than 80 or 90% of cases. Yeah, there's one stroke on the RITA radio to PDA because of the postoperative atrial fibrillations, which is not related to the ascending aorta manipulations. From this long-term outcome from log length test, you can see that from MACE and survival, there's some benefit of the GA group compared to the RITA plus radio to the ITA to the PDA group. In multivariate regression analysis, the only thing that have effect on the long-term death is the history of the peripheral artery disease. So on the summary from the study in my hospital is that in situ GA may be a more appropriate graft than RITA plus radio artery as an eye composite to the RCA system in off-pump surgeries. This is my conclusions. So I would say that the GA in Southeast Asian country, even in my hospital, is another alternative and good choice to complete revascularization in total artery revascularization way. This is my message to you, sir. Thank you very much.
Thank you. Sorry,
Yes,
I have
Dr.
a question
Kikuchi.
and comment. What the indication to use the RGA for the PDA and our right coronary system? Because it has some chance of competitive flow, right?
Yes, sir. That is a very important key point that Professor said. In my early practice, I suffer from some case that I don't select the patients well. I mean, you have to select a very bad stenosis. I don't think 90% is enough. It's a CTO or near CTO. But another thing is that sometimes 99% stenosis is a focal stenosis of the RCA. We say it's tight, but it's not the case. You have to find the case that have the long lesions and whatsoever, not just focal stenosis. Nearly 90% or 100%, maybe GA cannot fight with that flow. a few years back. So I find the case that the ASEAN must be a really severe stenosis, not just focal, but long stenosis. And you have to find a good target for them. That's the chance that your GA will live longer. And why I use GA? When I use GA, I use in every case if I think that I will do total arterial revascularization. This is combinations of the good thing for the patients. Usually, I would say that I don't care much about how old the patient is. What I always think is that just do it regularly and routinely. Because if you said the indication is calcification of the aorta whatsoever, not so many cases you have to do like that. If you don't do it regularly, when the times come, you don't have a choice. And also, even in elderly, like a 65, 75 years old, some patients' vein graft is not so good as well. So I think arterial graft is not just about the age of the patients. Maybe it's about quality of life and a better conduit, actually, because all of these arterial graft usually more preserved than the vein, actually. Thank you.
Dr. Kiai and Dr. Chang, do you have any opinions on the gastroepiploic artery?
Was mentioned by Dr. Royce. I personally myself don't have any gastroepiploic experience. I have not used it. I use radial artery routinely. And so it's great to see. This is a very elegant performed study, and it's good to see. But the interesting thing that Dr. Kikuchi brought up is the native coronary artery stenosis is critical also for RGGA as it is for radial artery in terms of postoperative, we can say, graft competition. Thank you. Very well done.
Thank you, Dr. Chen.
Yep. Thank you, Dr. Natapon, for the excellent presentation. In Singapore, we do not have any experience with right GA as a conduit. There was only one case which I saw almost 10 years ago, and I think that case didn't do very well because of like what you said. There was the stenosis wasn't tight enough, so there was comparative flow, and the graft didn't work quite well. So I think with your study, I think the results are very promising, and it does inspire us to try using that graft more frequently. Thanks.
Okay, thank you. Any more questions? Dr. Gap?
Hello, good morning, Professor, and welcome to the Philippines. Thank you for gracing us with your presence. Wonderful lecture. I have a question with the GEA. Do you measure the size of the GAA with your CT scan before doing the surgery? And do you have any, do you have pre-op, post-op complications, gastroparesis or ileus after surgery?
Thank you for the question, Dr. Gap. In my team experience, I would say that there's no complication related to the GI complications. Only mild. I would say that because when I manipulate the stomach, I use the Babcock to pull the stomach up. So sometimes, especially in the first day, patients have some like a red contents, GI bleeding in the NG tube for one day, but it's not a big deal. It's okay. And if I try to do this, to do the GA, I will harvest the GA first, at least to check the size. If it's good, I continue. So I would do the GA first and then IT on both sides. So I know that the GA is good. If it's not good, I will skip and use vein graft or some other graft. But in my experience, only 1 or 2 cases that the GA was small and I abolished that use. So most of the case, more than 99%, if you want to use in now Southeast Asian population, at least in my hospital, it's really good conduit. Yes.
Thank you, Professor.
Thank you. Any more questions?
Just to follow up on that
Yes, sir.
question, preoperative CT scan, will that be helpful in terms of you determining the size of your gastroepiploic preoperatively rather than having to, if you see if it's small, you say, well, I don't think this would be a good conduit to use. Is that helpful?
Thank you, Professor. I wish I could, but in Thailand, we cannot do that. So just not different from the Japanese, like Professor Kikuchi might said. So I just do the exploration first. If it's good, I continue. If it's small, maybe we abolish. But in Japan, it's a different story. Sir.
Yes, I strongly recommend to do preoperative contrast CT scan to measure the length and the diameter of GA before harvesting GA. And if you want to use GA, but the GA is not very good, we can use proximal GA and extension with the extension using the radial artery. It's a good option. Yeah, good inflow. So we have a 3 inflow from bilateral mammary artery and the GA. So we still can do analytic bypass configuration.
One thing to look for the future in terms of making the procedure less invasive is laparoscopic gastroplug harvesting with the harmonic scalpel.
Thank you. Any more questions? I have a question, Dr. Natapan, regarding your previous lecture about the cabbage. I noticed you had one lecture with a very big heart, and you still continue to do your mix. So I would like to ask, do you have any cut-off values for types of patients you do mixed cabbage, or you do all, if, as you said, you just try and do it?
Thank you, sir. Thank you for the question. My selection criteria for the mixed cabbage. I don't have CT scan from the beforehand. Like we get consulted from cardiologists. So usually I just watch up only for the PA chest X-ray. The landmark is just in the mid clavicle down to the diaphragm. If your left side of the heart border is not beyond that, I would say that out of this case, you throw into the mixed group. That's possible to do. And then later on, we can do CT scan and echo to later evaluation and do the selection of the patients later. That's what we do. And also, I don't have CTA every case. I just do the CT, plain CT without contrast to select the patients, which one I can do with. And at least like I found out there's a papers in Lampang Hospital last year also about the stroke with the aortic manipulations. And we see a lot of papers like if you do manipulation or CPB whatsoever have maybe 6-to-1 ratio of stroke rate. But found out that in my centers, the result is the same. Why? Because of when we do more investigation and you don't do CPB, and even you do hashiogram or you use the heartstring or another type, I'm not sure, heartstring or encroach tool, result is the same. The stroke rate is below 1% because you fully investigated everything. So the problem is you don't do fully investigated, the ratio between off pump and on pump is so high. But you can mitigate the risk by fully investigation as much as you can, and you can do everything. So now if you do mix and you can do hashiogram or ascending aorta safely if you fully investigated it. So let's do it.
Yeah, let's do it. Thank you, Dr. Nut. Dr. Royce?
Just to follow on, I noticed you would put the side biting clamp on, but do you do the ultrasound, epi-aortic ultrasound before you put it on?
So, Professor, we do it. So we just bought the system from the ETFM. So every case from 2013, we do the epitic ultrasound before doing the hashiogram, sir. Yes.
Dr. Chang?
One question on your pre-op investigations. That's in my experience doing mid-cap in the earlier part of when I just started. We used to just do CT thorax non-contrast. And I ran into problem with intramyocardial LAD, where the target is intramyocardial. So right now, my practice is to do CT coronary angiogram for all of them before that. What is your take on that for intramyocardial LAD?
Couldn't agree more from that, but I cannot do CTA as much as I can because of the workload from the government hospital. I try to watch on the coronary angiogram. We can see some sign of the intramyocardium, and if possible, you just avoid it. That's what I can say. but I didn't do CT scan to find out this case. Yes.
Yeah, sure. Contrast CT scan is very useful to detect buried coronary artery. And also, the Medistim high frequent echo is also very useful to detect buried coronary artery from the epicardial surface. Yeah, and when you do need to dissect the coronary artery, already the harmonic scalpel is also very useful.
Okay. Any more questions? So if none, let's give Dr. Nat a round of applause. Thank you, Dr. Okay. So it's already midday, so the next part of our symposium will be the lunch symposium. So I invite everyone to transfer to training room A for a luncheon symposium. Also, after eating, if you would like to check out our booths for our sponsors. Okay. The next session will commence at 1300 hours. Okay. Thank you.
Very good.
Dito yung mainit.
Ready mo na.
I'll introduce you in a bit, yeah. No problem. I can just have you have the HDMI, it goes directly. Yeah, you have just give me the HDMI, yeah.
Perfect.
Perfect.
Do you need a
Laser?
sticker?
Sorry?
Do you need a slide changer?
No, it's fine. Thank you very much. Perfect. It's set up. Ready to go.
Natin. For Aventura. Good afternoon and welcome everyone again. I hope everyone had a wonderful lunch. So before we start with the afternoon sessions, we'd like to have one big group picture taking for all the attendees that are here. And our industry partners. Yeah, okay. Sir, dito ka na lang. Yeah, we'll just stand behind our esteemed guests so we can have one big group picture taking. Yeah. Malaking tao dito. Maybe we can all sit down, yeah, and occupy the middle rows. So we can have a uniform picture with everyone in the middle. So if can you move sa middle row? Because we'll have the photographer stand here in front. Sige po, our industry partner, sige, you can occupy the spaces at the back. Thank you, everyone. So to begin our afternoon session, our third session, we will discuss how to start a robotic cardiac surgery program, current status of CABG versus hybrid coronary revascularization with robotic CABG by Dr. Bob Kiai. So a little overview of Dr. Kiai. He graduated MD in Western University, Ontario, Canada, general surgery residency in the University of Calgary, Alberta, Canada, cardiac surgery residency in Western University, Ontario, Canada, cardiac transplantation fellowship at Western University, Ontario, Canada, minimally invasive and robotic cardiac surgery fellowship, University of Leipzig Heart Center in Germany. He is also the chief of cardiothoracic surgery, University of California, Davis Medical Center,
Associate Editor, Innovations Journal for International Society of Minimally Invasive Cardiothoracic Surgery, a previous director of the Minimally Invasive Robotic Cardiac Surgery Program in London Health Science Center, and the founding member of the Canadian Surgical Advanced Technology and Robotics C-STAR Lawson Health Research Institute. His fields of interests are minimally invasive, robotic-assisted, and transcatheter cardiac surgery. Let us all welcome Dr. Bob Kiai.
Thank you very much for that very kind introduction. I wanted to thank Dr. Aventura, Dr. Yam, and also the remaining members of the Philippine Heart Center for this invitation and this opportunity. It's indeed a privilege and a pleasure for me to partake in the 50th anniversary and having heard the history behind the Heart Center. So thank you very much for the opportunity to share such great milestone. My quest with robotic surgery started back in 1998, over 20 some odd years ago, when we first started utilizing a system called computer motion, and then eventually intuitive surgical, because back then there was only one system available. So, and I have started several robotic programs during my career. So I'm going to highlight some important aspects of robotic program. So these are my disclosures. I'm a consultant with these particular type of companies. So the objective of my talk, I'm going to give an introduction. What's the basic training involved? Then the most important thing is the team training. Something that I think that to transition from regular operation to minimal invasive and then robotic surgery is not going to be successful without a team dynamic and a team choreography. It's extremely important. And then I will talk about some of the procedure-based training in terms of extracardiac and intracardiac procedures and some examples of cases. So before I start, I want to bring your attention to this quote from Dr. McGilvray. Dr. McGilvray was a past president of the Society of Thoracic Surgeons. He mentioned that the management of heart disease has evolved dramatically over the past 2 decades. The surgical treatment option must be tailored to each patient in order to optimize the benefits and minimize the risks of detrimental effects. Having said this, I want to make sure that everybody is aware that not everybody is a candidate for minimal invasive or robotic operation. Patient selection is extremely important. If we go historically, in 1957, Dr. Lillehei performed the first mitral valve repair and was done through a right thoracotomy approach, and his axis was cannulating the femoral artery and the femoral vein. Over the course of the next 35 years, the standard approach for any operation, specifically open heart operation, has been the sternotomy. 1990, Dr. Benetti started the limited anterior thoracotomy for LAD bypass, and that was really the evolution, the start of minimally invasive surgery, and how he eventually went into more or less invasive techniques, better image guidance, better, you can say, endoscopic assistance that allowed us to be able to get to the scope of minimal invasive operations. In the last 2 decades, this has changed quite significantly to the point that has shown to improve survival and quicker return to regular work. The most important thing is to be able to allow us to have all the degrees of freedom. Here, one of the pioneers of cardiac robotics is Dr. Randy Chitwood, who has Dr. DeBakey at the age of 97 sitting on the intuitive console for him to understand how it is. So the robotic surgery allows us to give us all the digital interface we have between our hands and actual, basically, the end effectors, which are the instruments that which the patient is being operated on. The reason why we make big incisions is because our hands are big to get inside the cavity. So if you can get to the particular target where you're operating through small incisions and having the instrument provide all the 7 degrees of freedom we have in our hand allows us to perform the operation much more accurately. So in terms of getting to robotic surgery is almost climbing Mount Everest. As a regular, all of us start as traditional approach. It's the very comfortable base camp, and you basically move up based on the comfort level as you become more familiar with. So, and these are the different levels that's basically present. Level 1 is limited incision. Level 2 is videoscopic assistance. Level 3 specifically only video directed, smaller incision. And eventually when to get to the top, and that's when it's all what we call port access robotic operation. And these are the levels that you need to get in terms of being able to eventually become comfortable with robotic operations. Now, the benefit of this, the benefit has been stated by Dr. Pascas in his very amazing lectures that he had to us about avoiding the morbidity that's associated with our cardiac operations, such as sternotomy, and if you're avoiding manipulating the aorta, and also if you can avoid the heart-lung machine in some off-pump procedures. Patients improve better, improve rapidly, and they accept operations better. And this economically becomes advantageous because we'll eventually reduce the length of the operation, not in your learning stages, but as you become more proficient with the operation. It reduces the infection rate. We talked about at lunchtime, deep sternal infections or superficial. Overall, we all know that thoracotomy incisions very, very rarely get infected. And if they get infected, it's not such an unbelievable complication. So again, these things are all very beneficial. So robotic assisted cardiac surgery has evolved, as I said, as this was introduced back in 1997, 1998, when the first Intuitive became available. And it's shown that the intervention allows us to be able to provide much better visualization and provide precise movement in terms of the spaces that we operate on. And if you look at the track by which we started, sternotomy, mini hemisternotomy, mini thoracotomy, video-assisted procedures, and then eventually robotics. And again, the main thing is to reduce the morbidity associated with the operations we perform. So establishing a successful robotic cardiac program, the fundamental factor that's essential for this particular achievement, number one, as I mentioned already, is patient selection. I think patient selection is extremely important in terms of being able to make sure you start with less challenging patients, and as your experience becomes better, you go to more complex patients. Second, it's a dedicated team. Teamwork is extremely important here. And this is a typical example of a heart team where you have the patient in the center of this particular type of, you can say, way by which things are being managed. And you have all the different disciplines of surgery, specifically with cardiac operation, involved with the care of the patient. And then institutional support. It's extremely important to make sure that you have the support of the institution to be able to provide the needs you have as a team, to provide in terms of the resources for you to deliver what you're supposed to deliver. And that means you can make sure, because it's not only technical aspect, it's the non-technical skills of the team, delineate specific tasks, and also making sure that every time you debrief to make sure the next case is done better. So in terms of the team support, becomes once you add a robot into a very already, you can say, busy operating theater, it adds further complexity to the operation. That's why it's very important to have specific checklists and roles for every individual in the room. As you can see here, you've got a robot there, you've got the perfusionist, you've got the scrub nurse, you've got the circulating nurse, you've got the console surgeon. So it becomes more complicated than what the regular operating rooms look like. So the institutions that want to implement this, it would be advantageous for them to have experience with minimal invasive procedures prior to proceeding with robotic operations. And then prior to the onset of the robotic, you have, exactly as I mentioned it, all these different levels of the hospital, you can say, governance need to have endorsement and agree that you would like to proceed with establishing a robotic program. And that you can see from the hospital CEO, department chair, administrative staff, the surgeons, anesthesiologists, perfusionists, surgical trainees, interventionists, advanced basically practice practitioners, operating room nurses, and of course, other OR staff. It's extremely important for them to all be on board with that. You need to have adequate time on the OR. Some institutions, the robot is shared by numerous disciplines. And sometimes you can't get access to the robot for every like 2 months or 3 months. You can't have a very successful program if your access to the robot is limited. And of course, you need to have the proper infrastructure to have proper ideas and feedback shared. And of course, all these stuff can be done these days now. There are all these independent surgical robotic training companies that what they do is they come and they train the team and allow the proper team dynamics. Such company is Minimal Invasive Solution. I had the experience of working with them when I started the program in Sacramento at UC Davis, where the individuals come and they put you through a profound training simulation, starting with the extracardiac program, with intracardiac programs, allows proper benchmarks to be established before you move on to do your first live case. And this is an example how you start a clinical pathway and you basically progress through different parts of training and then different levels by which you can get into an advanced, you can say, level before you proceed in doing your first live case. So to start the training, the most important thing, you have the first robotic module training performed. That is basically for all team members to be introduced to the way the robotic system works. And that means become familiar with the docking of the robot, the instrument exchange, and the key safety features involved with it. Because when you add such a technology into the operative field, into the operation, it becomes actually potentially also safety issues, and you need to have all those things put into account. Surgeons, they need to complete an online training module that's set out by basically intuitive, and then the technical skills on the robotic console with different simulation. On the console, there's a simulator, and you can go do different simulation to become familiar how to use the instruments, where the clutches, where the different just like learning how to drive another car, everything, you need to become familiar with that. And that allows you to be able to have the basic skills necessary. And of course, the most important thing is the basic principles of surgery. Know the pertinent anatomy well, understand and be familiar with the open operation, like for example, coronary bypass, whether it's on pump or off pump, and also for the structural heart procedures, know the anatomy and the basic principles behind that. And you have to be familiar with the robotic surgical platform. And I think that the most important thing is, as I said, the team, you have now 2 surgeons, or 2 individuals. You have the console surgeon and the bedside surgeon, and the proper communication with them is very important, almost like being in the cockpit of an airplane. So if you look at the way we divide for robotic surgery, it's always better to start with the extracardiac program, the extracardiac procedures. Those are procedures done on the surface of the heart. For example, is coronary bypass operations, or you can say epicardial type of procedures that you do, thymectomies, things that doesn't require intracardiac access to the heart. And then once you become proficient with that, you move on to the intracardiac procedures, which is the different valve operations, whether aortic, mitral, tricuspid, ASD closures, or removal of masses such as myxomas, which of course that becomes very much advantageous because of the amazing visualization you have with the robot. So you do different simulations. Simulation can be done as dry simulation models, for example, structural heart surgery, and that by creating some kind of a simulation model using this lifelike biological tissues, which I will show some pictures of. Unfortunately, for the IT harvest, we do not really have a suitable dry simulation. The simulations that have existed through different companies have not yet been able to create one for internal thoracic artery harvest. So the way to do that is you have to utilize fresh animal models in the wet lab, such as porcine, a model, or you can use a calf model, depending different models are in terms of utilizing to harvest the internal thoracic artery. Of course, cadaver models is always beneficial and it's recommended before proceeding on to your live case. And of course, you start first with becoming expert in how to put the port placements and then eventually go on to the next level, which would be harvesting the internal thoracic artery before you move on to the more complex procedures. And these are some examples of wet lab. This is looking at a CAV model, how you take the way the ports are situated for a regular operation for harvesting the internal thoracic artery to how you do it in you can say in a CAV model to be able to get the practice before you move on to live cases. So for the team training, the one particular procedure is very good to do is the mitral valve. Mitral valve, as we know, it's a very complex procedure. And therefore, because of its complexity, is very important if you want to train not only specifically how to perform the procedures, but you can say the different choreography required between the team members to deliver it. And this is why, for this specific thing, it's important to emphasize not only the technical aspect of the procedure, but the non-technical aspect in terms of communication within the team members and making sure that the training encompasses adequate amount of educational efficiency and clinical time and everything that requires to make sure that the team becomes very comfortable delivering the procedure. And the way we do this, as I mentioned, is we use a high vitality patient simulator, and this is a bio tissue type of a mitral valve model that we use. Is from the Life Lab. It's very, you can buy this, and these are great because you store it in saline and you take it out, and it has all the complexities of all the mitral valve that has in terms of the subvalvular apparatus. And then you take that and are able to put it inside a thoracic cavity. As you can see, this is how we did it. We put it inside the thoracic cavity. And then once inside a thoracic cavity cage model, you then deliver whatever pathologies that you want to do, whether you want to do a resection, all the different complexities it is. And the most important thing is not only to set that up, is to have all the team members involved with it. So what we do is we bring all the disciplines together, set it up, the cardiac surgeons, perfusionists, anesthesiologists, cardiac OR nurses, and also the OR equipment specialists, which to troubleshoot with the aspect of the robot. And all these are put together, and we simulate this particular thing several times to be able to become proficient before you can move on to your live cases. So specifically, before we did our first live case, when I first moved to Sacramento, we did over 33 simulations on the weekend. So the whole team would come in, it's dedication. We did over 82 hours of simulation, docking the robot, doing valvuloplasty, annuloplasty, and also atriotomy closures. And we needed to make sure that the time is good, because one of the things when you move on from conventional surgery to minimally invasive surgery to robotic surgery is the time of the operation, as you become more familiar with it, goes up. Your pump time goes up, your cross clamp time goes up. And this is why it's very important to have benchmark before you think that the team is ready to basically advance from a simulation into a live case. And we timed everything. We timed all these, and we wanted to make sure that the time decrease was going down. And this is why that consulting company does that. They have benchmarks in terms of other teams that they have trained, and they want to make sure that through these different steps of the procedure, you meet all those milestones. And then after every simulation, we did debriefing with different members of the team, how things could be improved, where were they that basically the time could be done. So debriefing is extremely critical to be able to make sure that all team members learn from every simulation. So each team member were able to understand where the positive aspect, what area needs to be improved, and to be able to, for the next procedure, to improve those aspects. Based on this, then adjustments were made in terms of how you can become more efficient and how you'll be able to improve doing a particular type of task before we have moved on to our live cases. So when we eventually were ready to move to the live case, we made sure that at least we have met the criteria and that we had basically had done better or at the same thing as numerous other basically programs who were doing the training before we moved on to become independent and proceeded. And that aspect of it is, again, the robotic procedures are divided into 3 different levels. Level 1, which is the early learning curve, is the internal thoracic harvesting, the pericardial window, left ventricular lead placement are all on the surface of the heart, which is called extracardiac. And then level 2, level 3 are intracardiac procedures, which requires basically more complex work. And that's why advancement should be completing level 1 before you move on to level 2 and level 3. And mitral valve operations or aortic operations are generally aortic valve procedures considered level 3 training. So an example of extracardiac procedures is exactly how you go from an op cap to a non-sternotomy cap to a T cap, and indications again to avoid the potential complication in high-risk patients. For example, if you look at this patient had a BMI of over 50, and to do this procedure, using regular mixed procedures, it would be extremely challenging. And the mortality potentially would be 200% because both the patient and the surgeon would not survive the surgery. So therefore, with the robot, if you have such a big, difficult body habitus, because you can everything be done with robotic assistance, you can achieve that. And this is an example I can give you of internal mammary harvesting. You can both do as a pedicle, patient's head situated here, patient's feet are situated here. This is a phrenic nerve, single lung ventilation. And we go on, I think you already saw the video from Dr. Puskis. This is again being done as a pedicle. You can do as a pedicle, you can skeletonize whatever the team would like to do, depending on the comfort and whatever the team, usually you can say preferences. You can see we're doing a pedicle harvesting of the internal thoracic artery. Right over here is doing a skeletonizing technique. We use very, very nice fine shear scissors that are monopolar scissors with a bipolar microforceps. For the intracardiac, as I said, you can do valve procedures, AST procedures, removal of masses. And again, the complexity is added is you have got to go on pump. So you got to do the cannulation strategies, pump time is important, cardiac arrest time is important, and the relationship and the complexity of the cardiac procedures and the cardiac structures. As you can see, these are pictures of it. This is how we usually do. We do a soft tissue retractor to do that. This is an example of a mitral valve procedure. And where the heart is arrested at this stage. We go away, we enter the atrium. We're putting neocortex cords. The left atrial retractor allows me to get beautiful exposure to the papillary muscles. This is a patient with P2 prolapse, and we're putting Gore-Tex cords into place. Again, this is, you see the choreography. There's bedside surgeon to do the tying, and the console surgeon does all the suturing. This is tied, and then the band is going in place. We utilize, again, technology of Coronary. Coronary, again, reduces the length of, you can say, cardiopulmonary bypass time, a pump time, because you can basically kind of do sutures and tying without having to actually do tying. And then the mitral valve is repaired. This is an example of a simple repair of a mitral valve. This is now removal of a myxoma from the left atrium. Again, the view is so nice. You make a very small incision of the left atrium to get into it. You go in, and this is a relatively large size myxoma. That's basically the anchor right of the septum. There is a myxoma being removed. Again, with robotic assistance, you have beautiful visualization. This is a very interesting case. Once our team had reached a level that we were very comfortable in doing operations, I got a phone call from our electrophysiologist that they had just attempted to insert a pacer lead on an 89-year-old patient who was on chronic steroid because of rheumatoid arthritis, extremely fragile lady, very small, and they think that they perforated the atrium, and they wanted us to take the patient to the operating room. So I knew if I did a conventional operation and the patient would never leave the hospital. So I said, you know what? Interestingly, we had just finished the robotic case, and I said, why don't we bring the patient? I talked to my anesthesiologist, talked to the team. I said, we'll do single lung ventilation, and we just put a scope in, see whether it's doable. So we put a scope in, that's exactly what we saw, the perforation in the atrium. So I'm going to show you this video. So there it is. As you can see, the lead on through the right atrium. put a purse string. You couldn't do this with regular instruments because you don't have the ability of all the degrees of freedom. So we went ahead, I put a purse string around where the rupture was through the right atrium. This is on beating heart through all endoscopic port incisions. And then I wanted to make sure that we have adequate seal before I had my electrophysiology colleague who was in the room to pull the lead. So once I had all my sutures in, as I was basically pulling it, the lead was pulled, and I just went ahead and did my ties, and I was able to do that. So this patient left the hospital the next day. If I would have done a conventional operation on this patient, but again, what the robot allows you to do is gives you all the degrees of freedom for you able to do the pronation that you need to do to put the proper stitches in without tearing the tissue. Again, this patient was on chronic steroids. So in conclusion, I think robotic cardiac surgery has drastically changed the clinical practice of cardiac surgery. Patients benefit significantly because they're able to return back to their pre-surgical activities. And while the learning curve for implementing a robotic cardiac surgery program may initially be relatively steep and will be quite daunting, however, with simulation and proper team training, this can be very easily achieved in a very safe manner. So the recommendations to have a successful robotic cardiac surgery program is you need to have done, before the team gets good autonomy without having been comfort, about between 30 to 45 cases. And then the recommendations to do at least 2 cases per month to be proficient at it, and you perform a minimum of 20 cases per year. I think this is what's recommended by numerous societies in terms to have a successful team that are able to continue to progress in that particular field. So I think that robotic cardiac surgery is here to complement rather than compete with conventional procedures. The way you look at it is you need a dedicated team, and it provides you another tool as another instrument for the cardiac team to use to be able to provide the care for such complex patients. So this is the team that we work very closely together. As you can see, involves all the disciplines that I mentioned: anesthesia, cardiac surgery, OR nurses, perfusionists, to be able to deliver that. I close by saying this statement by Dr. Starzl, who did the first liver transplant, says, "What was inconceivable yesterday and barely achievable today will become a commonplace tomorrow." Thank you very much for your. Yes, I can maybe do the next talk, and then we can have some questions. Definitely, no problem. Let me just go on to the next one. Okay, my next talk, I was asked by Dr. Yam to talk about the current status of robotic CABG, mixed CABG, and TCAP. I'm not going to put too much emphasis on mixed CABG because I have my colleague, Dr. Kikuchi, who's an amazing speaker and one of the experts in mixed CABG to provide us. I will put more emphasis on the evolution of robotic CABG where we are. As you can see, there is the IMA getting filled up. There it is. I have a very amazing resident that does a lot of these things for me, so help me with that. So again, I already talked about my disclosures. So this is the objective. We want to talk the evolution of how robotic CABG came into fruition, preoperative workup that we talked about it already, a lot of my previous esteemed speakers talking, and the classification of different cases, procedural steps, and then I think Dr. Puska has provided a very elegant talk on hybrid procedures. We do that quite routinely, and I'm just going to provide some comparisons data. So this is the evolution. I kind of presented it before we started in terms of the up cap, then the non-sternotomy CABG, then eventually the goal would be to go a totally endoscopic CABG. We're still far away from it because we don't have all, you can say, the congruent technology to allow us to get there. And if you look at this platform of surgical coronary revascularization, you start with the arrested heart, which is conventional surgery. You go to smaller incision, which is mixed. And then at the same time, you do the beating heart, which is the up cap. you get to something called a multivessel bypasses through small thoracotomy or mixed cabbage multivessel bypass. And then eventually you go to the closed chest approaches, which could be either arrested heart totally endoscopic or the beating heart totally endoscopic. And you allow full revascularization by incorporating these technologies along with the hybrid. This allows you to achieve what you want. The way we do it is when we find a patient at our combined rounds with our cardiology colleagues that's suitable for basic robotic assisted cabbage, patients basically undergo this minimal invasive or robotic ITA harvesting. And then based on the way they were stratified, they either go into a multi-vessel cabbage to a small thoracotomy or through a totally endoscopic cabbage or towards off-pump cabbage, depending on what is the best for the patient. So we don't have a postage stamp. We triage the patient based on what is their best need is. And again, this is done as a team approach. It's team. We have weekly discussions about the way each patient's revascularization should be done if we consider doing a minimal invasive approach. So robotic cabbage basically is an off-pump or can be beating heart, depending on the comfort measures. There's beating heart cabbage, and use a robot as an instrument to allow you to perform the procedures more accurately, such as harvesting the internal thoracic artery. And within a robot, you can very easily do a bilateral ITA harvesting, as Dr. Pasquez alluded in his talk. And of course, you can achieve that either by also using a pump-assisted approach if you want, and then you can complement that with a hybrid approach. So pre-RF workup, we put a lot of emphasis on that before we basically move on to see what is basically the step we're going to take. The first step is every patient gets pulmonary function testing. The pulmonary function testing allows us to know, will the patient tolerate single lung ventilation? Single lung ventilation for these approaches are extremely important. A lot of these patients are smokers. They have bad chronic obstructive pulmonary disease. And if their FE1 FVC ratio is less than 50%, there's very high likelihood they're not going to tolerate single lung ventilation because their CO2 starts to go up, their oxygenation reduces, and you're posing more risk to the patient. So we know right away, based on the pulmonary function testing, are they going to be able to tolerate this procedure? Next, with angiography, we want to make sure that the patient's vessels are suitable for this approach. And if our cardiology colleagues can also do selective catheterization of the left internal thoracic artery, make sure the left internal thoracic artery is suitable, it doesn't have any, you can say, surprising pathology in it, they'll do that. If not, then we use the CT scan, where we use to make sure we've got the adequate space in the patient, we've got normal position of the heart, is the heart in the location where it's not going to allow us to get access to the target, and also if there's any complicating pathologies. So for the CT scans, the way we do is we look at the anterior posterior measurement and the transverse diameter. And those two measurements, we divide them, we make a ratio of AP over transverse. If that ratio is greater than 0.45, the procedure will become challenging. So if somebody's starting on their learning curve, my recommendation is to choose candidates who have a bigger, you can say, AP diameter compared to transverse to be able to allow it to be successful. And then we look at the subclavian artery pathology. If there's any plaques or anything like that, for example, as you can see right here, this patient has got complete total occlusion of the internal thoracic artery on the left side. So if you don't know that and you go and harvest the internal thoracic artery endoscopically, and then suddenly there's no flow in it, the first thing you think of is engine. But it's good for you to have this information. So that's why CTA and in terms of CT preoperatively allows us to achieve that. So you can see here, this one has got a significant amount of plaques. You have to proceed with caution. So these are information to have before that. Now, again, patient selection is key to make sure that you're choosing the right patient to perform that. Another thing is, I think this information was brought up by Dr. Chang in terms of the LAD identification. A lot of times we go in it and in a closed chest approach, you open up and there's complete fat and muscle everywhere. You don't have a clue where the LAD is. But this CT scan allows us to understand what pathology we're dealing with in terms of intramyocardial location, intra-adipose location, and the presence of pericardial fat. So right here, this is a very good example. You see how the patient is intramyocardial in this location here and allows you that it comes out later on. So if you do an internal thoracic artery harvesting and then you're planning to do your mini and anterior incision to get access to the LAD, you know that you have to go into that intercostal space to get access to the LAD. So the CT scan is very beneficial there. In addition, here, as you can see, the calcification of the LAD. You don't want to go and produce your vessel somewhere where you're bypassed, where there's significant calcification present. So that's why, again, the CT scan and looking, this is all cardiac gated, because you don't want to have significant amount of artifact, allows you to be able to determine this particular image. As you can see, calcification and how you can avoid it. And as you can see right here, this allowed us to know where to do our bypass. This is a CT angio post, so that we can see when the IMA is anastomosed to the LAD, distal to where the CT can of these calcifications are present. And that allows us, again, to have proper planning. The way the operator setup is, these patients very easily get hypothermic if you do an off pump. So we always use, number one, a warming blanket to keep them warm. And second, for pain control, we've come up with some kind of a pain control strategy with our anesthesiology colleagues. Patients either get an intra-paravertebral block or an intrathecal block that give them a very good pain control afterwards, because this kind of procedure sometimes can be more painful the first 24, 36 hours, and then eventually becomes better. So this is why it's important to get very good pain control the first 24, 48 hours. They always have a defibrillator pad, warming blankets, and always we use carbon dioxide insufflation to create a working space inside the chest cavity. In laparoscopic operation, the abdomen can be inflated very much. In chest, it cannot, because you've got the thoracic cavity that produces the boundaries that doesn't allow you to increase. So it's very critical to have the proper CT scan to see you've got the proper spacing. So you know with CO2 insufflation, single lung ventilation, you have the space you need. So the positioning of the patient's positioned basically supine. We put a roll under the left side, get the left shoulder to come down, as you can see in that picture. The roll is put underneath. And then we put the camera port always in the fourth or fifth intercostal space. Then above the anterior axillary line, we put our other ports. Usually the second and third inner space is for one working port, and the sixth or seventh inner port is for the other working ports. And it's very important to have these intercostal ports separated from each other with at least a minimum of 10 centimeters, because prevents collisions of the instruments externally, and then allows you to have the cone you need, which is triangular, because that's exactly the camera port is the span of your camera that allows you to have the entire span of the chest to be able to do your dissections. So the way we harvest either the IMA or IMA on the right IMA. We open the pericardium, we locate where it is. I'll have a little video showing this. And then if we don't do totally endoscopic, but these days and age, totally endoscopic is not possible. I'll explain to you why it's becoming very difficult because of lack of stabilization. And we perform the anastomosis under direct vision. These are some pictures of single vessel with the stabilizer being brought in. We use an octopus nouveau stabilizer, as has been already shown in the exhibition hall. We've gone through all the different, you can say, generations of the octopus stabilizer, the NS, the nouveau, and also the totally endoscopic one, which we use initially for our totally endoscopic. This is exactly how it is, our port spaces, and then how we go, we make a small incision with the soft tissue retractor allows us to get exposure. I want to talk about totally endoscopic coronary bypass. We used as I said, the conduit technology preventing us to achieve what we want to achieve in this technology. And number one is because of lack of stabilization to do an off-pump procedure. So Intuitive came with a Da Vinci EndoWrist stabilizer, and this allowed us to do a lot of the totally endoscopic bypass. Unfortunately, due to lack of support that Intuitive had towards cardiac surgery, this instrument was withdrawn from the market. So the XI system does not have the stabilizer. The SI system had it, but they stopped making it. Now, Intuitive has promised the cardiac surgeons that in the platform of the Da Vinci 5, they will have a cardiac stabilizer in order to enable us to do beating heart, closed chest bypass. I can give you an example. This is the video of how we do it. You see the stabilizers brought in. This is the left anterior descending coronary artery. This is all totally endoscopic. We go ahead, we put our silastic snares to basically have hemostasis. We open up, and there it is. This is an 8-0 pronova suture, which is 8 centimeters long. And that's how we're able to perform our totally endoscopic anastomosis. And those are all what we call the black diamond, very fine forceps to perform that. Now, this is not reproducible by everyone. So as Dr. Puskas mentioned, what allows us to be able to get where we are with totally endoscopic is anastomotic automated connectors. And then we used to have a lot of these in the past technology, but unfortunately, a lot of it was taken away from us. These are the coalescent clips, which allows you to do an interrupted anastomosis. You put the suture through it, and then once the clip has gone through it, all you do is you crimp it and you form a knot there. And this allows you to do interrupted anastomoses. I started to use this technology back in 2007. Unfortunately, this technology was purchased by Medtronic and then was shelved and is gone. It's not present. So we don't have access to this. This was called coalescent clips. Now, this technology here was by Cardica. It's a stapling device. You make a small arteriotomy in the vessel. The stapler has been loaded with the internal mammary artery. The anvil goes into your arteriotomy. The stapler comes down. That's the internal mammary artery loaded on it. And staples gets basically fired in less than 10 seconds, is brought out. And then what happens is that arteriotomy site, which you already put a pursing suture in it, is closed. This technology was utilized by my colleague, Dr. Sam Balke, more than anybody else. And he was doing it routinely. Unfortunately, his technology was purchased by Debron and was shelved. So we lost this technology again. So unfortunately, we didn't have that. So now we're talking about future. Luckily, we've been successful enough to be able to work with some of our colleagues in Europe, specifically the University of Utrecht. This is a good one.
Using the three-step Opticon bypass system. This remote-controlled anastomotic device is equipped with a delicate stapling head. The device is specifically sized to accommodate all target vessel diameters, down to 1.3 millimeters. It is reloadable with matching connector halves, one for the bypass graft side and one for the coronary artery. The connector halves are positioned almost entirely outside the vessel and boast an ultra-thin design near the anastomotic orifice of only 1/10 of a millimeter to minimize metal exposure to the bloodstream. The deployment follows a clear step-by-step process. In step 1, the applicator is introduced into the internal mammary artery through a previously made 3 millimeter vessel incision. Activation of the applicator first expands the stapling head, ensuring precise tissue alignment, and subsequently clamps the vessel wall by bending 12 fine staples. In step 2, the same procedure is repeated on the coronary artery, in this case to create a jump graft to an obtuse marginal branch. The applicator's expansion upon activation of the device is once more evident, aiding in the accurate positioning of the vessel walls for receiving the staples. A visual inspection through the orifice of each connector half now offers checking the patency. In step 3, the anastomosis is completed by snapping the connectors together with a one-way clip mechanism. In this simulation, the mammary artery is subsequently pressurized with saline up to 250 millimeter mercury, demonstrating satisfactory watertight integrity. To visualize the interior, the graft has been longitudinally cut open. The very thin metal rim is distinctly visible, along with the microstaple.
So this technology is still in the experimental phase. I was fortunate enough to do this lab using the Da Vinci in experimenting with that with the crew from University of Utrecht. And I think that this technology, along with other ones that could potentially develop, are going to be the future. So the advantages of minimal invasive robotic surgery is I just want to show you how advantageous it is in terms of ICU stay and the length of stay in the hospital. Does this laser printer work? Doesn't, I guess. On. Oh yeah, there it is. No, it doesn't work. If you look at the mean ICU stay, You've got the op cap, which is in dark red, dark brown, and then in pink and yellow are the different robotic systems. We used the Da Vinci system, and also we used way back when we were utilizing the computer motion. If you look in the mean ICU stay, significantly reduced with the robotic systems, and the mean hospital stay was exactly divided in half. There's a patient that underwent single vessel robotic CABG versus an op cap in sternotomy. So this is the advantage in terms of length of stay in the hospital, how it's reduced, and how you can go from that incision to those incisions, and how patients can recover much better. And of course, the ERAS, most recently we came up where we did about 166 patients. We avoided the ICU completely. Patients got extubated in the operating room, went to the recovery room. They stayed in the recovery room for 4 hours, transferred to the regular ward, telemetry ward. They were able to be discharged post-operative day 2. Again, these are some amazing how things can be done. So I'm just going to touch about, we talked about the hybrid. Hybrid is not preventing working in silos where before cardiologists did the PCI and the CABG, but this is all teamwork now, all right? Teamwork and not working in silos is to be able to work in teamwork. I just have to add a bit of humor. This is a good example of why a hybrid is working such a high-risk case. This patient came to us with a 68-year-old, came with acute coronary syndrome, had a history of stroke, hypertension, renal insufficiency, severe aortic calcification, circular. And look at the left main disease, ejection fraction of 20%. So this patient, we decided to do as what Dr. Pasca has explained. We did a robotic Lima to LAD on this patient, and then patient underwent the PCI of the left main and able to leave the hospital on third postoperative day. I'm not going to go over the video again. I'm just going to discuss about hybrid op-cap. We looked at comparing hybrid to op-cap. So we looked at 216 patients that were done off-pump CABG versus 147 robotic-assisted hybrid procedures. And we did propensity matching for them to be matched appropriately with the proper preoperative, you can say, parameters. And then we looked at the result. If you look at the result, I'm going to circling the effective ones. If you look at basically the first one is the amount of time of mechanical ventilation, the group in the hybrid, much less mechanical ventilation. Second, if you look at it, is basically reintervention. Your intervention in this situation favored the off-pump group. The off-pump group had zero intervention, but the hybrid group definitely required some intervention afterwards because of stent problems that, of course, continue to be. And then if we looked at further result, again, this is an off-pump group in terms of their hospital length of stay was significantly less for the hybrid group. And we looked at the freedom from angina. Afterwards, it was much better again in the hybrid group compared to the regular op-cap. Then we did, okay, let's compare them to the unpumped CABG versus the regular hybrid robotic CABGs. And we did 682 in the CABG and 147 robotic assisted. Again, we did the typical propensity matching with the weighted thing. These are the preoperative parameters. And in terms of the graft type, this was the distribution where the grafts were done and what conduits was used. LAD territory, circumflex, this is for the group that underwent regular CABG. And then this is the group that underwent stenting. Stenting was done in the RCA and circumflex territories. When we looked at the results again, so in terms of the procedures that were performed, any transfusion, muscle transfusion was performed in the hybrid group. And also in terms of death, much less death, there was leading mortalities in the hybrid group. And then length of stay in the hospital was significantly reduced in the hybrid group. Then finally, freedom from angina again was better in the hybrid group. So the most important thing with robotic assisted CABG training is to make sure you do the proper intraoperative flow measurements, whether it's basically transit time ultrasound or fluorescent imaging, or even angiography of access to that. And then postoperative was shown by our esteemed colleague that talked about his postoperative CTAs in terms of angiography with CTAs. And of course, proper clinical follow-up and proper, you can say, data collection. So I think robotic CABG and hybrid has got a significant prosperous future as further technologies develop, allows us to have a better tool, especially with hybrid congregation for proper, you can say, patient benefits and to provide less risk for the patients. But of course, it's a methodical approach, needs a dedicated team. Patient selection is extremely important, and you got to make sure you maximize the efficacy and also limit intraoperative surprises by doing the proper preoperative workup. Again, I'll close by saying that when one door closes, another door opens, but we so often look so long and so regretfully upon the closed doors that we do not see the ones that are open for us. Thank you again. And then before I end, I want to invite everybody to the International Society of Minimally Invasive Cardiac Surgery. And members who are not members, I will invite you to be members. This meeting is in Istanbul this year, Turkey, from May 28th to May 31. Please join us to exchange ideas to better improve this technology. Thank you very much.
Thank you, Dr. Kie, for your lecture. So we move on to the question and answer portion. We start off with Dr. Andin.
The question is, when you were starting your robotic surgery, what was your greatest roadblock that you met, and how did you manage it? My second would be on your second lecture, which is when you do hybrid coronary bypass, which do you do first, the PCI or the CABG? Thank you.
Thank you very much for your questions. Excellent questions. To answer your first question, the biggest roadblock when I was starting was access to the robot. I shared the robot with urology, shared the robot with general surgery, and it was very difficult for me to make sure. So we had to come up with kind of a strategy that this day was cardiac access, this day with this access, this access. So because the more you do, the more the team will become comfortable, the more that better the anesthesiologist will get at it, the better the operating room nurses would come at it, and also the perfusionists. So the number one obstacle when we started was basically getting access to the robot. And then, of course, patient selection. I very, very recommend start with low-risk patients. For your second question, that's a very good question in terms of the strategy by which phase you do first, the PCI first or the CABG first. We like to do the CABG first because patients are not on dual antiplatelet therapy. If they do the PCI first, patients come in with dual antiplatelet therapy, and generally they have a higher risk of bleeding, even though you're doing less invasively, but they still have a higher risk of bleeding. So we got two strategies. If these are elective cases, and we discuss it at our rounds, we first do the CABG, and during the same hospital stay, they basically then undergo their PCI. But if patient comes in with a STEMI or a non-STEMI of a non-LAD vessel and they got to get stented, they get stented. And if they're stable, we send them home, bring them back in 6 weeks after their stent has become a bit stabilized. We'll hold the Plavix for 3 days. And when they're just on aspirin and just off Plavix for 3 days, we do the surgical revascularization.
Thank you. Dr. Royce?
Bob, I just had a question about the anesthetic side, or rather the pain relief side. We've been using an erectus spinae pain block, which is just in the intramuscular plane, and it's very easy to put in. And of course, you can use a catheter in there for days if you want. I was just wondering if your anesthesiologists have considered that as an alternative to intrathecal or other.
Yeah, that's a very good question. That is a bit positional, you can say, dependent upon the individual that's performing it. So on occasions, we would get excellent success with the insertion of that going in the right plane and putting the catheter in and the injection. And sometimes it didn't work. We found that the intrathecal block or a paravertebral block for them was much more successful in terms of being to be reproducible and provide better things. But the interscaling block, we have utilized it as well. I think works very well when it's properly placed and properly done. Correct.
Any other questions? Dr. Francis?
Dr. Kia, regarding the preoperative imaging, the CT scan, the sagittal slice you showed had, in terms of the calcifications, it didn't seem to occlude the whole lumen or anything. Does that, I mean, if you have calcification there at the root of the subclavian, are you concerned with the rest of the IMA? I was just wondering what's your cutoff for saying let's not use the IMA anymore?
These patients all had high-grade LAD stenosis. That CT scan was not showing where the stenosis was, showing how diffusely calcified the vessel was, and giving you the proper target location to do your anastomosis. So majority of these patients had high-grade lesions, so we had no concern that the Lima was going to have any problems in terms of longevity, in terms of durability. The purpose of that CT scan showing the sagittal image was to see exactly where the calcium deposits were and to avoid putting your anastomosis there to go further. Because the way we do it is we decide, is it the fourth space or the fifth space we're going to perform anastomosis? And based on that, based on the CT scan, we see, okay, it's better to go in the fifth space. And that's where we do the anastomosis.
More in the inflow, because I think you also showed a slide there for the root of the subclavian that there was some calcification there. I was just wondering what's your cutoff to say that maybe the inflow from the subclavian might not be that good.
Yeah, well, if your plaque is obstructing the entire lumen, and I don't think there's any ways by which you say, but the second slide that I show, there was still patency coming through the internal thoracic artery. And you could, on the CT scan, you could also see there's contrast in the internal thoracic artery, because we always give contrast to these patients unless they've got reasons because of the renal function not to get contrast. But because of the fact that there was contrast and showed that the ITA was adequate flow in it, we utilized it. But if there's any things from the CT that shows that that is a danger, we would be very cautious.
Thank you. And because I at least I can, for myself, I don't think I've ever looked at the inflow from the subclavian in a CT scan. We request for CT scans in some patients, contrast enhanced CT scans, but we rarely look at the inflow from the subclavian. So thank you.
No problem. Yeah.
Thank you. Any more questions? Dr. Yam?
Yeah, Dr. Kiai, you did tell me that you do 80% of your cases minimally invasive. I was just wondering, how often do you encounter chronic post-thoracotomy pain in these patients, and how do you deal with them?
I would say probably chronic post-thoracotomy pain can happen anywhere between 10 to 15% of the time in some patients. Specifically, I found that in people that utilize their arm a lot, especially with the right-sided incision, majority of my structural heart procedures are on the right side. I remember very briskly about one of my female patients that I operated on was a teacher, and she was having significant, she had a mitral valve repair done to her right mini type of incision, and she could not raise her hand for a long time to be able to actually write on the blackboard for the student. Was an elementary school teacher. So it's around 10 to 15% of the time, and all is multifactorial. Patient positioning is important. Sometimes the way the shoulder goes down, hold on the brachial plexus. So the complexity of it, just like we want to protect the ulnar nerve, is very important to make sure you protect the shoulder, because sometimes also, especially with a robot, that right arm on the robot can push on the shoulder. They can have pain, especially big people, patients who are muscular, that shoulder becomes a problem. So those things are all very critical. Muscular people have more post-thoracotomy pain because they got more muscle. So all these things are very critical, and every step counts in terms of trying to minimize the amount of muscle you actually cut to the muscle sparing type of incision. That's like we like to do. So those things reduces that post-thoracotomy pain, but unfortunately can exist and sometimes can last for a long, long period of time.
Thank you. Any more questions from the body? If not, thank you very much, Dr. Bob Kiai. Okay, we move on to our fourth session of the day. We will talk about no-touch endoscopic vein harvesting and mixed cabbage learning through the years with Dr. Keita Kikuchi. So just a little background on Dr. Kikuchi. He graduated medicine at Santa Mariana University School of Medicine in Kanagawa, Japan. PhD also in the same institution. General surgery residency also in the same institution. Clinical fellow adult cardiac surgery, Singapore National Heart Center, Singapore. residency in the Department of Cardiovascular Surgery in St. Mariana University School of Medicine. He's currently the director and coronary program Tokyo Bay Urayasu Ichikawa Medical Center in Japan, supervisor of the Department of Cardiovascular Surgery in UI Medical Center, Japan, a visiting professor in cardiovascular surgery in Xi'an Jiatong University in China, and is also a board of directors of the International Society of Minimally Invasive Cardiac Surgery. So let us all welcome Dr. Keita Kikuchi.
Thank you very much for kind introduction. And I'm great honor to be here and to celebrate the 50 years anniversary of Philippine Heart Center. And congratulations for all. And usually this presentation about the no-touch EBS technique is Dr. Yoshino present this presentation. So today I try to do my best. But very informative and very important presentation, I think. Thank you very much. Okay, thank you very much. So I come from Tokyo Bay Ichikawa Medical Center. And so today I'd like to introduce our new techniques, no-touch endoscopic surface pain harvesting. We call it no-touch EBH. So this is my disclosure. I have no disclosure to declare. So first, let me briefly introduce our institution hospital, Tokyo Bay Medical Center, located near the Tokyo Disneyland. You guys know Tokyo Disneyland. It's actually very close to our hospital. And it's a hub for advanced cardiovascular care. We specialize in minimally invasive cardiac surgery, including mixed valve, miscavige, TAVI, and aortic surgery, among other. Despite being the modesty sized facility with 344 beds, we perform over 500 cardiovascular surgeries annually. Turning our focus to the subject at hand, the surface graft remains a vital component in coronary bypass surgery. Its advantages include availability, length, ease, harvesting, and handling. However, it's crucial to address the significant drawbacks such as reducing long-term patency and potential length wound complications associated with traditional harvesting method. It's a big issue. In ESG guidelines, endoscopic vein harvesting, EVH, is recommended to reduce wound complications, while the no-touch harvesting technique is advocated for. Just a moment. Here, both, so as you know, the endoscopic harvesting is class 2A, and no-touch with harvesting is class 2A. So both graft quality or fewer wound complications should be achieved. The no-touch SVG have a higher graft patency compared to the usual vein harvesting, and no-touch surface vein may have a long-term patency rate compared to the latter. However, its problems are wound complication and cosmetic issue. The superior surface vein trial reported the length infection occurred in 23% of patients in the no-touch surface vein graft groups. To solve these big problems, we start new techniques, no-touch endoscopic vein harvesting. Dr. Yoshino reported this in Innovation. Our no-touch EBH technique is particularly designed to preserve the historical feature of the surface vein, ensuring the integrity of the initial layer and maintaining the vasculature. By avoiding direct contact and minimize trauma during extraction, we uphold the structural and functional viability of the vein. We have demonstrated that no-touch EVH effectively preserves these critical historical features, including intimal folding and patent vasculature. So this illustration, despite the anatomy of the substance vein, which is located between the substance superficial fascia and the deep fascia, and an area known as the substance vein compartment. Our no-touch EVH technique is especially orientated toward the fascia and utilizing the Busview Hemoprobe 2 system for precious visualization of the substance vein graft. The harvesting of the SVG is meticulously performed just below the superficial structure and just above a deep fascia. Next, lateral third is dissected using a Hemoprobe 2 harvester, ensuring the preservation of the perivascular adipose tissue. The substance vein is harvested from the patient upper lips using the Busview Hemoprobe 2. The patient type is positioned as usual. Pre-operative echography is performed to ensure the substance vein is in the substance vein compartment and to inspect for any branches. A 3 centimeter skin incision is made in just above the knee through which the substance vein fascia is divided to expose the substance vein. Beneath the fat tissue, a camera scope equipment with a dissecting tip is carefully inserted just below the substance superficial fascia, taking care to preserve the perivascular connective tissue. So we do this kind of techniques to harvest no-touch EVH, but the importance is using this Busview Hemoprobe 2, which has a dissector and scissor type electrocautery, so which makes taking down the no-touch EVH easily, actually. So we do this kind of technique during harvesting no-touch EVH. But it takes a time compared to the usual EVH. Okay, now we're cutting the small branches using a harvester. Also use a CO2 during harvesting no-touch vein graft using Hemoprobe 2. Okay, so summary of procedure. Busview Hemoprobe 2 system is used for no-touch EVH. Anterior and posterior surface of vein are harvested, preserving perivascular connective tissue using Busview dissector. Lateral surface are dissected with Busview harvester, with preserving perivascular adipose tissue. And marking on anterior surface of substance vein graft are performed for the prevention of twisting of vein graft. Vein grafts are expanded with patient femoral arterial pressure for preparation before anastomosis. It's really important. We don't infuse the saline into the vein graft. This is very important.
So I'm sharing our result from the 99 cases of the no-touch EBH. And BMI was 26, A1C hemoglobin A1C was 7, and emergency case was done in 16%. And off-bone bypass was done in 76%, and miscarriage was done in 40%. And the target of SBG was RCA is 101 cases, and circumflex was 18 cases, and the diagonal was 47 cases. And average EBH technique time was 60 minutes. And graft injury was occurred in 1 cases. So this is our result, graft patency. Early patency was 98%, but not too bad actually. And wound complication was occurred in 2 cases, 2%. So we also checked 1 year patency. 1 year patency was 96%. And yeah, we also use coronary CT scan to check the 1 year patency. So discussion, this is the discussion. What is the difference compared to conventional EBH? Is the left side is conventional EBH and right side is no-touch EBH. So no-touch EBH preserve vascular and preserve intimal foldings. And what is the difference compared to the conventional EBH is adipose avoids manual expansion. This is very important, and preserve the vascular. So we can preserve endothelial function in EBH technique, no-touch EBH technique, and preserve perivascular tissue, adipose tissue. So preserve kinking, prevent kinking, and preserve or produce production, and preserve contractility. So no-touch SBG is considered to be a living graft. So it can be spasms actually during surgery. So this is the living graft can adapt to its surrounding environment. Becomes very got this good graft flow after surgery, and becomes a bit smaller, adjusting the coronary arteries. And here are some elements that improve the survival of the saphenous pain. They are not all or one, all or none, but through to influence each other little by little. We believe that achieving as many of these factors as possible in EBH is important to improve the long-term viability. So early graft patency was compared between no-touch EBH and the conventional EBH. Although there is some bias, no-touch EBH has significantly good patency, has a good patency. And in our cohort, 1 case of thrombosis occurred in sequential bypass of this of saphenous pain. They are not all. Sorry. Okay. In a cohort, 1 case of thrombosis occurred in a sequential bypass of no-touch vein graft 3 months after surgery. To prevent thrombosis, it is important to ligate no-touch vein graft after full heparinization. So before harvesting a no-touch EBH, we give a heparin, even if we just open incision. So it's very important to give a heparin. And this is our learning curve. Regarding the learning curve of these new techniques, the first 10 cases required an average of 86 minutes per procedure. It takes a long time compared to others. The subsequent 20 cases saw a reduction in time taking less than 60 minutes each. After comparing 30 cases, the surface pain graphs were consistently harvested in under 50 minutes. The image displayed surface pain harvested using a no-touch EBS technique in recent cases. As illustrated, the perivascular adipose tissue was continuously preserved like this. But now with accumulation of so much experience, education has become smoother. We are trying to pass on our skills to young trainees by harvesting together for the first five cases. We believe that no-touch EBH can be performed independently. So now our young surgeon, post-operative 5, can take down no-touch EBH. But now with a accumulation of so much experience, and this is another learning curve for surgeons handling graft torsion and kinking. It can be happen in learning curve. So these are potential risk of graft torsion. We have one case of graft torsion after surgery. So we did reopen the chest and repair the graft torsion after surgery immediately. So this is a conclusion. A novel technique of endoscopic SBH harvesting is an effective technique which had a good early patency and advantage about wound healing. Oh, thank you very much for your attention. I'm so sorry, and my English is not so much. So I also would like to invite all of you to the Istanbul for the ISMIX. Thank you very much. Yes. Can you change the slide, please? No. Please. It's okay. You can make a big, bigger one. It's okay. 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 Thank you. So this is my main presentation. How I have developed mixed cabbage. This is the background. So we can look at the less invasive cabbage. We have many procedures for less invasive cabbage, mid-cap, robotic assisted cabbage, and T-cap, TC-RAT, mixed cabbage. We have a lot. And as you know, mid-cap is basically a single bypass surgery leading to RAD. And this was reported by Dr. Carl Foley many years ago, and robotically assisted coronary bypass surgery. And this is by Bob loves this kind of surgery. And actually the theta and beta with robotic harvesting and later RAD plus hybrid or multi-vessel mixed cabbage using bilateral mammary artery to the left coronary system. And the total endoscopic coronary bypass surgery. This is actually from some bulky video. We can do this kind of TCAP in the future. And this is TC-RAT procedure. Many South Asian people love this kind of surgery with arrested heart, complete revascularization with quadriplegia, and actually lita plus vein graft or radial artery. And this is minimally invasive CABG, so-called mid-CABG, is actually off-cap by a less small thoracotomy under direct vision. I love to do this kind of surgery. So move on to the mixed CABG. Okay. This is surgical field of mixed CABG, what I do. And mixed CABG retractor is pulled cephalad and toward the left with additional crane retractor. And I did contain just some Japanese 6 bypass using bilateral mammary artery and 2 proximals using vein, and 3 mixed bypass mixed CABG using bilateral mammary artery and radial artery. So these are advantage of mixed CABG: shorter hospital stay after surgery, early return to normal activity, no deep sternal infection never happened, reduced blood transfusion, increased patient satisfaction. So I'd like to share my experience, the road to mixed CABG. Why did I become a cardiac surgeon? This is very important. Why? They joined cardiac surgery because our guides want to be a cardiac surgeon because very tough job. But another reason, I want to invent new techniques. This is my purpose, to be a cardiac surgeon. So I joined the Department of Cardiovascular Surgery in 1991. And in 1996, encounter with MidCap from Dr. Antonio Carflore. And it was very impressed to me because at that time, our senior surgeon did on-pump bypass surgery. It takes many times, 8 hours for triple bypass. So I was very disappointed of the CABG at that time, but this MidCap impressed me so much because he did one bypass with a small incision with beating heart. It was extremely impressed me. And in 1999, encounter of off-cap. Do you know this? This is the first generation of octopus. Yeah, very first one. But at that time, we couldn't do off-cap at the time. But I was a registrar of the Singapore National Heart Center in 1999. And at that time, my senior surgeon, Dr. Sriram Shankar, he's an Indian Singaporean, started off-cap with me. So I have a lot learning come from him because we do off-cap together and learn off-cap at National Heart Center, many things. So after going back to Japan, I started off-cap and started to use Harmony Scalpel from 2002. Then mixed CABG was reported by Dr. Magin, Joe Magin, and Markwell. They are my good friend now. And also very surprised and impressed me so much because only small, they did multi-vessel bypass surgery by a small left thoracotomy with a beating heart. So 2011 encounter with mixed CABG, and I also started the mixed valve then. So at the time, Medtronic asked me to go Italy, Milan, to observe a mixed CABG. At that time, Dr. Massimo Lemma was there, Italy, and I observed his surgery. And after back to Japan, I start mixed CABG in 2012. But of course, I did mid-cap actually many times, but the mixed CABG are a bit different from the mid-cap. So I recognize the difference mid-cap and mixed cabbage. Mid-cap surgical incision is very close to the sternum, but the mixed cabbage is lateral incision. And the other difference is between mid-cap and mixed cabbage, incision and ITAB harvesting, and rate harvesting, surgical field, everything are different from mixed cabbage, everything different from mid-cap. So I recognize it and I start mixed cabbage at the time. So I asked my cardiologist to refer patient with a single vessel disease for mixed cabbage. Then some cardiologist kindly sent me a patient. So I start mixed cabbage as a single bypass, as a mixed cabbage later to LAD and using harmonic scalpel in 2012. However, proximal anastomosis is recurrent for multivessel mixed cabbage. So I asked Mark how to do the proximal anastomosis. So then he came to Japan to participate in JACAS in 2012, and he taught me how to do proximal from the small left incision. But at that time, I couldn't have any YouTube channel to right. So it was very tough for me to do proximals. But I have a good anesthesiologist, so we discussed many things with a team, and we developed how to do proximal anastomosis. But at the time, heart displacement was not easy for this anastomosis. We have a lot issue to complete mixed cabbage, so we need to solve one by one, step by step. Then I had an idea to use starfish, but starfish have a big arm and it disturbs surgical field like this. So I remove arm of starfish and put the suture in the neck of the starfish. So it works really well to disperse the heart. So I present this result in ISMIX 2014. And I also published this technique in Innovation 2015. So I published many papers around 2015. But for long-term prognosis, beta should be used in mixed cabbage. At that time, the ratio was using beta in cabbage was 80%, more than 80% in my series. So I need to use bilateral mammary artery even in mixed cabbage. So I went to Bob's place. At that time, Dr. Bob Ki was in London. So I visited his place because he offered us to do some cadaver training. Then I only focus on how to approach to the right mammary artery at the time. But I recognize we can do it. So this makes me now, I think. So it was a great opportunity for me how to take, to recognize how to take down right mammary artery. Yeah, but fortunately, I used harmonic scalpel at the time, long shaft. So after going back to Japan, I started to harvest bilateral mammary artery, and it was successfully finished. So I published paper in Anastrophic Surgery, a case report, as a case report. And also, I find out a good surgical instrument. This is Signet flexible partial clamp, and this is very flexible, so we can get a good surgical fit even using doing the side by on the ascending aorta by a left small thoracotomy. And I also find out a good long shaft punch. So I report this assisted as an assisted technique for proximal anastomosis in mixed cabbage. So this is my procedure, how to use bilateral mammary artery in mixed CABG. Then usually I open a fifth intercostal space and use a thoracic retractor, and which is lift up using a crane retractor, and put the long shaft Hamlin scalpel by a metallic pot and harvesting bilateral mammary artery. Usually I take down right mammary artery first, but when I take down right mammary artery, right lung already disturbed my surgical field. So I recognize some we need to depress the right lung, use something. So I put octopus nubo stabilizer by a subzygoid small incision to depress the right lung to achieve the good surgical field beneath the sternum to access to the right mammary artery. Now you can see the right mammary artery. It's a very nice and very big one. So harmony carpet also works very well to harvest right mammary artery by a small left thoracotomy. Usually, I prefer to use right mammary artery as an in situ graft for the LAD. So now I'm taking down right proximal or right mammary artery. Usually, it takes around 30 minutes to harvest right mammary artery. And proximal, I put clips on the first intercostal lip branch. So now I pressing the ascending aorta using harmonic scalpel. So we always check ascending aorta and everything using preoperative contrast CT scan. If the ascending aorta is not very good, I don't do this kind of pressing down ascending aorta using harmonic scalpel to harvest during harvesting right mammary artery. Then sorry. Then after that, I harvest left mammary artery and opening the pericardium. Now you can see it already clearly. And open the pericardium completely to the IBC and to the distal ascending aorta. Okay. And I will do Y composite graft inside of the chest wall. This is small table and clip to stabilize the left mammary artery on the table and making a Y composite graft using bilateral mammary artery or radial artery. So it is small tips, but works really well to make a composite graft inside of the chest wall. I usually use 8 of rolling to make a composite graft. Then I tie down the 8 of rolling. Now we have a good one composite graft for the left coronary system. And making a proximal anastomosis. So lift up the distal pericardium around the ascending aorta to lift up ascending aorta towards the surgical incision. I put the two sutures to the right side of pericardium and another one suture on the left side of pericardium and retract the pulmonary artery, main pulmonary artery to the caudal direction. I try not to press the pulmonary artery to maintain the inside of the pulmonary artery, because if you press down the pulmonary artery, it causes lower blood pressure. So try not to press down pulmonary artery. Just retract the pulmonary artery like this, and dissect ascending aorta and pulmonary artery completely, and remove all fat tissue and adventitia around the ascending. So I do like this. I don't press the pulmonary artery, and remove all fat tissue and adventitia like this. This is also step-by-step approach to the ascending aorta. And put a side-winding clamp on the ascending aorta. Now you can see the ascending aorta very clearly, just below, just below the surgical incision, and mark a vein graft. This is a bit old video, so I don't for this case I don't use no touch vein graft, and make a small hole and open a little bit and punch. This is not long punch, so it's not so easy to make a hole. So you should use a long sharp punch and make a proximal anastomosis on the ascending aorta. And after making a proximals, lift up the left side pericardium and put the 3 deep pericardial sutures, so-called Lima stitch, just below the left pulmonary vein and beside the IBC. Second one, I put second one beside IBC. And third one, it actually put between them. Number 1, number 2, and number 3 between them. So these deep pericardial sutures works very well. So you can see circumflex and PDA. So you can access all territory of the coronary artery. Then I did vein graft to PDA anastomosis first, because this patient had a total occlusion of the PDA, right coronary system. So I did CTO fast technique. So you can see a PDA very clearly, even by a small incision. And make a Lima to LAD anastomosis. Put the shunt tube in and make a usual anastomosis. Oh, sorry. Sorry. So I did the 6 bypass. This is our result, and also I published paper compared to the theta and beta in mixed cabbage, and these are artists of mixed cabbage with beta at that time. And I also start to use RGA in mixed cabbage. So I report this result in 2016. And so then I had many items of mixed cabbage, multivessel, proximals, off-bone, beta, RGA. And these are our indication of mixed cabbage. I try to do mixed cabbage for good cardiac function cases, but I don't do mixed cabbage for emergency case, poor EF case, and CVF COPD case, and previous left lung surgery. And this is our strategy of cabbage. We try to do mixed cabbage as a standard procedure, but if the patient had a poor EF and emergency, we do off-cap or on-pump beating heart bypass surgery. And this is our strategy of mixed CABG, complete revascularization, multi-arterial bypass grafting based on beta, and one inflow per area and aortic surgery of pump analytic and no-touch EBH. So what the advantage of mixed CABG? Beta can be used, and almost the same graft configuration can be used as a regular, same graft can be used as a regular CABG and off cap, but we don't have any deep sternal infection. Even patient have a very severe diabetes. So I report many times about result of this kind of surgery. And I also did live surgery in Wuhan Asian Heart Hospital, which has 4,500 cases a year, a big heart center in China. And moved to work at the Wuhan Asian Heart Hospital for 2 years as a consultant surgeon. So I did many presentations in the world and the surgical guidance for mixed CABG also in the world. So this is activity in China, and I visit the Philippine Heart Center many times, and Thailand, Malaysia, and India as well, and Russia as well. But unfortunately, we cannot go Russia again. Yeah, but it's a very impressive. I was a moderator for Mark Real. It's a very impressive, and at that time, I met Dr. Carl Fiore at the Harvard Club of New York at the faculty dinner, but very surprised he recognized me at the time. So I was very happy because I believe I can do it. Yeah. So I have a lot of friends in the world, but I also progress my techniques. So we report this kind of result in JTCB technique. And we also report our result of using RGEA in mixed CABG last year in JTCBS techniques. So this is short video. We usually take down bilateral myelin and GA together, so time consuming. Using a harmonic scalpel, it's very useful. And introducing RGA into the pericardium and do GA to PDA anastomosis after this. Like this. Okay. So this is our result. We achieved analytic technique in 100% of this series, and we did total arterial revascularization in 94% in this series, and we did complete revascularization in 99% in this series. So this is our result of mixed CABG using bilateral mammary artery and GA, and we also use no-touch vein graft, and we do this kind of proximal anastomosis by a right side second intercostal space. And we also report this result in innovation. And we also do mixed CABG combination with PB isolation and left atrium appendage resection. So so far I have written about 17 articles in English. So this is really important to publish our result in the journal. And we did a live surgery in ISMIC's workshop last year. And we also finished randomized controlled trial of mixed CABG, so-called MISS trial. So Mark Rare will report this result in WATS in this year. we hope we'll get a good result of this trial. So this is the message to young guys. Do you know this? Sorry, not only man, female as well. So what people can imagine, people can surely realize. This is very important. This is my favorite words. So this is the reason why I did mix cabbage with pita. So this is from take home message for young surgeons. Be ambitious, dreams come true. And thank you again, and please come to Istanbul to join ISMIX. Thank you for your attention. Thank you very much.
Thank you very much, Dr. Kikuchi, for giving a very inspirational lecture. Especially for us young surgeons. So anyway, let's start with the question and answer for Dr. Kikuchi. Would anyone like to have a question? I would like to start off with the questions for EVH. So is there a steep learning curve for doing EVH standard and no touch EVH? Because I think some surgeons here in the body do EVH. I myself have a little experience on EVH, but the learning curve from doing it from open to EVH is very difficult. So going from EVH to standard, is it more difficult? And also, do you use only just the VASOFU? You can't use any other harvesting technique?
Yeah, actually, I did EVH many years ago, but I know steep learning curve. But now the surgical equipment is very nice. So, but you need some supervisor to start EVH. So you need to call some surgeon from Singapore or Japan or somewhere, and to start EVH. Yeah.
Okay. Thank you. Any others? Do you have questions for Dr. Kikuchi? Dr. Aventura?
Yes. So I want to find out from the audience if you know who the first one to do the gastroepithelic artery in the world was or is. Does anybody know? It was Charles Bailey and Dr. Aventura in the posterior pericardial. Yeah, that was the one I showed earlier. First gastroepithelic.
Any other questions? Okay, if none,
Okay, thank you.
Thank you very much, Dr. Kikuchi. Okay, so for our fifth session, we will talk about radial artery as a conduit, indications, outcomes, and harvest techniques, arterial graft configurations by Dr. Alistair George Royce. We'll start off with a little overview of Dr. Royce. Graduated MBBS in University of Melbourne, Australia, Fellow of General Surgery, Royal Australasian College of Surgeons, Fellow in the Cardiothoracic Surgery, Royal Australasian College of Surgeons, MD research thesis in the University of Melbourne, Australia, and Fellow Cardiac Society of Australia and New Zealand 2006. He is the Deputy Chair, Medical Advisory Committee, Melbourne Private, Australia. Previous Board Member, National Heart Foundation, Australia. Previous Board Member, Cardiac Society of Australia and New Zealand. And a Co-Director, Mobile Learning Unit, Melbourne Universal Medical School in Australia. Fields of interest are total and multiple arterial coronary bypass surgery, clinical ultrasound, and echocardiography. Let us all welcome Dr. Alistair Royce.
Thank you very much for that kind introduction, and Dr. Aventura and John Lamb for inviting me to this esteemed meeting. It really is a very great honor indeed. So radial artery and total arterial, very much an area of my interest here. Yeah. Excellent. Doesn't work. Okay. So the talk was two talks, but I thought if you guys are happy, I might just run it through in one because it kind of flows fairly easily. But the first part would just be on the outcomes and the indications for use of radial artery and arterial grafting. And then the second part, a bit more hands-on with the harvest technique and so on. Now, the assumptions when I was in Melbourne was that, and I may be wrong, but most of this audience here and those who might watch the video online don't commonly use radial artery. They might use it occasionally. Most don't, routinely or commonly practice total arterial revascularization, but most people would have an interest in this topic. And I think that most people might be open to the idea about this topic that might change their practice. And basically, this is the Achilles heel of coronary artery bypass surgery. What you see here is a piece of myocardium that's dependent on a patent saphenous vein graft that becomes diseased, stenosed or occluded, which renders this bit of myocardium acutely or chronically ischemic. That's the basic problem, fundamentally. On the other hand, the arterial grafts don't exhibit this pattern. Here is one of my lemur radial Y grafts, the lemur here, the radial here, 21 years post-operative. And what you see is a perfectly patent artery. The implication after 21 years is that this is never going to fail, unlike the vein grafts, which routinely are predicted to fail. And in PCI versus CAGs, all of the randomized studies come up with a similar theme, which is that the coronary bypass has better long-term survival and lower reintervention rates than PCI, although almost all of the CAGs arm is single mammary and vein grafts, not multiple arterial or total arterial revascularization, which would suggest it might have even been a bigger difference. Now, the ANSCATS data set, ANSCATS is Australia New Zealand Society of Cardiothoracic Surgery. The data set only goes to 2018 because of an issue with linkage to the Australian Death Registry, and they haven't been able to overcome this little hurdle. So that's as far as we've got with our data. But there are 97,000 patients in this data set, and this is the practice up to there. So it's even more so since then. But multiple arterial grafting was 47% of primary isolated CAGs. The world is about 5 to 9%. Single arterial grafting was roughly half. That's 90 to 95% for the rest of the world. And total arterial revascularization was the majority of the multiple arterial at about 30%. And the world is tenfold lower than that. Radial artery use overall for all patients was 39%, again, tenfold higher than the world average, and bilateral radial artery was 8%, and that's almost not practiced at all internationally. And the key to much more arterial grafting is reflected in this slide, which we published in the Journal of American Heart. And essentially, the multiple arterial grafting here, here's radial artery, there's multiple arterial grafting. 79% of patients received radial artery. And if you look at those who received total arterial, that's 90%. And as you go down from more arterial grafts, 2, 3, 4, So the radial artery usage goes up. Why? Well, because it's convenient, easy to do, easy to harvest. Mammary artery was also used, but to a far lesser extent. So I might ask you the question, well, what's the goal of coronary bypass at all? Really? I mean, what are we here for? I would say permanently, perfectly patent grafts. They work forever and blood goes to the heart forever. That's it, full stop, right? That means there's no progression of graft disease. So that means it remains ad infinitum. So that should theoretically, obviously just from first principles, mean you have better survival, less recurrence of symptoms and so forth. Now, this is an interesting angiographic series from Royal Melbourne Hospital where we had serial angiograms. Now, these were primarily symptom-driven indicated angiograms, not study research ones. And the first angiogram was an average of 7 years post-op. The second one in red, 12 years post-op. We took only perfectly patent grafts in all of those three, mammary, radial, and vein. And we said, okay, now what happens to these? Well, for the two arterial grafts, mammary and radial, nothing. For the vein, a large drop in perfect patency. That's not unexpected. This is unexpected. The radial and the mammary, we did not see a difference. And this is the larger data set that we analyzed. This is one angiogram per patient. And you can see it's spread over the late period. Green radial, red mammary, the grey vein grafts. The dark color is perfect patency. The light color is overall patency. And there are three things to see here. The first is the two arterial grafts, red and green, have high patency at any time postoperative and basically don't change. So if the arterial grafts have failed, they'll probably fail within the first few months from competitive flow primarily. But thereafter, if they are patent, they probably remain so forever. And we're not seeing a difference between the two, by the way. The second thing is, if an arterial graft is patent, it's almost certainly perfectly patent. But not so for the vein, where perfect patency is always lower. In fact, patency overall is never higher in the vein than the arterial grafts. But of course, over time, that falls away, as we all know. So the vein, it's not the artery, it's the vein that's the most important graft in coronary surgery. That's because it doesn't progressively fail. It does progressively fail. I set that back to front. Now, a lot of people say, well, a total arterial and multiple arterial, it's the same thing, or shades of the same thing, or, roughly the same thing, or whatever. It's not. Total arterial is the absence of a vein graft, no matter how many arteries there are, right? That's the point. Multiple arterial graft, by definition, is two or more arteries, irrespective of how many veins. The fundamental thing here is the total arterial, the important graft is the vein. Multiple arterial, the important graft is the artery. And the veins are more or less irrelevant to the discussion or definition. This is a large series we published in JACC, where we looked at total arterial versus single arterial grafting for late survival. The literature, our new registry data, the bottom line is that there was a survival advantage in favor of total arterial revascularization by quite a large margin, hazard ratio 0.78, huge sample size, 130,000. But we've also published many papers showing multiple arterial grafting clearly has a survival advantage over single arterial grafting. This is our data, 45,000 or so. matched, etc. And we've also published in all of these subgroups the same thing. Multiple arterial has better survival than single. And these are all large numbers because of that data set that I just showed you before. The problem with this analysis, though, is this. If we take only the multiple arterial group and we divide that into those who had no vein, total arterial, versus the multiple arterial group with one or more veins, there is a strong survival advantage in favor of total arterial. Hazard ratio fairly similar to what you saw before with single arterial. In fact, the multiple arterial group with vein survival is only slightly more than the single arterial group. Most of the benefit of the multiple arterial is arriving from the total arterial subgroup. Another way of displaying a similar kind of concept, let's just say you had 4 grafts. And here you can see the combinations, 4 arteries, no vein, 3 arteries, 1 vein, 2 arteries, 2 veins, and so on. And you said, well, the survival over the medium to late term is highest with total arterial, but the survival progressively and incrementally falls as the number of vein grafts increases. Presumably, this is reflecting more veins likely or at risk of failing over time. So the bottom line, in terms of survival as an endpoint, total arterial is better than multiple arterial with vein, which is better than single arterial. Logically, that actually does make some sense. Now, the fundamental concept from someone like myself is, well, if total arterial is good for some patients, why is it not good for everybody? I mean, after all, this is an arterial circulation on the heart. Why on earth would you use a vein? If it's an artery, why not just use an artery from first principles? The caveats, of course, are numerous. It's not a total thing. I mean, of course, you may have damage to the conduits, use of the conduits, renal patients, etc., etc. And you can also make more efficient use of the conduits that you do have, which I'll describe a little bit later. Now, when I go around the world, a lot of people come up and give me their opinion about why they don't do whatever, usually total arterial or multiple arterial. And you can have a look at this list. That's actually only a subset of the things people have said. And, you know, it makes no difference. There's a common one that you're old or whatever. Starting to feel that myself even. Please let me tell you, I don't think even one of these is true, actually. So I thought I'd throw in this other question as well because of the complexity question. People are comfortable doing aorta to coronary and they say, oh, well, if I have to do total arterial, I have to go Y-graft, and I'm not comfortable with that. This is a paper published in JACC that my Lima radial Y-graft series versus single arterial, there was a survival advantage. And I was very much a Y-graft man for everything for many years. But when you took the data and analyzed total arterial, that's total arterial, of course, total arterial by any other technique, no Y-graft, so essentially aorta to coronary grafting techniques, the survival is identical. There's nothing magical, actually, about the Y-graft specifically, right? It's not that important, although, of course, I thought it was, and I've changed my ideas about this. It's about the conduit. And another point, well, the memory, it's magical. It's like fairy dust gets spread on it. Everything else is no good by comparison. This is a common concept Lima to the LAD, if it's not that, you're doing some bad harm to the patient. Well, in Australia, we published this paper where we looked at the Royal Melbourne Hospital Lima Radial Y experience with the matched group of the Lima Rima Y graft from Sydney, and the survival is overlapping. So the Lima Radial Y or the Lima Rima Y are as good or equally good or whichever one it is fine. The point is an artery is an artery, in my view. So to conclude this first little part of the talk, the radial artery is generally the easiest way to broaden the use of arterial grafting. And I'll explain why that is shortly. The vein is the most important conduit in my view. If you're looking for something, the treatment that fails, look for the thing that fails in the treatment and try and eliminate that point of failure as the logical sequence there. So if you're happy, I'll just keep going. So how would I say you should use a radial artery if you wanted to increase your use of arterial grafts? Well, stop thinking about it as something completely different. Just use it like any other conduit that you currently use, mammary, vein. Don't get hung up about the complex forms of revascularization. Just do the same as what you're doing, only substitute the radial for a vein, for example, and do everything else exactly the same. The complexity is how to do it with fewer tubes, basically, and that's about it. Now, don't get obsessively obsessed about the vasodilator question, and I think that's what I was referring to earlier. In my practice, for at least the past 12, 14 years, I have used 100% of patients have had noradrenaline infusions at the commencement of the anesthetic. So that that's a way of minimizing fluid control. But essentially, all of my patients are deliberately vasoconstricted to some extent with noradrenaline. At the Royal Melbourne Hospital, about 70% of patients will get a noradrenaline infusion of sufficient duration, which from my memory, I think was about a minimum of 2 hours to get registered in the database. And that's about 70%. So almost everybody is being vasoconstricted, not vasodilated. My personal protocol for blood pressure is a minimum of 100 millimeters of mercury systolic. And if it's below that, we'll constrict them some more. Anecdotally, I don't see spasm in any conduits that often, but when I do, it's more commonly in the mammary than the radial, to be frank. So I would say use the radial and substitute for the vein and just use it exactly the same, treat it exactly the same, and do your operation exactly the same. Now, if we said, well, okay, how could you achieve total arterial in 3 or 4 graft patients, which would be the average number, I guess, for most of our practices? There are many ways in which you can achieve this in a fairly straightforward fashion. Lima to the LAD, you have a Rima, a Frema, a radial, even a gastroepiploic, 1 conduit per distal anastomosis, just like you currently do. You might introduce a sequential graft. That's really, I think, well within everybody's framework of early experience, if they're not already doing it, and is not, I don't think, overly challenging. But as you get more and more sequential grafting, there is a little bit of nuance about the way you judge the distance between those, and you might have a slow or a slight S bend and so on to facilitate that. But basically what I'm saying is you can easily achieve in about 2/3 of patients total arterial revascularization with conventional techniques, conventional strategy, conventional bypass, conventional anesthetics, conventional everything. Just substitute an artery for a vein. That's it. The radial artery, of course, is the easiest conduit to harvest by far, in my opinion. And the harmonic scalpel is definitely recommended. We just use the same protocol for vasodilation whilst we harvest it, i.e. 1% papaverin. I don't use blood, but other people do. Roughly, it's the same as we do for the mammary. And as I said before, the perioperative vasodilators, inotropes, the fact that they've had a radial is of no consideration. But after radial artery angiography, I would recommend you learn how to do your own ultrasound, which takes about maybe 5 minutes to learn. It's very simple. Here you can see a little bit of calcium here and there. I would still use that. I wouldn't throw that away. It's just fine. If the vessel is patent, then it may well be considered appropriate to use that cannulated by the cardiologist radial artery. And I would now do that quite commonly. Here, for example, is the puncture site of where that radial artery was cannulated only a day or two before. The first step of the radial artery harvest is to divide the deep fascia of the forearm just medial to that brachioradialis border so that you get the little branches that go across. The neurovascular fascia, a bit hard to see in this slightly overexposed image, is the next layer, and the nerve, artery, and vein, of course, exist within that. Once you're in there, there's just loose areolar tissue that practically falls out of the arm. It's very, very simple to harvest. And then, of course, we would use this harmonic scalpel these days by preference, although clips and diathermy or clips and cut is an alternative. And you can see, I think, how simple and easy it is to just whiz up and down with this thing. It's very, very straightforward. I'll just let that play a little bit longer because you'll see the area of the cannulation site shortly, which again, for most grafts, you don't necessarily need the full length of the radial artery. You can excise it, and that's what we'd normally expect. So there is the cannulation site, just for interest. Now, for more complex reconstructions, my view would be the easiest one to start off with is the lemur radial Y. Everybody's familiar with the lemur. You get used to the radial, you simply join it to the lemur and add about the pericardial reflection. So the lemur comes to the heart and then it changes direction. The alternative is to use 2 radial arteries. That's these days very controversial in terms of how new a concept that is. But it certainly helps with those with poor lungs because the impact of a lemur harvest on the respiratory function is quite high. But having no lemur harvest makes quite a difference. Little mini Y grafts, so you can have little short, like a lemur to diagonal graft, for example, is another thing. Another mental block, I'd say, is that if you're not grafting the lemur to the LAD, you're a bad person. Please, if I can encourage you not to get overly obsessed. This is how I do the Y graft. It's very simple. You get 3 gauzes, you roll it up, you put it on the thymus before you put the purse strings in or before you cannulate it anyway. Lay it on where it's convenient, make a hole. 99.9% of the time, that's exactly where the pericardial reflection is. And then you simply do an anastomosis. Toe first is the easiest if you use a forehand technique. Of course, you can do it any way you like. Join the 2 together. Here we're making a hole in the pericardium. The phrenic nerve is just over here. The front of the pericardium is here. The heart is here. And with a Y graft, you need to make a slightly more inferior cut than usual. And then you simply bring those conduits through. And the radial, you'll see, will have more than sufficient length for the circ and the right coronary territories. A radial Y is another thing. I thought I'd just describe it because you haven't really seen it most likely, but it's very simple. I just measure the distance to the lateral border of the pulmonary artery. Here you'll see it's about 5.5 centimeters. You take the two radial arteries, make a hole on the reverse side of one of them at that measurement, and it almost always is 5 or 5.5 centimeters. And then you sew this second radial artery to it. Generally, if you're doing, say, a radial to a distal diagonal LAD, you'll still have redundant length. You might choose the right radial artery, but it always reaches very distally, more so than the mammary, especially if there are additional sequential grafts along the way. I tack the two together subsequently so that you don't inadvertently have torsion once you've deployed it. Then I'll do the top end onto the ascending aorta, whatever technique you like. I then put a temporary tacking suture to the lateral border of the pulmonary artery here, and then bring that Y graft down to that point. The reason being, once you have the heart retracted and you're giving it a bit of a tug, sometimes you can over move that, and you might end up with a bit of tension over the pulmonary artery. So this is a way of trying to prevent that. At the end of grafting, of course, you remove that. Here you see intermediate diagonal and LAD. That radial is more than sufficient to reach. And I thought I'd finish off with a couple of case examples as mind games. They're not really the bog standard, straightforward cases. So this is not necessarily reflective of my everyday routine practice, but I thought they might illustrate some of the points. So here you see an obvious stenosis in the LAD. It's affecting the diagonal artery. And there is a stenosis in that intermediate artery, which is quite large. And you could see that up here with the stenosis between the diagonal and the LAD there. This is my diagram, 69-year-old gentleman, 3 lesions. The right coronary artery was not overly severe, right radial artery cath. So, what are some of the obvious alternatives that we can think of? Well, you could have the lemur to the LAD and then 2 arterial grafts be radial, mammary, right mammary. You could do a lemur with a radial or mammary, for that matter, Y graft to the diagonal and to the intermediate. Do a mini Y and 1 other graft to the intermediate. It's a separate graft if you were concerned about the degree of stenosis. 2 separate radials only, no mammary. All of those, I'm sure, would work just fine. Or you could just use 1 radial and it would be more than sufficient length to reach all of those. In fact, there's another diagonal there we didn't see on the angiogram. So the illustrative point about this case was that 1 radial artery will fully revascularize 1 territory because it's extra length compared to the mammary. For the LAD territory, composite grafting, the most difficult graft to do is the intermediate artery or the high diagonal, high marginal, because it's very close to the Y and the angulations can be quite difficult. But from the aorta, it is literally almost parallel. It's actually the best trajectory for the intermediate artery. And it will still reach the apex of the heart despite that. And this is an illustration of what that would look like. The aorta would be over here. This is coming around, and here is the intermediate artery. You can see how that really sits nicely. And in that particular instance, this is how it might otherwise appear. All right, so here's another example. Quite a very calcified left main and proximal LAD, critical stenosis, and the origin of that LAD stenosis, another stenosis down there. You can see the diagonal artery is not very big. There is a moderate stenosis here, but not particularly critical. And there's an occluded right coronary, which is a codominant system. So that was my diagram here. High-grade lesions, moderate, small lesion, moderate, and occluded right. And by the way, yes, he's 91. He's got a mildly dilated ascending aorta 4. He's got 2+ AI. So, what are your options? Pretty much the same as everything else. Lima layered, one conduit to that circ, one conduit to the right. You could have the radial where you might have picked up the diagonal on the way to this if you wanted, but otherwise it's more or less the same. Or you could do a classic Lima radial Y, or in the case of using the free right internal mammary artery, Lima Rima Y, and that would work just fine. In fact, the point about this, age is not a consideration in our practice for whether you choose total arterial or not. And the final case here shows quite a diffusely diseased big LAD that crosses well beyond the apex. There's a critical lesion halfway down the circumflex and another lesion here. This LAD has a stenosis really quite close to the apex of the LV, apart from other disease. And he has an occluded right coronary artery. This was my diagram. Again, right cath, radial cath, 73-year-old man. And obviously the issue here is how far down you would need to graft. And in fact, very close to the apex of the left ventricle. So again, to make it easy, we could easily do a Lima to diagonal and then the LAD here, although in my mind, it's a very real consideration, and especially with the sequential graft, you may not reach this point. So there's a degree of uncertainty. You could do one radial and do all of those 3 marginals and another one, or a Frema to the right coronary artery. Here we do a classic Lima radial Y. Again, the issue here is whether that Lima was long enough to reach. You could maybe do an extra little extension graft, mini Y, an extension graft, something. Or you could potentially use 2 radial arteries, one to the LAD territory and one to the circumflex and the right coronary artery territory. The point about this was the Lima may not reach all the way to the apex, but the radial artery from the aorta always will, even with other grafts along the way. And this is how a case like this might look. Radial, the Y graft, as you can see at the lateral border of the pulmonary artery, this would be a diagonal and so on. The other thing is that the radial artery, the Lima radial or radial Y, it's not infrequent for us to see, no, that's the wrong one, sorry. I'll go here. This is the PDA here, and you can see the radial ends way down there. It's quite common that we would need to shorten the conduit through redundancy of length rather than insufficient length, as the case may be. Just briefly, a few happy pics of radial arteries. This is a radial artery graft for an anomalous right coronary artery that we tied off. A lemur radial Y, and the radials continuing on down to the circumflex and right coronary territories. A radial 19 years post-operative, perfectly patent. And a picture of a radial Y. You can see its origin at the ascending aorta, going to the diagonal and the LAD twice, and this one coming around the back to these marginal arteries. So to conclude, the radial artery is pretty versatile. It's robust. It's the easiest graft to harvest by far. Our angiographic evidence shows that there appears to be no progressive decline over time. So an early patent radial seems to remain so. And research with survival would be consistent with that remaining patent. What I can tell you is that the radial artery is steeped in mythology of some kind. If I was to say anything at all, just treat it the same way in your practice, in your hands, as you would any other conduit, be that mammary or vein or whatever. Thanks so much for your attention.
Thank you, Dr. Royce. So we can move on with a question and answer for Dr. Royce. Does anyone in body have a question? Dr. Novilla.
Hey, thank you very much, Professor Royce. A very, very excellent presentation. We are now pretty convinced to really push for a total arterial revascularization. But then I just one point, because we've been doing bilateral IMAs, and the limitation with the right IMA is that most of the time it doesn't reach to our desired target. So oftentimes we put the sort of a composite graft. So we put an extension like a vein graft, for example. So where does this type of configuration fall into your category, and what do you think would be the long-term result?
Question you've asked, and the first thing I would say is if you're extending an arterial graft with a vein graft, you're kind of negating the benefit of the arterial graft in many ways. So I'd be saying, if you wanted to do that, I'd be using an arterial to lengthen arterial. That would make more sense. But go back one step and say, well, if it's not long enough to reach, then maybe consider not using it for that purpose. And I think exactly that issue is why we did a lot of, in Melbourne from about the late 80s, we did a lot of free right internal mammary artery grafts, because so often the pedicle or the in situ reamer wasn't long enough to reach the PDA. The two elements of that was there's nothing wrong with extending an artery, but if you could just avoid doing it in the first place, that's even better. Prevention's better than cure. But if you were going to extend it, I would be advising against extending it using a vein graft, but rather extending it using an arterial graft.
How about the use of the no-touch vein as an extension?
Get myself into hot water here.
Don't ask it.
Okay, so if you harvest a vein any way you like, once you've harvested, guess what? It's still a vein. The biology of the conduit is still a venous, not arterial. So I know there's been a great deal of advocates about no touch somehow changing the biology of the conduit. I must confess I don't take that line. The second is just from first principles. The vasa vasorum is supplied from vessels, arterial supply from outside the vein, and you divide that, whether you do it no touch or not. And subsequently, the nutrition to the vein comes from within the lumen, because you're now producing arterial blood flow through it, not venous. So one way or the other, it needs to remain, so it gets its nutrition from the flow through the middle of the lumen. And if you've divided the vasa vasorum from the outside and that is no longer there, there's a certain logic problem with the argument as well. I would not be too, I would suggest to use an arterial graft instead of a venous one.
Okay, Dr. Natapan. Very impressive presentation from me. And I was taught that the radio was just designed for the critical stenosis of the target. Like more than 90% of close to CTO to remains open of the radial arteries. So what about the lesion that we always see, like 60, 70%? What should we do?
Yeah, I mean, I think it's a really difficult question because, again, there's a huge amount of noise out there. If I ask 10 people in the room, 10 people give me 10 different answers about their favorite number. In their view, it's X%. That's the important thing. Whereas I'm not sure 10 people looking at the same angiogram would come up with the same percentage anyway. We tend to use the radial artery a little more conservatively these days than we did 25 years ago. But nevertheless, we would graft a vessel if we thought it was perhaps a small vessel, 60%, maybe 70% for a larger vessel. For example, the right coronary artery territory grafting, the PDA, is always the lowest patency of all, no matter what tube you use. And the favorite question, and David Taggart's asked me this 4 times in a row now, you have a large right coronary artery, 60% stenosis, what do I do? And the answer is, I leave it alone. I don't graft it with anything. If you said, well, why don't you use a vein? It's definitely better. I say, well, prove it. No one can. The data in our series is always, and almost all series, has shown the lowest patency of all conduits is still the vein. So the notion that somehow a vein is resistant to competitive flow yet still has the lowest patency is a bit of a intellectual difficulty I have. If it's not failing from competitive flow itself, if it's not also subject to competitive flow, why is it failing? It doesn't just block for nothing sort of thing. So I would be advising that you continue to graft today as you do tomorrow using a radial instead of a vein, more or less the same. If I was to say you might choose to be slightly more conservative, I would suggest the right coronary artery. You might be a bit more conservative than the circumflex. But overall, I wouldn't change my policy grafting strategy too much at all, actually.
Thank you very much. And about the preparations of the radial, I see open the fascia or adventitia outside, or someone don't do because they want to make the radial.
You mean the radial artery? Or?
Yeah, when you radial artery preparations, when you harvest that, and then we were taught to split the adventitia outside to make it split open to make it more relaxed when you do the bypass.
Yes.
Is that still recommended?
No, I don't recommend it at all. I think that's not a good technique. If you want to get the radial to come out easily, you get into the correct plane, which is inside of the neurovascular fascia, where there's looser tissue. If you take the fascia and the muscular fascia underneath, that's just extra trauma to the arm for no benefit for starters. But the second is, particularly with a harmonic scalpel, you can end up with this kind of envelope where you've got a shrink-wrapped edge to one side and a shrink-wrapped edge to the other. And now it's actually almost trapped under pressure and you've got to open it up. So go through the deep fascia of the muscle. Next, go through the neurovascular fascia. When you see the looser tissue, that's the correct plane. Harvest the whole radial in that plane. Divide all the branches any way you like. It doesn't matter. And regarding vasodilation, I use exactly, well, we all use exactly the same as we would for the mammary. For me, that's 1% perpavin without blood. For half the unit, it's 1% perpavin plus blood, whatever.
Thank you very much. Dr. Ventura?
Yes, so Professor, that was a very informative lecture. I just have a question regarding, is there a difference between putting it in the aorta and putting it in the IMA, the radial? Because theoretically, there's more pressure coming from aorta and than the IMA. And of course, we know that if there's more pressure, there could be more possible stenosis and all of this injury. So how is there something that is there a difference, or do you favor one?
So I spent the first 10 years of my career being the advocate of the Lima Radial Y. I mean, I published the series in the 1990s. And when I saw the data that I presented before, where the aorta to coronary and the radial was identical, I then changed my mind based on the evidence. The evidence is it doesn't make any difference.
So now you use more aorta from the aorta.
Yeah.
Okay.
Yeah.
And any reason why you find this are the findings that you saw?
Well, I mean, the reason why we did the study was because, say, at Royal Melbourne Hospital, there was a few people like myself who did almost routine Y grafts, and a number of those who never did it, sort of thing. And yet, within the group, there was no difference in outcome. Well, there's either, and again, it comes to observation versus theory. The theory was it would make a difference. The observation was it didn't. So which one do you believe? The theory that says something, or the evidence in front of your eyes? And in many ways, that's a relevant question to vasospasm and the radial artery. Listen to a devotee on somebody who says you must vasodilate the radial artery, not just within hours, days, weeks. Some people say for life, because they saw a histology of a radial artery where there's more muscle than the mammary artery. Therefore, they predict that it is more prone to spasm. So that's why you should give this treatment. Or you have people like us who do the opposite of what's predicted, and there is no spasm, and we're just fine. Do you believe the observation, or do you believe the theoretical prediction? Now, if what I do for the past 30 years would lead to 100% of my patients dying of vasospasm, but they haven't, there's a problem with the theory, is my concept here.
Dr. Kikuchi?
Yeah, I have two questions. One is, please let us know your contraindication to use radial artery.
Sure. Well, let me answer first. I mean, there are a number of them. Firstly, obviously renal patients are a big issue, although if they have an established fistula and it's working fine, it's not in deep trouble, we might take the other artery if they need 5 grafts and so on. And with 2 tubes, we can revascularize the whole heart. So they will get their full revascularization. But any obvious damage to the radial artery, so, obviously it's pretty common to get cardiology interventions. As I showed you before, it's very easy to do an ultrasound, but obviously dissection or occlusion of the radial artery precludes you from using that. And in some patients, of course, the radial artery might be heavily calcified and not suitable, but that's the minority, not the majority. If there's a little bit of calcium, for example, I showed you one of those pictures where there's a few little speckles as you sweep the probe up and down. That's not an indication, contraindication in my view. The fact that it's not perfectly normal, there's no evidence that they won't function normally. But obviously, an extensively calcified artery makes it, apart from anything else, difficult to actually use and suture and so on. So there are practical reasons for that as well. Sorry, the other thing is people with systemic, SLE, a scleroderma, collagen vascular diseases, people have had hand injuries and so on are
Mhm.
obviously not suitable.
One more question?
Yes, one
Because
more question.
yeah, I know the radial artery is quite big when we use harmonic scalpel to harvest, but sometimes it causes spasms, especially young surgeon. When young surgeon take down radial artery, it causes spasms. And the issue is once radial artery has spasms, it's not so easy to dilate because it's not so easy to dilate radial artery. It's not very difficult to dilate the radial artery once it has a spasms. But the mammary artery and GA, we can dilate easily. This is different from the other arterial conduit. And I think it caused stenosis, string sign, and graft occlusion, I think. So how to dilate radial artery?
Yeah. So firstly, there are a couple of things there. The first is that I find it more difficult to stop a mammary that's spasmed, usually after you've done the anastomosis from the handling than the radial. But for a mammary, after grafting, I'll just put papaverin on it and let the heart start to perfuse, and it generally resolves within about 5 minutes or so. With a radial artery, what I found at the top end is if people clip the veins before they divide the artery, that makes it more likely to spasm than if they just transect it and do all that later. With pharmacological, papaverin, for example, both a mammary and a radial, if I had persistent spasm, I would put a metal probe down, and Dr. Carpentier will probably turn in his grave, but it works fine. And no, I don't. If the question was, you harvested and there's some spasm, now I graft it with spasm, I would never do that. I would resolve the spasm before it was grafted. I would never leave something spasmed and use it in a grafting situation.
Okay. Why I try to use no-touch vein graft is the reason is spasms of the radial artery. In my experience, it was very difficult to dilate the radial artery once it got a spasm. And this is the reason. And the length. Asian people have a short arm, so sometimes it doesn't lead to PDA, distal PDA and ABE. So that that is the reason why we cannot use a radial artery for frequency.
So there's a lot of questions that I get from especially Asian country saying, our people are not like your people. Well, actually, half the people I operate at are like your people. They're either Indian or Chinese or Polynesian or something. I've never met anybody with an arm shorter than the mammary artery. So no, it's not shorter. It's always longer if you harvest the full length. It's always bigger than the mammary. That's just human anatomy, unless they've had an injury of some kind or they have a problem with their hand. It's always more robust because of the wall being thicker. So, I'm not sure I quite accept that, but if I was to say the main barrier that you encountered was spasm, the main solution I would offer is if after you're treated with the pharmacology drugs that you use and there was still some spasm, I would use a standard metal probe and put it through, and you'll find that it will relax completely.
You don't have a such experience in your city, right?
Sorry, if I had.
You don't have you don't have this kind of experience in your cities to use radial.
Not really, no. I mean, if there is spasm, we fix it at the time, and those were the steps that we would take. Sure. Yeah.
Okay.
Thank you. If there are no more questions, thank you, Dr. Alistair. Another question, Dr. Yam.
Just two things. Professor, do you still use calcium channel blockers post-op for your radial artery?
No. Within the whole of Australia, yes, there would be quite a number. And within our hospital, there would be a couple of people who do. But within the Royal Melbourne, predominantly we don't at all.
And question for all the panelists. I guess most of you guys use the Y configuration for your as a graph strategy. One inflow with a Y configuration. How many outflows are you comfortable with this single inflow and Y graph configuration?
Excuse me. Well, I could start the ball rolling if you like. I'm happy with any number. I'm spent half my career just having one, but
I think it depends on stenosis. Yeah, if you talk about the Y configuration and the sequential bypass, we need to discuss about the stenosis. Yeah, if you do the Y configuration, the coronary artery should have a same stenosis. Yeah. So if you already have a 75% stenosis and the circumference has a 100% occlusion, I don't do Y configuration. So this is very important to use Y configuration. Yeah, it depends on stenosis.
Really also depends on that external, the different vessels are divided. Because if one has got a higher grade, then you get the steel phenomenon will go dominantly in one direction. And that particular lens may not be get occluded. So I think it's very critical. It's actually a very good paper from Japan. Reading a long time ago. Yeah. That when you're doing a sequential anastomosis, but you want two outflows, it's very important to make sure that the two outflows, the native stenosis, is not competing with each other. Yeah.
So when we started to have the flow meter here in our institution, I used to do 4 outflows with one inflow with a Y graft, but there are a number of times that I noticed that in the fourth distal target, you have a really low flow already. So I'm not sure if any one of you experienced this.
Yeah,
with more than 3 outflows.
I think the whole central question of the degree of stenosis is very relevant. If the target is where the final graft is going to has a high grade stenosis, then the patency of the whole conduit is primarily based on that final. And so you can graft vessels of lesser stenosis along the way. But if you end up with one with a low degree of stenosis, then you're likely to lose the final segment for sure, as per competitive flow. The longer the graft is, of course, the less pressure you will have, just the inverse of the square of the length. And in fact, I just did another case where the LAD macroscopically on angiogram looked very moderate, but the IFR, which I have no great faith in, was significant. I chose to do separate inflows for each territory because I felt that there was going to be a high degree of competitive flow affecting the LAD, for example. So, yeah, I think the nuances are definitely there.
Thank you.
Dr. Chang and Doc Nat,
So personally, I think besides the stenosis, which is very well mentioned and studied, I think one other variable that we might have problems assessing is the distal runoff. So if the vessel's caliber distally are a lot smaller compared to the rest, then naturally you have some competition coming from there as well. So personally, I usually don't do more than 2 distals.
Dr. Nat, my comment was that be the same with all the experts. I was taught that way too. And when we do sequential, no matter how sequential you do 3, 4, 5, it can be done. The bottom line is that the last one should be the big bath for the flow. That's what I was taught by my teachers, and I'll do that.
Okay, thank you. Let's give Dr. Royce a round of applause. Nasaan yung ano?
Yeah. Sharon as well. I'll just introduce you for a minute. Yeah.
For our sixth session, we will talk about cardiac viability studies, simulation and training for cardiac surgery with Dr. Go Hao Chang. So a little overview of Dr. Chang. He graduated MBBS in U Lu Lin University, National University of Singapore, member of the Royal College of Surgeons in Edinburgh, Master of Medicine in U Lu Lin School of Medicine, National University of Singapore, Fellow of Cardiothoracic Surgery, Royal College of Surgeons, Clinical Fellowship in Minimally Invasive and Transcatheter Cardiac Surgery for Heart Valve Disease in Milan, Italy. Director is CTVS Simulation Center, National University Heart Center in Singapore. Chairman and Domain Lead, Scientific Committee for Adult Cardiac Surgery, Asian Society for Cardiovascular and Thoracic Surgery. And his field of interests are minimally invasive cardiac surgery, robotic cardiac surgery, aortic surgery, and ECMO. Let us all welcome Dr. Go Hao Chang. Yeah.
Yeah, good afternoon, everybody. Thank you for the introduction as well as the invitation here. I'm very privileged to be here to join in the 50th anniversary. And thanks to Dr. Yam and your team led by Dr. Ventura. It's indeed a milestone, so congratulations on that 50 years. So today we'll talk about myocardial viability studies. So myocardium, whether it's dead or alive. So we want the alive myocardium, and we hopefully can revive the dead myocardium. Maybe not today, but in the future, who knows? So this is the rough content. First, we'll go through definitions, classifications, what's the clinical relevance of myocardial viability, what are the investigative modalities we have, the evidence, and lastly, the decision, which will be largely controversial. And I think this talk will serve as a stepping stone to tomorrow's discussion. So first, traditional versus contemporary. So this illustration shows what is the traditional concept versus a contemporary concept in patients with ischemic cardiomyopathy that are considered for CABG. So if you see here on the left, which depicts the traditional paradigm, first we assess the myocardial viability focused on a pre-specified threshold. Does the patient have substantial amount of viable myocardium on viability testing? If the answer is yes, we offer CABG. If the answer is no, then sorry, no CABG. So CABG would improve LV systolic function and reduce ischemic heart failure and thereby lead to increased survival. So that's the traditional concept. Next, we move on to the contemporary concept, which is the current more accepted concept, where we assess the viability using the same type of studies that we have, but this time we focus on the distribution of viable segments. And we see that we want to see that there's concordance between viable segments and the vessels that are suitable for grafting. If there isn't a concordance, then no CABG. If there is a concordance, then there is a chance for CABG, even though some of the segments might not be viable. So this will result in protection of viable segments and reduce risk of fatal myocardial infarction and ventricular arrhythmias, thereby leading to increased survival. So definition, what is viable myocardium? So it is a live myocardium that is not dead, and the clinical implications is that LV systolic dysfunction in ischemic heart disease will not always represent irreversible damage. And they are dysfunctional but viable myocardium that has the potential to increase and improve its systolic function after adequate revascularization. So a bit on histopathology, which is fairly distant for most of us surgeons, is that myocardial viability says that cardiomyocytes that are still alive have preserved cellular function, metabolic function, and microscopic contractile function. And this translates clinically to presence of dysfunctional myocardium at rest with a potential for functional recovery when we restore normal blood supply by revascularization. And these myocardium come in two forms, hibernating myocardium as well as a stunned myocardium. So this is the histological picture cartoon of the different classification of viable myocardium and translates into the contractile reserve. So we are more interested in stunned myocardium as well as hibernating myocardium in the first three rows of this table. The infarcted myocardium, unfortunately, to date, I don't think there's a chance for recovery. And the time for recovery is as follows. For stunning, is in days. For hibernation, is either weeks or months. So this slide actually shows you the percent of normal coronary blood flow as well as the time scale on the x-axis in a stunned myocardium. Okay, so coronary blood flow being 100% of normal, depicted as this dotted line. When there's an insult, there's a reduction in coronary blood flow, which results in a reduction in myocardial contractile function. So for as long as the coronary blood flow is compromised, there's a reduction in this myocardial contractile function. And the moment this restoration of blood flow occurs with rapid reperfusion, the stunned myocardium takes a certain time to recover. It may or may not recover back to normal. So this state of transient hypoperfusion results in decreased contractile function and a transient LV dysfunction, which is what we see after an AMI that is treated by prompt reperfusion. Next is the hibernating myocardium, and this is the first mechanism for chronic reversible LV contractile dysfunction. It is essentially an adaptive mechanism of the myocardium to a state of critically reduced blood flow. When an insult occurs, coronary blood flow drops. There's a reduction in myocardial contractile function accordingly. And this is the state where myocardium goes into hibernation, which is a chronically reduced myocardial contraction to match the critical reduction in baseline blood flow. And when there's a restoration of baseline blood flow with revascularization, the recovery of function occurs. So this is a new balance of demand and supply where flow and function are matched. Both will be at significantly reduced levels, as seen in the next slide, where we talk about the alternative mechanism for ischemic cardiomyopathy. So this mechanism talks about repetitive stunning that is caused by recurrent episodes of reversible ischemia where myocardial oxygen demand is increased. Normal resting blood flow is in areas with systolic dysfunction, and there's reduced coronary flow reserve, resulting in chronic systolic dysfunction. So this is the table as in the cartoon representation for repetitive stunning, resulting in chronic systolic dysfunction. If you follow figure A, we can see that there are multiple episodes of ischemia due to increases in myocardial oxygen demand exceeding the ischemic threshold. And this results in a reduction in coronary flow reserve and a reduction in contractile function. With repetitive stunning, the flow reserve reduces tremendously, and there's a downward slope when there's repeated episodes of reduction in oxygen supply. B will show the normalization of coronary flow reserve after revascularization. So this is the state on the left, is a state of reduction in LV function due to repetitive stunning. And when we have coronary revascularization, there's improvement in LV function due to the resolution of repetitive ischemia. So we ask ourselves, what is the clinical relevance of this? So the potential for dysfunctional myocardium to improve its contractile force after revascularization is the type of myocardium that we want to catch. And there are instances when myocardium that is viable does not improve function with revascularization. This presence of viability is limited to subepicardial layers of segments with subendocardial scarring. And perioperative infarction, despite adequate myocardial protection with cardioplegia, does happen. So recovery of LV function is an indicator of success of revascularization in ischemic cardiomyopathy, and the goal is recognition, because poorly contractile but viable myocardium is the ones that we want to save because they have recovery potential. and there's therefore a need to discriminate viable versus non-viable myocardium. So these are the investigative modalities that we currently have. The SPECT or MIBI scan, which is colloquially known to us as the nuclear imaging. DSE, the dobutamine stress echo, which has the highest specificity and positive predictive value at a segmental level. PET imaging with the highest sensitivity and negative predictive value. And lastly is cardiac MRI. So this slide shows the different modalities that we have. First, on the top left, for SPECT, it measures the thallium or technetium, which is the nuclear uptake, to assess myocyte membrane integrity. Bottom left, the PET scan measures the uptake of fluorodeoxyglucose as a marker of glucose metabolism. CMR uses late gadolinium enhancement to highlight areas with increased extracellular volume as an indication for infarction. And a stress echo uses inotropic stimulation to measure contractile reserve. So what's the evidence behind all these modalities? So these are some of the papers with meta-analysis to show the various modalities, which I'll cover next. So do date myocardium equal date? So an assessment of myocardial viability in patients with ischemic cardiomyopathy is a prerequisite to guide our clinical decision regarding suitability of revascularization. There are, however, significant limitations in the papers that are shown here, is that they are largely retrospective observational nature. Heterogeneity is the criteria for inclusion of patients into different studies. There's treatment bias because knowledge of the findings actually influence treatment decision. And there's also a lack of adequate medical therapy in patients that are included in studies during that time, in the 1980s and early 1990s. So from all the studies that has been done to date, most of them actually show inconclusive demonstration of a true interaction between the results of viability studies and the benefit of CABG. So just briefly talk about the heart trial, the heart failure revascularization trial. They include patients with evidence of myocardial viability with any imaging that we previously discussed. So they classified them into conservative management versus coronary angiography, KIV, PCI, or CABG. 138 of planned 800 patients were enrolled due to withdrawal funding and due to slow recruitment. So this study was terminated prematurely and there's no difference in mortality. And it is also underpowered to address the endpoint. The STITCH trial, it was a prospective and randomized trial of 1,212 patients, 2002 to 07. I think most of you will be quite familiar with. It studied the effect of CABG in ischemic cardiomyopathy. Patients randomized to CABG actually had a reduced rate of all-cause mortality, cardiovascular mortality, and all-cause mortality plus cardiovascular hospitalization when compared to GDMT, guideline-directed medical therapy, over 10 years. So these are the STITCH trial as well as its extensions and its subdivisions of the STITCH trial. So when we talk about STITCH and viability, they have a STITCH trial viability subset. 601 out of 1,200 patients with ischemic cardiomyopathy, which is defined as EF of less than 35%. And they did myocardial viability assessment consisting of nuclear imaging as well as stress echo. The extensive viable myocardium was defined as more than 5 dysfunctional but viable segments on stress echo or more than 11 viable segments on MIBI scan. And a total of 298 underwent guideline-directed medical therapy and CABG. 303 underwent CABG alone. Underwent guideline-directed medical therapy alone. So in 2011, they found that the results were released. They found that presence of viable myocardium was associated with a greater likelihood of survival in patients with coronary artery disease and LV dysfunction. But this was not significant after adjustment of other baseline variables. And the assessment of myocardial viability did not identify patients with a differential survival benefit from CABG compared with GDMT alone. So this was the conclusion at 2011. In 2019, it shows that there is no link between the presence of viability and the benefit of CABG. And the presence of viable myocardium was actually associated with improvement in LV systolic function, but this improvement was not related to long-term survival. So from the result of this trial, I think as cardiac surgeons, we get referrals from cardiologists saying that patient's EF is 20%. It doesn't matter whether or not you get a viability scan. You should go ahead with CABG. But this we can discuss further tomorrow. But I'll show some slides to set a bit of stage and trigger a bit of thought tonight after dinner. So the limitations of this is that there's high prevalence of viability in 80% of all patients in stitch, but assessed by SPECT and/or stress echo. However, we know that PET and cardiac MRI are more accurate for defining and identifying viability and the prediction of functional outcomes, but these were not included. The decision to perform a viability test and the use of the result to guide the management were not randomized. And the third limitation was that the design of the stitch trial did not include assessment of residual ischemia or hibernating myocardium after the initiation of treatment or the long-term effects in LV ejection fraction. So now we turn our attention to this trial, myocardial viability for decision-making concerning revascularization in patients with LV dysfunction and coronary artery disease, which is a meta-analysis of non-randomized and randomized trials. It included a total of 32 non-randomized and 4 randomized studies with viability subgroup analysis that was done in 2015. So both patients with viable and non-viable myocardium appear to benefit, and a neutral and adverse effect of revascularization cannot be excluded in either group. So again, this meta-analysis shows that it's inconclusive regarding the usefulness of myocardial viability tests for guiding decision-making in revascularization for ischemic cardiomyopathy. So where we are now, Stitch says that despite confirmation of survival benefit of CABG, there's no demonstrable interaction between the presence of substantial amount of viable myocardium and the benefit of revascularization at both 5 and 10 years of follow-up. None of the prospective trials were able to confirm the usefulness of myocardial viability assessment for decision regarding CABG in ischemic cardiomyopathy. So we're as good as saying we are completely blind. So what should we do as cardiac surgeons? The amount of viable myocardium is actually a continuous variable, and it doesn't mean that it is a yes or no answer if the EF is 20%. So viability by these tests are actually arbitrary thresholds varying among different techniques. The Stitch trial shows that the most important mechanism of benefit of CABG is the protection against a fatal AMI and sudden death, despite the risk of mortality from the procedure. And if there is no viability, we should look for regions of viable myocardium that sustain systolic function and correlate with the coronary anatomy to actually achieve the goal of prevention of further damage. So it leads us to this concept of individualization of therapy, which, if you remember in the first slide that I showed, is a contemporary paradigm of CABG in ischemic cardiomyopathy. So success of CABG is number one and number two reason, both are the same reasons, the prevention of fatal AMI. That is what we are here for. So viability is a question mark. Viability is a tool that can enable us to facilitate us towards a certain decision-making pathway. However, it shouldn't dictate what we should do. It shouldn't be the only factor that dictate whether the patient is a bypass candidate or not. So the correspondence is important, coronary anatomy and viability mapping. So on top of these two preoperative variables that we can look at to help in our decision, we need to also look at the likelihood of successful revascularization in each patient. Therefore, the coronary targets that we see on angiogram will be important, whether or not the targets will last, whether or not there are graftable sites. All these are important factors. On the echo, what is the LV thickness? All these are important things that we need to consider patient by patient and guide our decision based on that. Next is intraoperatively. Distal runoff is important. After we construct the anastomosis, it is especially important for quality control, which leads me to this photo here that shows that transit time flow management is actually transit time flow measurement is actually very important. It shows us the flow, it shows us the PI, it gives us a guide to whether or not the anastomosis will last. And if it will not last, then we will not leave the OR until we change the TTFM so that we give the patient a better outcome. High frequency ultrasound is the next thing that we can use to actually assess the quality of the coronary anastomosis. We can actually use the ultrasound to see the flow across the coronary anastomosis, which is very useful. So this is all on top of achieving better outcomes such as epi-aortic scanning, looking for the coronaries using the ultrasound. This is pertaining just looking at the adequacy and quality of the anastomosis intra-op. And next is, what is the CABG strategy in ischemic cardiomyopathy? This, I think, we can discuss furthermore tomorrow. Should we do off-pump for these patients? Do all of them benefit from off-pump? If we do off-pump, what do we need? Should we do on-pump beating heart, or should we revert to the normal cardioplegic arrest strategy that we normally use for most of our patients? And if we do cardioplegic arrest, there are also various strategies that we can employ to actually improve the outcome of these patients, which we can discuss more tomorrow. Next is risk-benefit analysis, where we individualize therapy to the patient and the family members. Patient's age, frailty score, whether there's concomitant mitral regurgitation, whether the other organs are working fine. So all this on top of viability actually help us guide whether or not the patient is suitable for CABG and whether the patient will benefit from the revascularization surgery. So lastly, this is a $1 million question, whether myocardium is dead or alive. I think the main concept that we need to grasp is not whether myocardium is dead or alive, but whether we have a dead or alive patient at the end. So lastly, ASCVTS 2025, mark your calendar, 14 to 17 of May, happening in 2 months' time. We hope to see you there. So I take questions for this before the next one, or should I go? Yeah, can go to the next one. So next one will be a short presentation on simulation in training in cardiac surgery. So this is what Singapore looked like in 1950s. This is what Singapore looks like today. It's not just black and white or color, I hope. So in the past, knowledge acquisition was always from books. We started off with these 2 Bibles of cardiac surgery. Then we have endoscopic cardiac surgery, tips, tricks, and traps, which are very, very, very educational books. Then next we have YouTube channels, MMCTS, WooMedi, where we look at videos and we watch videos before we sleep. We watch videos over meal times on how different people do different things and approach the same condition. And we also have minimally invasive cardiac surgery, a practical guide, which was written by my ex-boss, who's the chief editor. This book is actually a very interesting book because it has QR codes that lead you to the videos. And it also has description in prose, which help you gain knowledge from there. So it combines both the old and new techniques into one book. So this was the previous paradigm, the previous belief that we have in medicine. See one, do one, teach one. It started out all the way from internship, right? See one IV plug, do one IV plug, and teach one IV plug, to see one CABG, do one and teach one. But unfortunately for cardiac surgery, I don't think this applies very much. Maybe you see 1,000, do 1,000 and teach 1,000. So do we want to get caught in this situation on the left? Wish me luck, you are my first. Or the one on the right, where you're operating, reading a book. And now maybe we can put the new cardiac surgery book with the QR code. You have another monitor at the side watching the video. So we all don't want to be caught in this situation because it is extremely stressful and it is not fair for the patient. So what do we have today? We have to negotiate the learning curve. So before we get to talk about training, we need to talk about the learning curve. Every skill that we learn, everything that we do has a learning curve. And in cardiac surgery, unfortunately, the learning curve is very steep. So repetition, do we do it through mistakes? If we do it through mistakes, how many patients have to die before you get there? From zero to hero, or you won't even make hero, you'll just die at zero. So next thing, training. Training in the modern day emphasizes on three tenets: safety, progress, and innovation. We have to do training safely. We have to progress so that our young surgeons progress to become good surgeons. And we have to continuously innovate, like what the Prof. Kikuchi said. You want to invent new techniques, and we need to continuously innovate so that our specialty can always improve. And we need to also have collaborative sessions like that so that we share and learn from each other. So this shows the stages of learning. Stage 1 to stage 4 in a cycle. Stage 1 is unconscious incompetence, where confidence exceeds ability. I'm the hero, I can do it, I'm Rainbow, let's do it. There's minimal experience, minimal skill, and you are not aware of what you don't know. So that's the most dangerous stage. Stage 2 is where you know a little bit, is conscious incompetence. You are aware of what you cannot do. You are aware that you have limited ability. You are aware that you need to call your boss to cover you when you do a difficult case. And that's where confidence drops. It is in this stage where it is important to try to keep the confidence at a higher level for the trainees. So to progress from stage 2 to stage 3, how do we bring the confidence up? How do we bring the ability up? And through this process, we achieve learning. And then from stage 3 to stage 4 is continuously practicing the good techniques that you have acquired from teaching, from simulation, from training, so that you can peak in your confidence, you can peak in ability. And once you peak in these two areas, it becomes natural. And when it's natural, it becomes a habit where you can do with your eyes closed. Okay, not with your eyes closed, but maybe at 4 a.m. in the morning, like what Dr. Aventura does. So this is Bruce Lee, everybody knows. So he fears not the man who has practiced 10,000 kicks once, but he fears the man who has practiced one kick 10,000 times. So he emphasized on training, training, and training. But when he trains, he doesn't go around beating people. He trains on his wooden enemy. And for us, I think we need to practice 10,000 kicks 10,000 times. So where do we get that? Do we get so many patients to practice on? Do we get so many cadavers to practice on? Unfortunately, no. And we look at all these industries, airline industry, pilots. Do they drive a plane for the first time? No, they have simulators. We look at skydivers. Are you going to go skydiving for the first time? No, you practice in a simulator first. Unless you are doing tandem dive with another instructor, then that's a different thing. Then special forces, do they go hostage rescue the first time? So many things can happen when they go for the first time. So they practice in a kill house. They practice 10,000 times. And even before they go for an actual mission, like for example, if there's a hijack, they actually practice in a simulated aircraft before they actually go for the real action. So what makes us different? Nothing makes us different from them. We are all in high stakes situation. And high stakes, not just not our lives, but people's lives, someone's husband, brother, son, mother, father, you know. So that's why my ex-boss decided that we need a simulation center, one in the region, to try to train cardiothoracic surgeons. And with the kind donation of one of his patients, we managed to set this up. And we did an opening last year. Process actually began in 2017, 2018, when I was a junior consultant. And he actually approached me saying that one of the patients donated money and it's time we use this for education. And he actually said it's time to go shopping. So we went to shop for simulators. So we went to shop for them online. We went down to look at them. We read reviews and we tried out ourselves to see how they are. And then the pandemic hit. So over 3 years, we managed to acquire the equipment, but the actual fruition of the simulation center only took place last year. No, the year before, 2023, where we officially launched it. So the next few slides will show some of the simulators that we have. So these are the conventional CABG off-pump simulators. On the inside of the cage, there's actually a mounting platform where we can mount fixed heart on it and we can let residents practice. And on the right side is the beat simulator developed in Japan, to practice off-pump surgery. Next, we also have dry lab for minimally invasive mitral. On the left is the Maastricht simulator, which we bought from the Netherlands. And this is actually a very smart system where on the inside, there's actually a camera that shows all your sutures around the mitral valve. And after each suture is being taken, the computer will assess how deep and how wide your stitches are, and they'll give you a score. So at the end of the day, after putting all the annular sutures around, the system will score you and you will have a timing as well as a score. And based on that, your boss can actually decide whether or not to let you operate on a real patient. So we have a couple of that. And on the right side is one of the newer simulators that we actually acquired. It's a totally 3D printed model, and the signature of it is smaller. It is modular so that it can be packed in a suitcase and we can bring it overseas for workshops. So we actually brought it to Busan in ASCVTS 2 years ago for the workshop. So Dr. Payman has developed the Maastricht simulator, and he has also come up with this suturing map for endoscopic mitral valve repair, developed on that high fidelity endoscopic simulator that I showed you about. And this is actually a very good guide on how to do it and what some of the fellows and residents in my center will practice on the simulator and get them to score you. It becomes a mini competition. So this is where we progress to the wet lab after the dry lab, where we talk about setup, we mount pig hearts inside, we do the actual annuloplasty sutures on the pig heart. Because in this situation, you will not be able to score. You will not know how deep, how wide your sutures are. It is not to test that aspect, because that aspect is addressed in the dry lab. This wet lab is actually to give you a feel of stitching on real tissues using shafted instruments in a highly simulated environment and controlled environment. So through the dry lab and the wet lab, we actually achieve different objectives. And you can see core knot here, where we can practice the usage of core knot on the right. So this wet lab is also a team-based workshop where we actually encourage surgeons to bring their assistants so that they can train together using knot pusher, using the core knot, and train on exposure of the mitral valve. And then mixed CABG, we also have a simulated torso and the root track as well as the thorax track in order to simulate taking of the IMA. On the inside of this model is actually a replaceable IMA. It's actually a heart down there with the pericardium intact, where you can actually practice using long shafted instruments. Because I think for cardiac surgeons, all of us grew up with sternotomies. In order to transit from sternotomy to MIS, one of the challenges is using long shafted instruments. Because the general surgical boys, they do both during their training years. But in cardiac surgery, most of the trainees, most of the residents will do mainly open cases, and only a small group will actually progress to MIS. And to make that jump, it's very important to practice on long shafted instruments. So workshop structure usually consists of practical lectures, followed by live in a box video presentations, followed by dry lab and wet lab, in order to get a feel of how it's like, and then to progress to doing it in your own country with proctorship, and then thereafter being independent after having done cases under proctorship. Yep. Thank you very much.
Shang, so any questions for Doctor?
Yes,
Yeah, Dr. Francis. Sorry, Dr. Francis. Yeah.
Okay. A very good lecture. Funny as well as very informative. A question about for your first lecture. Do you have a threshold of doing all this either cardiac MRIs or PET for actually trying to find out if you need to or not, like EF might be how low and stuff. So what would be your trigger to request for such tests?
So I think firstly, firstly, we divide them into the acute patients and the elective patients. So for the elective patients, my threshold is LVEF of 30% and lesser. Yeah, 30%, less than 30%. So less than 30%, I'll do a MIBI scan. I'll do a nuclear imaging because I think that's the most accessible for us and it costs the lowest for the patients. Then if the nuclear imaging, the MIBI scan, shows that it is not viable, I will look at the coronary targets and I'll look at the patient. If he belongs to a low-risk patient with good coronary targets, I will take the MIBI scan with a pinch of salt because it may not be the most accurate scan, especially in the acute phases in a few weeks after an AMI. So then if the patient doesn't need surgery so soon, I would actually schedule him for a cardiac MRI to further assess. Yeah. And then based on the cardiac MRI findings, I will look at the location of the targets, the location of the stenosis to correlate with the areas that are viable or not viable and make a decision from there. If it's patients who require urgent CABG, then I think viability is a little bit hard to assess. I'll go by echo. So if the echo shows that the walls are still moving, the echo shows that wall thickness is preserved, there's no aneurysm, there's no akinesia, then I'll be inclined to believe that is more viable. And the EF of less than 30% is actually a result of an acute event. Thank you for the question.
Thank you. Dr. Francis?
Yeah, also for your first talk. Well, you mentioned 4 modalities. We talked about 2 with Dr. Ventura's question. You said you usually make use of the nuclear imaging and the cardiac MRI. How about the others? Your PET scan or your SPECT. When do you use them?
Okay, so SPECT will be the nuclear imaging. I don't really use the stress echo because they already had an event and they have documented stenosis. So myself, I don't feel safe putting them through stress if there's a good alternative. So my alternative is MRI over PET because I think MRI also give other more useful information such as the volume, how big are the chambers, as well as the degree of mitral regurgitation, which usually is present in these patients with poor EF. So I think one scan will actually give a lot more information.
Sorry, just to go on that. Is there any instance that you would request for a PET scan in any clinical scenario that comes to mind that you would request?
Actually, the MRI has been pretty good in guiding my clinical decision. In fact, there was one case I remember. Patient has severe ischemic MR on the echo with the EF of 20% with doubtful viability on MIBI scan. So I went on to do an MRI, and the MRI actually showed that there is viable myocardium in the territories that I can graft. And in addition, it also showed that the papillary muscle fibrosis is pretty severe. So in that instance, I actually decided to change the mitral valve rather than put in an annuloplasty ring. Yeah.
Okay, Dr. Royce?
Just to follow on with the MRI, if you saw quite substantial scar, but some say epicardial muscle, perhaps, what are the triggers? What are the measurements you would say that there's too much scar here to warrant any intervention, or would you go ahead anyway, no matter what? What's the limits of what you find that would make you change your mind?
I think if there's significant amount of scarring, especially in areas where the coronary targets are not the best, then I would turn them down for CABG. Yeah.
Okay, any more questions?
I just wanted to say that this is a very controversial area that, as you said, our cardiology colleagues don't believe in it anymore. And when they send you a patient that you know that with an ejection fraction of 20%, and you know that that patient may not get off the table, and you have to use balloon or you have to use Impella or ECMO, they don't get that because they just cannot relate to that. But I think this is a very, very important point because a dead myocardium is going to stay dead.
Exactly.
No matter what you do to it. So it's very, it's going to be important for us in the future to do that. So what you brought up, and I'm looking forward to discussions tomorrow.
Yeah, it'll be quite exciting tomorrow. and my favorite reply to the cardiologist is, before we talk about long-term outcome, I need short-term survival.
Dr. Yam?
Yes. With regards to your second lecture, uh, the Heart Center, the Philippine Heart Center, is embarking on a 3D printing program for preoperative planning. I was just wondering if you're able to simulate dynamic mitral valve motion for repair in those 3D printed models.
Okay, I think the models that we have acquired from the metric company, some of them have the pathology, but we still cannot simulate the dynamic movement, like the testing and all that. Unfortunately, we can't simulate that. I'm actually in talks with our own 3D printing department and company to actually see how we can improvise on that. Yeah. Yeah, but that's a very good idea because we want to simulate it as real as possible, as high fidelity as possible, but there are definitely still gaps that we can improve on.
Thank you.
Welcome.
Thank you. Any more questions? If there are none, we'd like to thank Dr. Chang for his lectures today. Let's give him one round of applause. Yeah, so with that, that wraps up our first day. We'd like to thank everyone in attendance, and we'd like to see you tomorrow. So a little overview for tomorrow. For the morning session, we'll have two cases, like a panel discussion up front with all our esteemed colleagues. So the morning session will be what we do in coronary patients with heart failure, and another scenario wherein we have what we do in coronary patients with ischemic MR. In the afternoon, we'll have a panel discussion with three interesting cases to be presented, and a robotic surgical system simulation. With that, thank you very much, and we'll see you all tomorrow.
Just asking if you're